Let us start with our first participant. I would like to welcome Badam Sheetal Reddy on the stage. So everybody will be given 6 minutes for the presentation and 2 minutes for discussion. I would like to invite the judges on the stage, please.
Hello. Good morning, everyone. I would be presenting my paper of a study of analyzing the relationship between internet use and feelings of loneliness in medical students of a medical college in northern Telangana. So, coming to loneliness, human brains are designed to seek out attachment when they feel isolated or threatened, and to be reciprocally be moved by the pain and loneliness of those who reach out to us. The loneliness is a subjective psychological feeling or experience in which an individual lacks satisfactory interpersonal relationships due to a gap between their desired social interaction and the actual level. Those with loneliness cope in different ways. Some use positive methods leading to healthy lifestyles or may resort to negative strategies like substance use, risking addiction or depression. Coming to internet addiction. Internet addiction was first proposed by Goldberg in 1995, where he described internet addiction as a coping mechanism which is a way of relieving stress and is characterized by excessive internet use. Internet addiction is not recognized as a disorder by the World Health Organization, the Diagnostic and Statistical Manual, that is DSM-5, or the International Classification of Diseases ICD-11. This study analyzed the relationship between internet use and feelings of loneliness in medical students of a medical college in northern Telangana. Now coming to the methodology, the study design is an institution-based cross-sectional descriptive study with a survey research design. The sampling method is done through convenience sampling with a sample size of 354 participants. The study period was conducted using a self-structured questionnaire distributed as Google Forms through a social network from August to September in 2024. Study setting is Pratima Institute of Medical Sciences, Karimnagar, Telangana. And coming to the participants, the inclusion criteria is students aged between 18 to 42 years and students doing their undergraduate and postgraduate degree in a medical college. The exclusion criteria would be students who are not willing to participate in the study. The tools and scales I've used here are the Internet Addiction Test and University of California Los Angeles Loneliness Scale version 3, which assessed internet use and loneliness severity respectively. Coming to the statistical analysis, the values have been expressed as mean, frequency, and percentages. The data was compiled in the Microsoft Excel 2017 and analyzed using the SPSS 29 version. Descriptive and inferential statistical analysis were used in the current study, and p-value less than 0.05 is considered as significant. Coming to the age of the participants. In loneliness scores, there is statistically significant difference between the age groups with p-value of 0.04, suggesting that the age influences the scores within this group. The mean decreases significantly from the younger, that is 18 to 24 years, to older age groups. In the internet addiction, the p-value of 0.434 indicates that there is no statistically significant difference between the age groups, although the mean score still shows some variability across the ages. Now coming to the gender of the subjects, that is female participants being 65.3% and male participants being 34.7%. In this loneliness graph, the mean for males and females are very close, and the p-value of 0.6 indicates that there is no significant difference between the genders in this group, whereas in the internet addiction graph, the mean for males, that is 36.33, is higher than females, and the p-value of 0.017 indicates a statistically significant difference between the genders. Coming to the domicile of the subjects. For loneliness scores, the p-value of 0.05 indicates a marginally significant difference between the location types. The semi-urban group has the highest mean, while rural has the lowest. This suggests that living in different location types might have a slight influence on loneliness scores, with semi-urban individuals scoring higher on average. For internet addiction scores, the p-value of 0.301 indicates that no statistically significant differences in scores between the different location types, suggesting that location doesn't have a major impact on the internet addiction scores. Now coming to the year of graduation of the subjects. Loneliness scores show statistically significant differences across medical education levels, with first MBBS students scoring the highest on the average, while the second year students have lowest average score. Internet addiction scores do not show significant differences across educational levels, suggesting that these scores are relatively consistent regardless of the year. Coming to the socio-economic status of the subject, for both loneliness and internet addiction scores, there are no statistically significant differences across the socio-economic groups as indicated by the high p values, that is 0.343 for loneliness and 0.141 for the internet addiction. Now coming to the marital status of the subjects, for both loneliness and internet addiction scores, there are no statistically significant differences between marital groups, with p values being 0.236 for loneliness and 0.907 for internet addiction. Coming to the type of family of the subjects, for both loneliness and internet addiction scores, there are no statistically significant differences between the different family structures, with p values 0.587 for loneliness and 794 for internet addiction. Now this is the predominant purpose of internet use, and this is the severity of internet usage. And this is the severity of internet usage correlated with the loneliness. And this is the table which represents the correlation between loneliness and internet addiction using Pearson's correlation coefficient with 0.8278, which indicates a positive correlation between loneliness and internet addiction. While the correlation is not very strong, it is moderate, suggesting that loneliness scores increases while internet addiction scores also tend to increase, and vice versa. Now you can see the significance of two-tailed being 0.0001, meaning the correlation is statistically significant at the 0.01 level. This implies that the relationship between loneliness and internet addiction is not due to a random chance, and there is a moderate positive relationship between the two. Coming.
You have taken rural, urban, semi-urban, right?
Yes, sir.
So it's place of their origin.
Yes, sir.
But you are actually testing the internet addiction and loneliness now.
Yes, sir.
All of them are urban.
Not all of them are urban, sir. Some are semi-urban, some are rural, and some are.
Everybody is in Pratima Medical College.
Yes,
Pratima
sir.
Medical College is in Karimnagar, which is urban.
Yes, sir.
Everybody is urban.
But for
they
the
might have come from rural background. They might have come from semi-urban background.
Yes, sir.
Internet addiction did not start then. Loneliness did not start then.
No, sir.
Loneliness started now. Internet addiction started now. So everybody is actually urban population. No?
Yes, sir. Technically, yes, sir. But I have correlated with the origin because most of the students here are, if let's consider the fourth year MBBS students, the students are here for the past 4 years. But before that, they have been from the origin, sir. So that's why I have considered the origin source, sir. But in future recommendations, I will definitely add the current location as well, sir.
Location wouldn't probably matter, did not matter in your study because everybody was in the same. Probably that is the reason why the first year residents had, first year MBBS students had more loneliness because they have come from their homes.
Yes, sir.
So that's why they are lonely. By second year, it dips. The lowest loneliness is in second year because everybody is settled down.
Yes, sir.
Right. So it actually doesn't matter where they come from.
Yes.
Whether they are urban or rural, they have moved away from their home, that would actually matter. If you had actually studied how many of them are localites, PGs or even undergraduates, how many are localites versus how many of them are staying in hostel, and how loneliness. Am I audible to everybody? I'll not require mic, most likely. So if you had actually taken hostel versus people who are localites, that would have made more difference because we would know whether people who are in hostel are more lonely. In your, the second observation is that in your marital status, 94% of them are single because most of them are MBBS graduates. It would have been interesting to see how many of them are in a relationship and whether that leads to loneliness and internet addiction or not.
Yes.
Did you ever have a chance to see whether it was there?
So there's a question in loneliness that whether you feel lonely when you are with partner, but many of them answered otherwise, sir. So I haven't included the data in the.
Was it mentioned to them that it is anonymized?
Yes, sir. It was anonymous. Yes, sir. It was mentioned when I was.
But you
participating.
would know.
Yes, sir. I would know.
So nobody would tell you the right answer.
Probably, sir.
That's it from my side.
What was the study hypothesis?
Sir, the hypothesis is to determine the loneliness, sir.
No,
Loneliness and
what did you hypothesize before designing this study? Or
yes. So actually, I wanted to see since there's social media use is significant in these times. I wanted to see whether there is any correlationship between the loneliness and the use of internet, sir. And I wanted to use specifically loneliness because there are many other factors as well for loneliness. But I wanted to measure, as we use most of the times our social media or our phone, internet use. I wanted to see whether this makes a significant impact or not.
okay, so because having a clear hypothesis is important to design a study, which one do you think in your study is an independent variable and which one is a dependent variable?
Sir, I would determine that age is a dependent.
No, like out of these two.
Okay. Out of these two, I would suggest that loneliness is a dependent variable, whereas
Which affects the internet addiction,
yes,
isn't
sir.
it? So your hypothesis would be the people who are more lonely might have more internet addiction than those who don't feel lonely.
Yes,
So
sir.
having that hypothesis gives you some clarity as to how to go about with the data collection and analysis.
Yes, sir.
What is your simple English summary of your study?
Sir, simple English survivability. Since the statistically proven that there's a moderate relationship that whenever the loneliness increases, there's an increase in usage of internet. So I would conclude that with the increase of loneliness, people might turn to social media or internet more.
Pearson's correlation was 0.23 something.
Yes, sir.
Would you call
0.27.
it as moderate association?
Mild to moderate, sir.
It's mild, I think,
Mhm.
less than 0.3. So it's mild, though it is statistically significant. What would be the limitations of your study?
So the number of participants, sir, and
354. How did you, yeah, and by the way, how did you reach that sample size?
well, sir, out of 1200.
No, I mean, you had any a priori, sample size calculation?
Yes, sir.
Like on what basis?
I've done through a convenience sampling, and I've used the formula that out of 1200 participants, how much would be the minimum requirement, which I got that 300 would be the minimum requirement, through which I have.
So then you cannot say sample size.
Okay, sir. Yes, sir.
Anyway, I think we can. Yeah. So just one suggestion, probably you spend too much time in describing socio-demographic variables which are not your primary objective. You could have directly jumped to association or correlation between, which is your objective, isn't
Yes,
it?
sir.
So then would have gone for discussion and other things. So,
Yes,
so idea is to be focused as to what you want to do rather than analyzing every variable you have. So that will, one thing is dilute the study and leads to a lot of alpha errors, type 1 errors. So to be specific what you want to assess.
Yes, sir.
Thank you.
Thank you, sir.
Thank you so much, Sheetal. Next up, I would like to invite Kanmani onto the stage. One second. It's not. Should I start? 5 minutes. No, buzzer will go at 5 minutes. No, ma'am, 6 minutes. No, buzzer will go off and then you have 1 minute. Okay, can I start?
Good morning, everyone. I am Dr. Kanmani, second year postgraduate from Government Mohan Kumar Mangalam Medical College, Salem. My pre-paper is on serum uric acid levels in drug-naive patients with bipolar disorder during different phases of illness, a prospective case control study. On the background, in bipolar disorder, an increased purinergic metabolism and altered reduced adenosine activity has been proposed to be pathogenic. Adenosine, a nucleoside, together with ATP, appears to regulate multiple second messenger systems, energy homeostasis, dopaminergic and glutamatergic neurotransmissions, thus influencing sleep, cognition, and behaviors. Hence, uric acid, a nitrogenous end product of purinergic metabolism, is elevated in bipolar disorder, particularly during the manic phase. Aim and objectives: to compare the serum uric acid levels among drug-naive first episode manic patients and age and gender matched healthy controls twice at an interval of 4 weeks to correlate the serum uric acid levels with the severity of illness. The study was conducted at the Department of Psychiatry at Mohan Kumaramanglam Medical College Hospital, Salem. The duration of study was 1 year. Sample size: cases 30 and controls 30. A prospective case control study. Non-random convenience sampling was chosen, and the results were analyzed using the SPSS software. Ethical committee approval was obtained at the Institutional Ethical Committee of GMKMC at Salem. Written informed consent was obtained from all participants, including both cases and controls. Nil conflict of interest and nil financial support. The inclusion criteria: age between 18 to 65 years, patients diagnosed with bipolar 1 disorder as per the ICD-11 criteria and who are drug naive, patients who are willing to participate in the study. Exclusion criteria being age less than 18 years or more than 65 years, patients with comorbid medical illnesses like diabetes, hypertension, rheumatoid arthritis or gout, patients with other psychiatric illness, patients on drugs like steroids, beta blockers or substance use, and patients who are not willing to participate. The tools used are semi-structured performer for assessing socio-demographic profile. Cases were diagnosed using ICD-11 criteria for mania. Young Mania Rating Scale was used to assess the manic symptoms at the initiation of treatment and at the end of 4 weeks. Control group comprised of age and sex-matched individuals were administered Mini 6.00 questionnaire to screen for any psychiatric disorder. In this prospective study, 30 patients with drug-naive first episode manic episodes were included. Serum uric acid levels of manic patients were assessed during the acute phase at the baseline and at 4 weeks after initiation of treatment, which were compared with the age and gender matched 30 healthy controls. Moving on to the results, Group A is drug-naive first episode manic patients, Group B being the healthy controls. The age distribution in Group A and Group B were comparable. The gender distribution was equal and similar in both the groups. Moving on to the education level was up to primary level for 17 subjects in Group A and 19 in Group B. Both the groups were comparable. Moving on to the occupation, majority of the subjects were unskilled in both the groups, 25 in Group A and 28 in Group B. Socioeconomic status, almost all of them were from upper lower socioeconomic status. Marital status was comparable between both the groups. Coming to the family history, among Group A, that is drug-naive first episode bipolar patients, only 2 patients had a positive family history. Moving on to the serum uric acid levels, in Group A, the mean serum uric acid levels at baseline was 5.42 milligram per deciliter, which reduced to 5.06 milligram per deciliter after a period of 4 weeks. One-way ANOVA was applied, which shows statistically that the p-value is statistically highly significant. Moving on to Group B, the serum uric acid levels at baseline was 4.72 milligram per deciliter, which remained unchanged at 4.76 milligram per deciliter after 4 weeks. The two groups differ in the mean uric acid levels. Moving on to the YMRS scores, in Group A, the mean YMRS score as baseline was 24.50 and after 4 weeks it was reduced to 4.83, which is statistically highly significant. In Group B, the YMRS scores remained the same after 4 weeks also. The Pearson correlation test was applied, which showed a strong positive correlation between serum uric acid levels and YMRS scores, which was statistically highly significant. Discussion: the serum uric acid levels of manic group showed a significant decline after 4 weeks of treatment initiation. In drug-naive first episode manic patients, the serum uric acid levels was at admission was 5.42 milligram per deciliter, which decreased to 5.06 milligram per deciliter after 4 weeks. In control group, during the first contact, mean serum uric acid levels was 4.72 milligram per deciliter, and after 4 weeks it remained unchanged at 4.76 milligram per deciliter. So there was no significant change in uric acid levels of control group after 4 weeks. Mean uric acid levels in the case group at admission was significantly higher than that in the control group at the first point of contact. A positive correlation was observed between serum uric acid levels and symptom severity in manic patients. Limitations of my study: the sample size was relatively small. Parameters such as serum creatinine levels, cholesterol, glycemic status, and body mass index werein considered, all of which could have potentially influenced the relationship between uric acid and mania. Including bipolar patients during their depressive or asymptomatic phases, it's necessary to clarify the state versus trait relationship between uric acid and disease variables. Longitudinal studies with multiple measurements in different phases of illness in the same patient are strongly recommended. Conclusion: patients with first episode bipolar disorder had high levels of serum uric acid which responds to treatment. Positive correlation was observed between serum uric acid levels and the severity of manic symptoms. The results of the study support a purinergic system dysfunction hypothesis in first episode mania. These are my references. Thank you, sir.
Why did you rule out comorbid diabetes and hypertension? Gout I can understand.
Yes, sir. And even the diabetes, hypertension, and all can influence the metabolic changes, sir. Can amount to the uric acid dysfunction.
To the extent that it
Yes, sir.
clinically becomes meaningful? Okay, anyway, theoretically,
Yes,
that's
sir.
okay. Why did you apply ANOVA? Can you just go back to that your result study where you have compared baseline and end serum uric acid levels?
Yeah, sir.
Why did you apply ANOVA? Because there is only two groups, no? Baseline and end. Because you are giving separate p-values for both the groups. Case group you have separate p-value and control group you have separate. That means there are only two groups, pre and post. How can you apply ANOVA here? Ideally, what test needs to be applied here in this condition?
Fisher exact t-test.
No, I mean it's a continuous variable. So where you are comparing one continuous variable in same group, pre and post. So what kind of test is usually applied here? So student t-test and paired.
Yes, sir.
Paired
Paired
student
t-test,
t-test,
yes.
isn't it? So I don't know why you mentioned ANOVA there. And you said your p-value is 0.91, Pearson's R value. What was that? Just can you show that? Yeah, it's Pearson's correlation R. You mean to say 0.901? That 0.901 you have written, no? That's Pearson R value. It looks like, isn't it?
Yes, sir.
So it's extremely rare to get an R value of more than 0.8 in real life settings. So 0.901 is very surprising, that too with a small sample size of 30. So you need to relook into your
Yes,
statistical analysis. Even if you go back to the previous slide where you have shown your p-value, I mean, if you can go back, like if you can see, your uric acid levels have marginally come down from 5.46 to 5.06. With sample size of 30, whether it becomes statistically significant is a question. So it can be, but I have little concern here. You can relook into
Yes,
your
sir.
stats
Sure,
again. Is it technically a case control study? Because you have written a prospective case control study.
Yes, sir.
So technically case control study is where you go from the impact or effect to
Outcome
cause,
to the
isn't it? So it's not that you have taken those who are like here you are hypothesizing that uric acid is an etiological factor for bipolar, isn't it? So then bipolar and it looks like bipolar and non-bipolar, and you have gone into fine. But why did you look into uric acid levels after 4 weeks in normal controls? What was the need?
Sir, just to demonstrate, there is no significant difference.
No, but what do you think? After 4 weeks, a normal person's uric acid will come down without any reason?
No, sir.
Then it was unnecessary,
Yes, sir.
isn't it? Baseline, I can understand. You want to show that in healthy controls to differentiate it from the bipolar disorder. But repeating after 4 weeks, even in controls, was not necessarily unnecessary expenditures.
Okay.
By the way, who paid for these tests?
So no, sir. There is no financial support, sir. It was conducted in a government medical
No,
college.
I mean, whether patients paid from their pocket or
no, sir.
investigator
It
paid?
is completely free, sir.
Free. Okay,
Yes, sir.
fine. Thank you.
Continuing on that, whether for controls, where did you get the population from? Who are the controls?
Sir, controls are relatives of normal patient, I mean relatives of the patient, sir.
So for their test blood investigations also, because there is no file, there's nothing. So how did they get their blood tests done?
Sir, as a routine, we can do it for the study purpose, sir, after taking consent.
That's about the tests. The Mini 6 is also copyrighted.
Yes, sir.
It also involves money if you are using it for a study purpose. Who paid for Mini 6? You don't have financial support. Mini 6 was used. Sheehan would be very unhappy if he gets to know that people are using his tool just like that. What happened there?
Sir,
It's okay. For smaller studies, it's okay. You can write to them and get permission. Actually, without permission, it should not be used. Dr. Sheehan generally gives permission for smaller studies. For free of cost, it can be used,
yes,
but permission needs to be taken from him. What drugs were used in the patient population?
sir, lithium and sodium valproate, sir.
Even after giving lithium, the uric acid levels came down.
Yes, sir. It can have a ceiling effect on uric acid levels, sir.
That's interesting. In the population that you saw, many were from 28 were from upper socioeconomic status, only one from lower socioeconomic.
Sir,
Something like that.
most of them are from upper lower socioeconomic status, sir, according to modified Kupasamy score.
Yeah. So, but there was no statistical significance in that.
No, sir.
There again, I have doubts regarding the statistical analysis, because see, with 5.42 and 5.06, it can pick up something. 28 and 1, it doesn't pick up anything. It beats logic.
Sir, that was compared between group A and group B, sir.
Okay.
Sir.
You can project that slide.
Okay. It's between group A and group B.
Yes, sir.
Okay. And did you ever tried using student t-test?
No, sir, I didn't.
My doubt was that you have tried using. I'm not accusing you.
Yes,
This is what generally happens. My doubt was that when I listened that you have tried using it, nothing came up. So any other statistic, will it actually give something? So ANOVA gave you 0.001 or 0.005. So you used okay. This is. Did it happen?
Having more than 2 groups, you cannot apply only.
Yes. Yeah, this is like simply like that. It something came up. All the tests. Okay, this also I'll do. This also I'll do. This also I'll do. So it came up. So whichever came up, I'll put that in my study. Did it happen like that?
She must have given to some statistician.
So they might also have done that. Because in our statistics class, we have a saying. Dr. Jagdisha says this, that if you torture the data enough, it will confess. So did that happen? Is my doubt. You don't.
You can give it to statistician, but you should also know if he goes wrong. Like you should also know to correct it. Then only you give it. You need not just surrender yourself to statistician, and because they don't know the clinical aspects.
Okay.
So you should know the tests, and if they go wrong, you should tell no. I want it this way. I want this test to be applied. So you should have it.
Thank you.
Thank you, sir.
Thank you so much, Kanmani. Next up, we have Viveka.
Shall I start?
Good morning, sir. I'm Dr. Vivek Priya, second year postgraduate from Government Salem Medical College. My study is assessment of personality traits, stressful life events, coping strategies in patients with central serous chorioretinopathy. Regarding introduction, CSCR is a chorioretinal disease in which there is a damage to the retinal pigment epithelium, and that induces the subretinal serous fluid accumulation and detachment of neuroretina. It is common among young and middle-aged people. In most cases, there is a spontaneous resolution occurs within 3 to 4 months, but recurrence is common. In some cases, it may persist for longer duration. There are various etiology for CSCR. In addition, the impact of psychological risk factors such as stress and type A personality may also predispose to CSCR. The characteristics of type A personality includes competitive drive, a sense of urgency, an aggressive nature, and a hostile temperament. They have reduced tolerance to frustration, emotional instability, and insecurity. Likewise, CSCR patients reported more critical life events, and they may use adaptive as well as maladaptive coping skills. Aims and objectives to assess the personality traits in patient with CSCR, to assess the stressful life events and coping strategies in patient with CSCR. Regarding methodology, my study is conducted on Department of Ophthalmology, Government Salem Medical College. After obtaining ethical committee approval, the duration of study is 1 year with sample size of 30 cases, all convenient non-random sampling. It is a cross-sectional study. Written informed consent was obtained from all the patients. Inclusion criteria included age between 18 to 45 years, irrespective of gender. The patients with acute, that is within 2 weeks, or chronic central serous retinopathy, confirmed by fundoscopy, optical coherence tomography, and fundus fluorescent angiography. Exclusion criteria: age less than 18 years and more than 45 years, patient with history of any macular disease or any other ocular disease, with a history of any surgical or laser procedures on eye. Data collection tools and methods. 30 patients with CSCR were chosen, and the socio-demographic profiles were collected, and the personality were assessed using International Personality Item Pool 5-factor model, that is IPAP Big 5, and the stress levels were measured using Social Readjustment Rating Scale, while the coping strategies were evaluated using Brief Coping Scale. Regarding IPAP Big 5, it is a Big 5 personality trait framework which includes conscientiousness, extraversion, agreeableness, neuroticism, and intellect. It's a 50-item questionnaire rated using 5-point Likert scale, usually done within 3 to 8 minutes. Social Readjustment Rating Scale. It is used to assess the level of risk for the stress-related illness and is classified as low, moderate, and high level of risk. Brief Coping Scale. It measures various coping strategies that people use in stressful situations, that includes both adaptive as well as maladaptive strategies, that comprises 28 questionnaires with 14 coping strategies. Regarding results, in my study, most of the patients are between age 18 to 45 years, of equal proportion of male and female gender. Most of them are educated, employed, married, and belonging to middle social economic status. An assessment of personality traits reveals most of them belong to neuroticism, that is 60%, followed by conscientiousness 20%, intellect 10%, extraversion 6%, and agreeableness 3%. Assessment of level of risk for stress-related illness shows most of them have moderate level of risk, that is about 50%, followed by high level of risk 16%, and for low level of risk for 33%. Coping strategies. Most patients out of 14 coping strategies use active coping and positive reframing as the most important coping strategy, that both of them are adaptive coping rather than a maladaptive coping. Correlation of personality traits and stress-related illness source. Neuroticism patients have high and moderate level of risk compared to other personality traits, which is statistically significant with p-value of 0.10. The results have been already discussed. Discussion. In this study, we found that patients with CSCR exhibited primary characteristics such as emotional instability, a trait linked to neuroticism. This reflects a basic feature of type A personality, which is similar to other studies such as Yanouzi et al. And Safan et al. In our study, moderate level of stress was detected in CSCR patient, which is consistent with Conrad et al., who reported CSCR patients are more vulnerable to stress. Analysis of coping styles showed that our participants use adaptive coping, such as active coping and positive reframing. Limitation, the sample size was too small. As this study is confined to hospital setting, generalizability is uncertain. As it is a cross-sectional study, causal link between personality trait and CSCR cannot be done. Omission of comorbidity is a major limitation in my study. Conclusion, a higher level of perceived stress is a primary psychological risk factor for CSCR. Since type A personality trait can exacerbate the stress and elevate the risk for CSCR, implementing stress management skills would be beneficial in mitigating this risk and future recurrence. Hence, it is important for healthcare providers to address both the physical and emotional needs for this patient. These are my references. Thank you, sir.
So there was high neuroticism in your cases, and they also employed positive coping mechanisms.
Yes, sir.
But your conclusion is that they should be trained in better coping mechanisms.
Sir, they are using better coping mechanisms, sir. In spite of that, we have to give stress management skills.
They're
So
already
that future
coping
recurrence. In my study, compared to other studies, most of them use maladaptive coping skills, sir. But in my study, they used adaptive coping skills.
We will not talk about other studies.
Okay.
We'll talk about your study.
Okay,
In your
sir.
study, you found that people are using good coping mechanisms.
Yes, sir.
But your conclusion is that, okay, help them have a better coping mechanism. They're already using a good coping mechanism.
Okay, sir. Most of the patients are using active. In spite of that, other patients are also using maladaptive, sir. But my study shows significant adaptive coping as a major one, sir. So
Yeah,
early
that-
identification and treatment.
Again, the same thing.
Okay, sir.
So your data and your what is the result and the conclusion are not matching
Okay, sir.
in this. Because you're a mental health professional, I'll go and give stress management to everybody. It will not happen like that. If they are stressed, then you give stress management. If they are not using good coping mechanisms, then you do that.
So
But they are using, then why do you want to do that? In fact, there are I forgot the person who wrote that. There was actually one paper from I think USA where they tried actually teaching school children, UK or USA, school children about stress management and coping mechanisms for adolescents. In fact, they found that it has negative correlation. Means to say, the more you taught people about stress management, the more stressed they became.
okay.
Because they were not even having an idea of all these things can cause stress and this is the thing I should actually worry about. But giving that education actually made them more worry about their stuff. So if you're actually having you're also thinking it's a causal correlation, no?
Yes, sir.
That's what your conclusion says, that it is causal. If there is more stress, then there is more chorioretinopathy. And when there is a causal link that you are claiming to, then you teaching them stress management when there was no stress will increase stress and it will cause chorioretinopathy.
No, sir. Actually, they have stress, a moderate level of stress. I have mentioned, sir. But their coping is adaptive coping, sir. That's it, sir. But they have stress. In
But
the past
you're
1 years.
telling people that, see, what you're using is not correct. I will teach you better way.
Yes. No, sir.
And how did you conclude that it is causal? It may
No,
be correlated.
not a causal relationship, sir. As it is a
But,
cross section.
can you go to your conclusion? Higher level of perceived stress is the primary psychological risk factor for CSCR. That word is the psychological risk is causal.
Actually, as it is a cross-sectional study, we cannot find out the causal relationship, sir.
Yes. Then how could
Just
you?
to conclude,
How did you conclude that? Then?
just a discussion.
Is there anything?
I'm not aware of whether stress is hypothesized as one of the reasons for this retinopathy. Is there any such evidence or any research going on?
Yes, sir. Many studies have been conducted in CSCR and stress-related and type A personality traits, sir. In India also we have, there are
They
many
have
studies
some
are there.
etiological role or causative
Yes,
role
sir.
in causing.
Yes,
Okay,
sir.
fine. What was your hypothesis, madam, again in this case?
Sir, stress is the major factor for CSCR in some of the studies, sir. So, earlier identification for the triggering of the stress
No,
and
hypothesis means like how, what did you hypothesize? Like people with type A personality will have more, what was your hypothesis?
so people with type A have more stress, have poor stress coping skills, sir. They have they may be more competitive, frustration to intolerance. These are the characteristics of type A personality, sir. So CSCR
Can you
as a
project your objectives? Because you skipped the third objective. You didn't read the third objective. So the assess personality trait in patients with CSCR and assess stressful life events to assess coping strategies. Okay, did you assess stressful life events in them?
yes, sir. Using social readjustment rating skill I have used, sir. And
That
as
is the stress level you assessed, isn't
yes,
it?
sir.
But not the life events.
Life events, the scales included life events, sir.
Did you present that, the life event thing?
Life event I
Because
have concluded only the
no,
results,
objectives
sir.
are very important.
Okay,
Whatever
sir.
objective you have kept, that should be discussed
Okay, sir.
rather than discussing other issues.
Okay, sir.
Isn't it? Age and other issues are secondary. I mean, that is important, but
Okay, sir.
objectives, if you skip that, that is
Yes,
isn't
sir.
it? And to assess coping strategies in patients with central serous retinopathy. So if you look into your conclusion doesn't match with your objectives. Conclusion goes little beyond your objectives. It also try to go to the, correlate the etiological, So have clarity as to what is your objective, and your conclusion should also be in line with objective.
Okay.
Age, you have mentioned like 18 to 35, all of them were 18 to 35, fine, but it's always good to give a mean age.
Okay.
It's, see, when you it is like you are introducing your sample, your average patient or even ideal patient to the audience. My average patient was a 23-year-old male, if it was male preponderance in your sample. So saying that everybody was in 18 to 35 doesn't, because 18 to 20 it is different, 20 to 35
Okay.
the psychological issues are different, the challenges are different, coping strategies are different. You cannot club them in one bracket.
Okay, sir.
You said correlation when you applied chi-square test. So that's not correlation, that's just association. Correlation is different. Huh?
Okay, sir.
Yeah, this one. And high-low agreeableness, extroversion. Okay, and you said p-value 0.010. It's not statistically significant.
It's statistically significant, sir.
But you say it's
Less than
0.10. It's 0.1, isn't it? Less than
Less
0.05
than-
should have.
Less than 0.005, sir.
But it's 0.1, no? It's greater than 0.05.
Yes, sir.
Isn't it? It's not significant, and probably I don't know whether chi-square is this table, because there are some basic presumptions for chi-square.
Okay, sir.
So if you cannot, then you should apply for Fisher exact. Anyway, it's not significant. And as sir mentioned, the conclusion was far far-reaching than what you could in this study. So with only 30 sample size, you cannot conclude that stress has, as an etiological
sir.
factor for CSCR.
I mentioned it in a limitation, sir. Since in our setup only 30 cases I could pick up from the ophthalmology department.
Did you calculate the sample size?
No, sir. Just prevalence is 1%, sir. But in our setup, around 25 to 30 cases only per year it will be present, sir.
Okay, see, I mean, what I felt is you have taken three variables. One thing is CSCR, one thing is personality, one thing is coping, isn't it?
Yes, sir.
And you should have, probably you should have clarity as to like what you want to look for, what is your primary independent variable, secondary variable, and then go about with the statistical analysis. Otherwise it gets confusing and will lead nowhere.
Okay.
Yeah.
Thank you, sir.
Just for the people who are attending here and her sake also, there is a scale which can look at significant life events. It's called Holmes-Rahe scale. Okay, it has score till 100. So loss of a parent, loss of spouse, loss of children, divorce, in fact marriage also causes stress. So there is a list of items which can cause stress, and those life events can be taken into account? How much has it caused stress? That can be taken using that scale.
Just one, because all of them are postgraduates. Some common mistakes that all of us do, we did as PGs, you are also doing. When you say your inclusion criteria is 18 to 35, you need not say exclusion criteria is less than 18, more than 35, because that person does not get included itself. See, exclusion is after he meets inclusion criteria, and then you look for some exclusion criteria. So no need to repeat that. So this is one common mistake. And another mistake, probably it's not you, your guide also should think about it. So you randomly think of two variables and randomly select two rating scales and do a study and apply rating scale, and then it doesn't work like that. You should have a clear hypothesis as to what hypothesis I'm going to test. And then choose appropriately how are you going to measure that, quantify that, relate that. So having randomly two variables and applying, because if you, for any variable, you have 100 rating scales available. So have a clarity as to, maybe as you grow and when you become teacher, you can think like this.
Thank you, Viveka, and thank you so much, sir, for imparting this skill in a very crisp and time-bound manner. Next, I would like to invite S. Vikram.
Yes. Good morning, all. Myself is Dr. S. Vikram, postgraduate resident from the Gadag Institute of Medical Sciences. So I'll be presenting my study on the impact of the excess screen time on sleep among the preschool children in the urban population, which is a community-based cross-sectional study. So as per the NBEMS, preschoolers are the children who are attending the school between the 3 to 6 years. So as we're advancing towards the digital era, there is an increased use of the devices, for example, television or mobiles, so which leading to the exceedance of this recommended screen limits, and among 18% of the preschoolers, significantly compromising the sleep quality. And also some of the literature is suggesting that sleep disturbances impact 30 to 40% of the preschoolers' physical and mental health. So this study primarily investigates the screen time and sleep disturbances link in preschoolers, emphasizing the need for the healthy screen practices. So our aims of this study is to determine the prevalence of the screen time and sleep disturbances among preschool children, and to assess the association between the excess screen time and sleep disturbances among preschool children, and to assess the impact of the excess screen time on the sleep among the preschool children. So this is a community-based cross-sectional study involving the 1,870 preschool children who are studying in the preschools and also the Anganwadis from a Gadag Betagari urban population with a study duration of 4 months using the random sampling technique, with the inclusion of the children who are giving the assent and also the parents who are giving the consent, with the exclusion criteria including the children with intellectual disabilities and also the developmental delays. Institutional Ethical Committee approval was obtained. So tools used for the Indian Academy of the Pediatric Guidelines for the screen time. So children belonging to the preschool, that is 2 to 6 years, less than 1 hour, and National Sleep Foundation guidelines for the screen time less than 10 hours is considered as a disturbed. So data is analyzed, entered using the WHO EpiInfo 7.2 software and analyzed by the frequencies and percentages, and association between the variables was assessed using the chi-square test, and a p-value of the less than 0.05 was considered significant. So the results are showing that about 55% of this study population, including the 55% of the boys and also the 45% of the girls, and also the majority of them are belonging to the extended nuclear family, with the education of the mother belonging to the middle school certificate. So the prevalence of in our study, our prevalence of the screen time less than 1 hour is 22%, and more than 1 hour is the 78%, with the prevalence of disturbed sleep, that is the sleep disturbances, in around 16.31%, and the majority of them are using the mobile as a screen for more than 70%, followed by the television with the 26.3%. So this is the brief overview of the study. So the number of preschool children which we took is 1870, with the boys of 55%, girls 44%, with the children who are using the screen duration less than 10 hours and screen time more than 1 hour is the 240 children, which is found to be significant using the chi-square test. That is a p-value of 0.001. And most commonly it is impacts on the child's academic performance, followed by the daytime drowsiness and reduced physical activity and nighttime awakenings. So discussion in our study, we found that the around 16% and 21% of the preschool children are having the sleep disturbances and screen time more than 1 hour respectively. And our study also corroborates with the existing literature, that is the Bell et al. Findings with the association of the screen time and also sleep disturbances in the preschool children. So this study also shows that the girls have the increased risk compared to the boys in this study. And our study also replicates the Gare et al. Findings, that is the excess screen time is associated with the adverse outcomes such as the poor academic performance, drowsiness, and also physical activity and nighttime awakenings and the reduced social interaction. And certain limitations during the study, as it is a cross-sectional study and also can have the parent-reported recall bias and has no longitudinal follow-up. To conclude, our study finds that a significant association between the excess screen time and also the sleep among the preschool children. And also the study concludes that girls are at increased risk of sleep disturbances using the screen time more than 1 hour compared to the boys. And also excessive screen time in the children or the early childhood can increase the risk of the externalizing and also the internalizing behavior. This study adds to the existing literature regarding the monitored screen time can prevent the sleep disturbances, otherwise which can lead to the emotional and also the behavior problems at an early age group. So future directions. So longitudinal studies can be conducted for the causality and also the long-term effects. And in the future, studies can be conducted investigating the role of this blue light exposure, screen content, and also the limit timing of this screen content. And this study can add this strength to the existing guidelines and can able to develop evidence-based recommendations for teachers, parents, and also the healthcare professionals. So policymakers can consider some of the community-based programs promoting the health screen use and also sleep habits to strengthen our mental health infrastructure. These are my references. Thank you.
Yeah, the sample size is quite impressive. You said simple random sampling. How did you do? Can you explain how actually you did this simple random sampling and how did you choose your sample?
So actually we have screened over the number of 10 number of preschools and also 70 number of the Anganwadis, sir. So based on that we have selected the random Anganwadis and based on that only I have calculated the sample size, sir.
I mean, how did you like simple random? What we do, like every third child or every sixth child, you have a frame of sample and then, so how, because 1860 is a big number and you should have clarity, you should tell clearly as to how did you arrive at this number by simple random sampling.
Yes, sir. So in our, we have screened more than 10 preschools and also Anganwadis, sir. So in that school, we have excluded some of the children who are having the intellectual disabilities and also having the developmental delays, and also arriving at this sample size, sir.
No. You are not. The thing is, like, okay, you went to one Anganwadi. Let's say there are 50 students in that Anganwadi. How did you select? Out of that 50, how many, you selected, how did you select?
So it's based on all children we have selected.
Usually, did you actually randomize the Anganwadis or children?
That's the point.
It's, children.
Because such big sample, when somebody does, it's usually cluster randomization or block. You cannot do simple randomization for such big samples, community-based sample size. It's usually what we have seen is they do randomize these schools. So out of 20 schools, randomly 4 schools were picked, and in that 4 schools, all eligible children were screened. This is what usually is done. And simple random sampling with this huge number is little difficult. And 2 tools you have applied, isn't it?
Yes.
Can you just project about those tools? Are they validated for this age group, 3 to 6 years?
Yes, sir.
Okay.
These
good.
tools are validated.
How much time it takes to apply one tool?
So actually, these are guidelines, sir, which are given to the parents.
No, like if you want to apply this one tool,
Yes,
I mean
sir.
for one parent, one mother, how much time does it take?
So including the social profile and also the guidelines, it took me around 2 to 3 minutes per each children's.
2 to 3 minutes for total data collection, including this tool, these two tools.
Yes, the tools.
Like how many questionnaires are there in each tool?
So this for Indian academic, we have followed the guidelines, sir. So children who are
Achha, you
having
just
the,
asked,
yes,
like
the
how many
guidelines.
hours your child spends on.
It's like a cross-sectional, sir.
And you asked how many hours he or she sleep. That's what you asked.
Yes, sir.
You didn't apply any objective tool.
No, sir.
That's your limitation. You should just mention that.
This is my limitations.
Because one question cannot, reliably and validly, measure that. The validity of your measurement or reliability of your measurement depends on how reliable and valid the measurement tool you are using. So one question cannot justify that. So that's your limitation. Because I was wondering, because you have screened 1,800 children, and even if it takes 10 minutes for every mother, how much time you need to spend, and do you have that much time during your post-graduation, isn't it?
Yes.
So that is one limitation. And you said assent, 3 to 6 years assent is needed.
Assent.
Can they give assent?
Yes.
Okay, fine. And objectives, can you just go back to your objectives? Second is to assess the association between excess screen time and sleep disturbance, to assess the impact of excess and sleep. What is the difference between the second and third objective?
So first is the
Second and
whether
third. Second and third.
So whether there is an association whether the excess screen time can have the association with the sleep disturbances, and how this excess screen time impacting the child's daily lives.
Both are same, no?
Yes.
Both objectives are same, isn't it? And you said girls had higher risk of
Yes,
any
just
reason?
2%.
Any reason you can think of?
So from our study, it's
That's your finding, but is there
findings,
any
sir.
theoretical basis to believe that
No.
girls, it can be a random observation in your study,
Yes,
no?
random
Or is there any
observation.
similar data previously?
I didn't
That
find
girls
mention that.
who use more screen are more prone for sleep disturbance than boys?
No, sir.
Can you show me that stat where you got this? No, that statistical analysis where you got girls having more risk than boys. And this table, can you just go back to the table? What is that? That is duration of electrical device less than 10 hours. Less than, you mean less than 10 hours, okay. 10 to 13 hours, 13. Why did you make these divisions? On what basis you chose this categorization, less than 10, 10 to 13, 13 more
It's
than?
based on the guidelines, sir.
Acha.
According to guidelines only, it is this, sir.
But like anybody who uses half an hour and 9 hour are same in this first group. They are clubbed in one category, isn't it? It's a huge range. Like one child is using 15 minutes of mobile. One child is using 9 hours, 45 minutes of mobile. But they come in one category.
It's overall children who are using the more less than 1 hour per day, sir. More than one hour per day.
But this 10 hours is too much, I believe. If it is standard, that's fine, but it's little. And, acha, this is less than. Acha, that is sleep.
Sleep.
Horizontally sleep. Okay. Yeah. Sorry. Okay. Less than 1 hour, more than 1 hour. Okay. This is chi-square you applied.
Yes, sir.
Okay. 0.01. You could have just put the numbers instead of. Anyway, okay. Can you go to your conclusion?
Yes.
Our study findings. This third point you make, that excessive screen time in children and adolescents increase the risk of externalizing. From where is in your study you got this point, this finding?
So, because I would like to give the future direction, like the children who are having this excess screen time.
Like
with
in
sleep
your
disturbances.
study, did you got this particular finding?
No, sir.
You cannot tell anything which is not part of your study. You cannot.
Okay,
Your conclusion should be very precise. Only the salient findings you have got. That's it. You cannot give any general recommendations based on your study. That is usually not needed. So conclusion especially has to be rooted in your findings. Okay?
Yes, sir.
How was screen time measured?
So according to the Indian Academy of Pediatric Guidelines, the children who are children
No,
who
no, no. What did you ask and what did the mother tell?
so duration of the device use. So for example, a children who, for example, if I went to Anganwadi, I asked the Anganwadi mother that, so what is the predominant device in your home? So they are like a mobile. So but these children who are in the preschool Anganwadis, they spend their most of the time in the Anganwadis. So when they go back to the home, I'll ask them how much duration they use the device, either maybe the television or mobile. So and then like this, I have.
But again, that is not objective. No, it is very, very subjective. It may. Why I am telling is that
That's a limitation.
Wait. I know you have added in limitation, but my doubt is this: that see, in majority of our households, people will be watching serials from morning till night, 11 o'clock. So the TV is on. The child comes, is walking around, will sit while eating. Also, is seeing the TV because TV is on. Is it because the TV is on, mother feels that okay, my child is also seeing TV, or it is exclusive child screen relationship?
It's an exclusive, sir.
It was exclusive.
Yes, sir. Not passive, so it's active use.
So how did you ask that?
Like
Because see, majority of the households will have single mobile, in which mother is watching something, or there is single TV which they are watching. Okay, so when somebody is watching that, the other person comes and watches, is also screen time for that person. So if you are not considering passive, if you are considering only active, how did you actually ask that? That is not very clear, because you say it's a tool, but it's not actually a tool. You have asked one question, that does your child watch TV, or does your child watch any electronic gadgets? Everybody will say yes. How much time? Randomly they'll pick a number and tell, because they are also watching actually. So they'll pick a number and tell. So you'll not be able to conclude with that. You have added that in limitation, but the primary objective of your study is that. So that cannot be added in limitation, right? The primary objective itself, there is a limitation, then it will be difficult to conclude anything. That's one. At what time were they using this is the next question. Was it pre-sleep, or see, Anganwadi generally is there till afternoon. As soon as they come in the afternoon while having lunch, because they will be creating a ruckus, people will give one mobile and then they will make them feed. That will take 1 hour. And during dinner time also, they'll give one mobile, they'll feed. That will take another, say, half an hour, this half an hour, that half an hour. It's more than 1 hour. That will also come as more than 1 hour. Or is it after food, the child doesn't go to sleep and they're shown rhymes, they're shown cartoons, etc. What happens?
Most of the time in the evenings.
Yeah, but that is not collected in your data, no. So the sleep will be affected usually if a blue screen is used about 2 hours prior to sleep, yes. 2 to 3 hours prior to sleep. That will cause sleep disturbance. So anything which is watched in the afternoon, whether it will have similar correlation is very tough. That did not come up in our study at all. The same with the last one. It adds to emotional and behavioral problems at early age. Which behavioral problems and emotional problems did you notice in this? Majority of them had no problem. Some of them had poor academic performances. Where is it emotional and behavioral?
So this emotional and behavioral problems can be assessed in the further studies, sir. These problems can be studied with respect to the further studies, sir.
No, it's conclusion. It's not future direction.
Can increase the risk.
How? Where did you see that?
Because
in your
of this
study?
inattention due to excess screen use.
That is not emotional problem. That is not behavioral problem also. So aggression, kind of depression, quasi-depressive features, they will become emotional and behavioral problems.
And reduce interaction, social interaction.
But it was not there, no. So your major findings are that they did not, academically they became poor and they did not sleep well. How did it become emotional and behavioral problem is my question. Thank you.
Thank you. Organizers, if you are running out of time, you can remind us. Yeah, like you can keep some timing for us also.
Then the next session is at 10:45. We have this hall till that time. But if we have anything to do, then we can.
Okay.
Thank you, Vikram. I would like to invite Supriya up onto the stage.
Before Supriya comes, I was just looking, you can come. I was just looking up, assent, I think more than 7 years. I was just looking up, you can just confirm. Young children, they cannot even give assents, 3 to 6. You can just confirm. You can just come.
In some studies, 4 years also will take assent. Here also they have used 3 years, no. 4-year children we have taken assent. Our ethics committee needs 3 years, 4 years.
Good morning all. My topic is, my name is Dr. Supriya Salanke from MRMC Kalburgi, Karnataka. My topic is Association of Socio-Demographic Factors and Postpartum Depression in Tertiary Care Hospital. It is a cross-sectional study. Introduction. The postpartum period starts following the expulsion of the placenta until the complete physiological recovery of a various organ system. The transition of motherhood involves major psychological and then biological changes and makes the pregnancy and the postpartum period vulnerable to ill health. The prevalence of postpartum depression in high income countries is around 10%, whereas in low and middle income countries it is around 20%. While postpartum depression is a considerable health issue for many women, the disorder often remains undiagnosed and untreated, as greater priority has been given to the preventing the death related to the obstetric complications. Untreated depression is concerned because of its association with a poor infant physical and neurocognitive developmental outcomes. Also, the depressed mother may not develop positive and satisfying relationship with her infant. There have been several studies, meta-analysis and systematic reviews attempting to build and validate the predictive index capable of determining the risks of developing postpartum depression in advance. Still, it is uncertain whether socio-demographic, psychological, psychosociological, biological and obstetric factors make women vulnerable to postpartum depression. Thus, screening of women who are at high risk during the pregnancy would help to decrease the probability of getting PPD in the future development. Literature review. The study conducted by the Azal et al. In 2018 in southern Ethiopia found that prevalence of the postpartum depression is around 12%. Its association with the rural residency and the multiparity were found. Whereas in study conducted by the Deshmukh et al. In Maharashtra found that 96% of the primiparous women out of 96, 11% had a postpartum depression prevalence. Whereas coming to the Gale et al. It is a meta-analysis conducted in the USA. They found that prevalence of postpartum depression is around 19%, whereas associated factors for developing the risk factors for developing PPD includes childhood abuse, maternal low education, and low socioeconomic status, and a lack of social support and history of mental illness in the family. Coming to the aims and the objectives of my study, to estimate the incidence of the postpartum depression and to determine the socio-demographic risk factors associated with the development of PPD. Methodology, it is a cross-sectional study done under the setting of tertiary care teaching hospital. Inclusion criteria is around women with the age group of more than 18 years or within the 6 weeks of after the delivery. And then exclusion criteria are previous history of the psychiatric illness and critically ill patients. And the instruments we are used here, Mini 7.02 version. Sample size calculated by the Cochrane formula. Sample size is around 150. Coming to the result, mean age of my sample size is around 25 plus or minus 4. Most of the patients reside in the rural population. Most of them are studied till higher educations, and major of my population were unskilled. Most of them are homemaker and and some of them are daily wage workers. Almost around 92% of the patients were Hindus. They reside in joint families and most of the patients belong to lower middle economic status. Around 80% of the patient had birth of the female newborn in current pregnancy, and around 61% of the patient have previous female offsprings in my study. Coming to the incidence of the psychiatric comorbidity in my study is around major depressive disorder is around 10.66%. Risk factors associated with the BPD in my study done by the chi-square test. And the chi-square test, the strength of association significant statistically come in multipara patient who are who are rural residents and who have previous female offsprings, and birth of the female newborn in the current pregnancies have increased, have statistically significant. Coming to the discussion, the overall prevalence of psychiatric disorder in my study is around 16.6%. The most common disorder was postpartum depression. It is around 10.6%. The study conducted by the Rachel et al. In the North India, it has the same like my study, 10% of the postpartum depression, and the study conducted in the UA by Hamdam and the Tamim et al. It is also having 10% population have postpartum depression. The study conducted by the Chandran et al. In the Tamil Nadu state had 11% of the prevalence. Coming to the socio-demographic factor, the study conducted by the Azal et al. Identified the risk factor which are significantly associated with the depressions, where presence of the rural residents and the multiparity, which is similar to my study. The meta-analysis conducted by the Upadhyay et al. Found that high parity in the previous female baby were have significantly associated with the depression, similar to the my study. Coming to the conclusion, the presence of the postpartum depression is a common psychiatric disorder. The risk factor associated with the depression in our study were presence of the rural residency, multiparity, presence of the previous female infant, and the delivery of the female newborn in the present pregnancy. All were associated with the significant statistically. Hence, early screening and the treatment for the postpartum depression is important. My strength of my study is it is a study conducted at the geographical location.
Why do you think having female children in the previous birth or now is a risk factor?
Sir, and because of that stigma and that Asian countries and most of the Indian family stigma like blaming the women who had given birth to the female child.
That's
in the
not stigma,
previously. No, it is not stigma. So blaming, sir, that it will cause the women will go in under stress because of that blaming and all.
Exactly. Now, how many sees it is by seeing the incidences. Okay. Now, at this point in time, if the woman is distressed, that may be picked up as depression. So, was it actually distress or was it depression?
So we have to see over the period of time, not exactly at that point. With that, the distress it may, if over the period of time, it may continue as a depression. When most of the females in my study who have previous one or two female, and the current birth of the third baby, if third baby is female baby, they will be depressed around when we take that history around 4 weeks or 6 weeks, they will be more depressed and more will be, they will be more thinking about what if next.
That did not come up in your study. Either it is having a female child
Yes, previous female child.
Previously, or having a female child now. It was not shown that they both are linked. I mean, first one or two were actually female and now also it is female. That was not shown.
Okay.
Right. So either it is either. So earlier there was a female child, now a male child will also have postpartum depression. Earlier male child, now a female child will also have postpartum depression according to what you have shown. Right. Then how can we tell that having only female children versus having at least one male child? It was not seen, no? It was not studied.
Yes.
So then how can we tell that that's the risk factor?
Yes.
Right. And we, again, I'll come back to that question as to it might be distress.
Yes.
It might be just simple distress that, okay, see, now what will happen? Like now I have a female child and everybody will blame me for that and I'll be ostracized, etc., etc. There is so much of stress regarding that. Are you picking up stress as depression, postpartum depression?
No, sir, we have waited for 2 weeks, 2
2
weeks.
weeks it will not come down. No, how will stress come down in 2 weeks?
All those criteria after meeting those
That
criteria.
that will stay for almost lifetime probably.
Yes.
The stress. So
Yes.
it is not depression yet. Okay,
Not
depression
much.
has specific criteria to be
Yes.
met. It is not depression yet.
Yes.
It may be just distress. So we don't know whether sometimes these survey tools can pick up that. So it's true with Mini, it's true with Fly, which we are using in NMHS 2. We used Mini in NMHS 1. So again, the problem with all these survey tools is that the false positives are high, quite high. Again, the same question about Mini. So did you take permission from them?
Yes, sir, I have taken, sir.
Taken
Yes.
Sure.
I bought, yes, sir. I can show that document.
Yeah, you bought.
Yes, sir. It is in mail only.
No, you bought Mini.
Yes.
You did not anywhere tell about in the ethical considerations about finances for this, etc., etc.
No, sir.
Ethics committee, finance. Nothing came in our presentation. How will we know then? How will anybody know? If you want to publish this, like as a general thing to all the PGs, when you are publishing, many journals will ask for ethics committee approval number also. And if it's a intervention study, they'll ask for CTRI number, clinical trials registry number. Any intervention can be, it's a simple procedure, but nowadays it is mandatory for everybody to have these two things. And whenever it comes to finances, where did you get money from? Personal money generally should not be used for research. Unless you are a philanthropist and you have donated and then you use that, that becomes money laundering. So these are some of the issues. No, as PGs sometimes we don't think, okay, it's there, it's small amount, let us do it from this itself. But these, when you're disclosing, when you're actually presenting or when you're publishing it, the financial disclosures, etc., these questions will be asked. So you'll have to tell about your financial disclosure and where did you get that money from, etc. How did you pay that, etc. Those become difficult issues.
There are some methodological issues which I'll talk later. This is the only slide you have reference, or you have one more slide?
One more.
Okay, fine. So because I was looking for those meta-analysis, the Indian meta Upadhyay and Gele. Anyway, fine. So your objective is to assess incidence.
Yes.
Can this study design do justice for this objective? Can a cross-sectional study assess incidence?
No,
Isn't it?
Yes.
And in your results, you have said prevalence.
yes.
A cross-sectional study cannot assess incidence. So, and what you have assessed is prevalence only. That is one thing. Second thing, what is the novelty in this study? What was the need for study? Because there are big meta-analysis done in India and elsewhere. They have already given you what socio-demographic factors pose a risk to develop PPD. Then what was the need for another study when it is already been established in meta-analysis?
Sir, in our
You have said it is inconclusive. Again, some reference, 10, I don't know which one that is Steiner. Okay, anyway, so because extensively studied PPD and socio-demographic factors in PPD is extensively studied. For the sake of learning, you can do study, no problem. I mean, as a postgraduate, you want to learn research methodology, that's fine. But if you want to publish, this question will come. Okay? And why did you choose Mini over other short, simple tools freely available like EPDS is there, Edinburgh Postpartum Depression Scale is there, and even PHQ-9. Why did you choose Mini?
Sir, actually my previous idea was to study the comorbidities, overall comorbidities. After that, I have found
Acha, you want to see the spectrum of psychiatric
for-
problems. Okay,
for
fine.
presenting, I choose only postpartum.
You can say
depression.
this is a part of a little bigger project because usually globally people either use EPDS or PHQ-9
Yes,
for
sir.
postpartum depression. Can you show your inclusion exclusion criteria? Inclusion exclusion. Yeah, just yeah. All mothers 18 who were within 6 weeks after delivery. Okay. And where did you contact these mothers?
Sir, in hospital setting only, sir.
Why did they come to hospital?
Sir, in immunization, while coming to
So in
immunization,
that's the usual practice. You catch
Practice.
hold of these
With the
mothers in
mother.
immunization
Sure.
clinic. Okay. So previous history of psychiatric illness you include. Come to the sample size. 44%. 4p square. You have used 4p cubed by r square. Huh? What is this L square?
L square is permissible errors. L is a
Why did you
permissible error.
take 8.8%? Any reason?
20% of p values, that is
20% you took.
Hmm.
That's quite high. Anyway, fine. So see, if you come to your conclusion, your second objective is to find the association between socio-demographic factors and PPD. Did you actually do that? Because you have not presented that anywhere, how age has related to PPD, I mean how...
Only positive findings I have written, sir. With p
No, but
value.
in result section,
Yes, sir.
can you just show that? Acha, multipara versus primipara you have taken. Residence urban versus rural, previous female offspring. Birth of a female newborn. What about other factors? What other factors you
They
considered?
are not significant, sir. That's why
You
I'm
can
not
still, because whether you have included all which is
Yes,
there in literature, you better include.
Okay.
Like domestic violence is one thing which is
Okay.
often
I have
spoken
not
to.
taken.
And expected gender of the baby or previous obstetric complications. So all these things are existing obstetric complications in this delivery itself. Many various things are there. So those things you can think of. Okay.
Thank you.
Thank you, Supriya. Next, we have Anjali. Good morning to all. I'm Dr. Anjali Prakash from KMC Manipal, and the title of my study is Negative Symptoms in Cognitive Deficits, a cross-sectional study of their impact on real-world functioning in schizophrenia. Real-world functioning in schizophrenia, as we know, is a complex construct, difficult to define, and highly variable across the course of illness. It's influenced by the interplay of various factors, including neurocognition, negative symptoms, motivational factors, socio-demographic, and clinical characteristics. It's distinct from functional capacity, which simply measures what an individual can do, whereas real-world performance measures what an individual actually does. And there are several factors which limit the application of the acquired skills in real-world settings. Negative symptoms so far have been identified to be the most crucial predictor of real-world functioning. However, the exact contribution remains unclear. Therefore, enhancing our understanding may help to improve the functional outcomes in these patients. The aim of the study was to assess the association of negative symptoms and cognitive deficits with real-world functioning in patients with schizophrenia, with the objectives being to assess negative symptoms and its association with real-world functioning, and to assess the cognitive dysfunction and its association with real-world functioning in these patients. It's a cross-sectional study design conducted in KMC Manipal with patients recruited from outpatient and inpatient as well as its affiliated camps. Study period being 15 months, convenient sampling used, and a total sample size of 144 were recruited. The inclusion was a diagnosis of schizophrenia as per the ICD-10 with a minimum duration of 2 years. The age of the participants were 18 to 60 years in either gender. Those participants who did not have a severe illness, as measured by the CGIS and the individual scores on BPRS 24, and participants giving written informed consent were recruited.
Those participants having a major medical comorbidity and other comorbid psychiatric illnesses, except for nicotine dependence, were excluded. The following tools were used, including the Sociodemographic and Clinical Data Sheet, the CGIS, BPRS 24 version, the NSA 16, CGI SCH, the Addenbrooke's Cognitive Examination, Trail Making Test A and B, and the real-world performance measured by the Personal and Social Performance Scale. After having received the approvals from the appropriate regulatory bodies, a total of 171 patients were approached, out of which 3 patients had declined and 24 were excluded, and a total of 144 participants were recruited. Coming to the results, the participant characteristics is the mean age of the participants were 43 years, with fairly equal proportion of male and female. Most of the participants were single, studied up to middle school, were unemployed, with a total duration of illness of 12 years. Most of the participants were on atypical antipsychotics, followed by polypharmacy, and around 18% were on antipsychotic depot. Moving on to the comparison of the participant characteristics with the NSA and ACE, as well as TMT B-A, it was observed that single status was associated with higher levels in the negative symptoms, and male gender and higher level of education was associated, statistically significantly associated with better cognitive performance as measured by ACE. And younger age and an episodic course of illness was significantly associated with better performance in the TMT B-A. Moving on to the Spearman's correlational analysis, all the subdomains of NSA and ACE were significantly correlated with the PSP scores, with stronger correlations seen for the affect subdomain and the fluency subdomain. Lastly, a regression analysis was performed, and the model was found to be statistically significant with an R-square of 0.57, and among the predictors, the affect, social, and retardation subdomains of negative symptoms, fluency, and memory were identified as key predictors of real-world functioning. Reduced scores in the affect subdomain of negative symptoms and increased fluency scores are important predictors of real-world outcomes. All the subdomains of negative symptoms were significantly correlated with real-world functioning. Our study was in contrast to the previous studies, which revealed a stronger negative correlation with the affect or the diminished expression subdomain, whereas the previous literature suggests a more stronger correlation to the evolution apathy subdomain. Chronic schizophrenia is associated with poor cognitive performance compared to the age-matched controls, and higher education was associated with a better cognitive function, which suggests that higher premorbid abilities lead to improved cognitive outcomes after the illness onset. Negative and cognitive symptoms are closely interlinked, and in our study, we observed a negative correlation between performances in attention and fluency with most subdomains of negative symptoms. Coming to the limitations, it was a cross-sectional study design, therefore it limits our ability to understand the dynamic interaction of these variables. Probably the use of a more comprehensive neuropsychological battery could provide more detailed assessment. Use of self-reported data for assessing medical comorbidities, which also could impact the real-world functioning. And lastly, we have not examined certain other important factors such as family dynamics, support system, role of social cognition, which could affect the real-world functioning. The key findings can be summarized as all subdomains of negative symptoms, particularly the affect subdomain, were significantly and negatively correlated with real-world function. All the subdomains of even cognitive deficits were significantly correlated, with strongest correlation for fluency. And lastly, the affect, social, and retardation, along with fluency and memory, were found to be the key predictors of real-world functioning. Thank you.
Why you excluded people with high CGI scores?
So basically, I wanted to eliminate those having severe positive symptoms. So wanted to recruit stable patients. So the method we used was using CGI along with individual scores on BPRS, like hallucinations, suspiciousness, who was scoring high on positive symptoms. Okay, so that it doesn't interfere with their cognition, the performance on the scales.
Because CGI, I mean, if you rule out somebody based only on CGI, you will even rule out with the severe negative symptoms as well.
Yes, sir. So that is one thing that most of my participants, in compared to the existing literature, the negative symptoms are not too severe, the total NSA scores.
Okay.
But, yeah.
And like you said, previous literature differed from what you got in
Yes,
this
sir.
AA subdomain.
sir.
Any
Yes.
reason you could think of?
So one thing that I could think of is most of the literature that I could come across for the Western literature, and there probably the dependence, like real world functioning, is more of autonomy and how they could perform independent activities. Whereas for us, living in the community and more of a expressive subdomain is more significant in the cultural context. And the added thing that negative symptoms, overall, my total scores were lesser than the existing literature, my total NSA scores.
Okay, and if you go to that correlation, like you have correlated every subdomain of this tool.
Yes, sir.
Is it done in previous studies as well?
So that was one
that's
of the additional thing, because previous studies have only looked at total scores. So I wanted to further see which subdomain was further like strongly correlated. So
okay, in that case, you should think of false positive alpha
yes,
error
sir, that's
and
another.
correct for
Yes,
that,
sir.
because
Yes,
too
sir.
many
Yes, sir.
correlations when
Yes,
you
sir.
do.
Yes, sir.
So then you just look into it.
Yes,
You
sir.
might again do some
Yes, sir.
correction and
Yes,
see
sir.
how many of them then actually
Come up. Yes,
have
sir.
a correlation.
Yes, sir. Yes, sir.
So
Thank you, sir.
See, generally in cognition and schizophrenia,
Yes.
the majorly affected subdomain is fluency,
Fluency. Yes.
verbal fluency especially.
Yes.
And it might be simple correlation because of that reason.
Yes.
It's not that fluency is affecting the real world functioning, but because it is there and real world functioning is affected, you are just showing it. But why I ask you this, why I make this comment is that mostly real world functioning theoretically it should be affected because of executive functioning, planning
Yes.
and
Yes, sir.
execution.
Organization. Yes, sir.
That is not seen at all.
So that
Yeah.
is measured by my TMT B minus A. So that's a rough estimate of the executive functioning. So that comes as my limitation that I've not used an extensive tool, but it said that the B minus A of the ICMR NCTB toolbox gives a rough estimation of their execution function. So, but that didn't correlate for me. Like it didn't come statistically significant in my study. So.
You have not used that in your limitation either. You have used social cognition in that.
Yes,
it was
sir,
one of my
Yes.
other, that would have been my other comment.
Yes.
That what we have found in our research is that executive functioning and this social cognition
Cognition are more.
are the most important tools which will affect the real world functioning.
Yes.
In fact, for real world functioning, there is a scale called UPSA-B.
Oh, yes, sir.
Uh,
USB, yes, sir.
You have seen
Yes,
that,
I've seen that, yes, sir.
University of California,
Yes, sir.
performance
Performance
based
assessment
scale,
scale, yes,
B.
sir.
So that gives a very good account of how
The
real
changes
world
yes.
changes can happen.
Yes, sir.
Real world, how functioning is affected in the real world.
Yes, sir.
And because I was also involved in once upon a time matrix consensus cognitive battery with
Yes, sir.
UPSA-B,
Okay.
we had
Yes.
used it,
Yeah.
and hence even there we found that it's mostly about the executive functioning which affects. Verbal fluency is there
Yes, sir.
because it's the first thing to be
Get
affected,
yes.
and it stays for very long time.
Long time, yes, sir.
But it's quite interesting study.
Yes.
But you could have used that in your limitation that
Yes,
executive
sir.
functioning was not studied in
Yes, sir.
detail.
In detail, yes, sir. Sure, sir. Thank you, sir.
Thank you, Anjali. We have our last candidate, Pragya.
Good morning. I'm Dr. Pragya Jain, junior resident from KMC Manipal. The title of my paper is Patterns of Technology Use and its Association with Sleep Quality and Quality of Life in Young Adults, a cross-sectional observational study. Technology is an indispensable part of human life. It comprises broad spectrum of activities such as social networking, email and chat, etc. The WHO defines young adults as individuals between the age of 20 and 24 years. Addictive or problematic use of technology is characterized by being overly concerned about online activities driven by an uncontrollable motivation to perform the behavior and devoting so much time to it that it impairs other important life areas. Indian studies have shown up to 20% addiction to internet in young adults. Problematic mobile phone users in Australia was found to be nearly 41% in one of the studies. Significant psychological implications are there of overuse of technology such as disturbed sleep, mood swings, irritability, etc. Most of the existing studies target healthy individuals, leaving out those which are visiting the psychiatric clinic. There is limited exploration of relationship between technology use and its impact on quality of life. The objectives of our study was to assess the patterns of technology use, both internet and mobile phone, in young adults visiting the Department of Psychiatry in a tertiary care center, to find the association, if any, between problematic use of technology and sleep disturbance as well as quality of life. It was a tertiary hospital-based cross-sectional observational study conducted in the Department of Psychiatry, KMC, Manipal, from September 2023 to August 2024, with purposive method of sampling used with a sample size of 97. Young adults from the age of 18 to 25 years who visit the Department of Psychiatry on OP-IP basis both, irrespective of the psychiatric diagnosis, were included. The participants should be using any technological device, smartphone, tablet, PC or laptop, at least class 12 literate and understand English or Kannada, and give informed consent for the study. The exclusion criteria were acutely ill patients who are not good enough to give reliable information, and those who have severe neurological impairments or developmental disorders. After the scientific committee clearance, institutional ethics committee approval, CTRI registration, informed consent was taken for the participants, followed by socio-demographic and clinical details were collected. Internet addiction test, mobile phone use screening test, Pittsburgh Sleep Quality Index, and WHO Quality of Life, the brief version. These scales were administered, followed by statistical analysis. Coming to the results, these are the socio-demographic characteristics. Most of the participants were in the age group of 18 to 21, females, class 12, studied up to class 12, currently students and belonging to upper middle socioeconomic status. Clinical characteristics, 82% of the participants, 82.5% had a single psychiatric illness, 12.3% had more than one psychiatric diagnosis, and 5.2% had no psychiatric illness. The most common psychiatric diagnosis found was depressive disorders in 22 participants. Levels of internet use, which was assessed by the internet addiction test, showed that 57.7% of the participants had mild internet addiction, followed by 20.6% participants having moderate internet addiction, as well as normal levels of internet usage. Coming to mobile phone use, 52.6% of the participants had moderate mobile phone use, followed by 41.2% participants having addictive mobile phone use. The correlation between technology use scores with quality of life was assessed using the Pearson's correlation coefficient. Significant correlations was found between both the IET scores and the MUS scores with the PSQI scores. Similarly, correlation of technology use scores with quality of life, different domains, was assessed using the Pearson's correlation coefficient. Significant correlation was found between the IIT score and MUS scores with the physical health, psychological health, and environment domain of quality of life. A considerable proportion of participants exhibited mild and moderate levels of internet addiction as well as excessive or addictive mobile phone use. Addiction rates of 18.6% for mobile phones and 16% for the internet among patients aged 16 and above seeking psychiatric treatment in India has been found in one of the studies. Excessive technology use was found to be significantly associated with poor sleep quality. Continuous engagement in online activities, especially before bedtime, leads to increased cognitive and emotional arousal, making it harder to fall asleep as well as maintain sleep. Higher smartphone use duration has been associated with poor sleep quality in one of the Indian studies. Excessive technology use was associated with poor physical and psychological health and a less favorable perception of one's environment. Excessive time spent online can lead to sedentary behaviors and reduce physical activity, which negatively impacts physical health. Constant connectivity and exposure to social media can increase feelings of anxiety, depression, and loneliness. Smartphone overuse has been significantly associated with lower quality of life in one of the studies. Conclusion. This study highlights the prevalent issue of excessive technology use among young adult patients. Though it's unclear whether the psychiatric illness or technology overuse occurred first, The relationship could be bidirectional. These patients are more susceptible to sleep disturbance and have a lower perception of various domains of quality of life, both of which are linked to excessive technology use and may be influenced by their mental health conditions as well. Clinicians need to be alert and recognize these patterns of technology overuse. Further research, particularly longitudinal studies, is required to gain more understanding and to explore potential causal relationships. The limitations of these study, the cross-sectional nature of the study, which is making it difficult to establish causal relationships, limited generalizability of the findings, and possible impact of the psychiatric illness on the sleep quality as well as the quality of life, which is coloring the picture. Thank you.
Can you just go back to your objectives? Yeah. Pattern of technology use in young adults, visiting departure, sleep disturbance, find association. You said 82% of your population, your sample had one psychiatric diagnosis.
Yes, sir.
That's quite high, and it's a confounding factor, isn't it? So
Yes,
their
sir.
sleep quality and
Yes, sir.
might be due to that psychiatric problem, not necessarily due to technology usage. So
Yes,
how
sir.
how have you addressed this confounding?
So that's one of the limitations of the study. We haven't addressed that.
So these were basically young adults seeking health, mental
Yes,
health
sir. Yes, sir.
help.
Yes, sir. We
Okay.
are trying to establish if psychiatric comorbidity impacts internet addiction as well. Like that's one of the relation. It could be bidirectional, is what we are concluding.
And if you like, your conclusion again. You should ideally restrict to what you have found in your study rather than going for some hypothesis or some suggestions not needed.
Yes.
Yeah.
Why was only age group of till 25 was taken?
So we were targeting young adults because the proportion of internet addiction is found to be more in young adults, according to the previous literature.
In fact, in older adults, it is also found more.
Yeah, it's either the elderly or the young adults which have more as compared to the middle-aged participants.
Why class 12th?
So at least class 12th literate to be able to give the reliable information we are asking for based on like all the scales and.
So class 10th person, a
So,
person who has passed class 10th, you don't think they would give reliable information?
So that was not based on something very specific, I would say. Class 12th was picked up. Based on one of the scales also said like the mobile phone use scales also had one of the requirements of class 12. So like based on that we decided between 10th and 12th.
Again, similar question as to in your study, at what time were they using the mobile phones more?
So I didn't get your question. What time as in time of the day?
Time of the day, in the evening hours or
So I
in
did
the
not.
night, just before sleep?
Hmm.
Because that would affect the sleep pattern.
Yes, sir.
So if they're using during their sleep hours, say they'll start using their mobile after food, everything at 10 o'clock and keep watching mobile till 3 o'clock, and then that affects the quality of sleep.
Yes,
Versus somebody who comes back from work, sees for 2 hours or 3 hours, and then has food and goes to sleep. That's a significant variable.
Yes, sir.
Which will affect the quality of the study, right?
Yes, sir. So that wasn't considered the time of using the device.
We are running out of time. So. Yeah. Thank you. Thank you.
Thank you, sir.
Thank you, Pragya. We have come to an end of our free paper presentation. I would like to thank all the participants, and I would like to extend my sincerest thanks to the judges for giving us some wonderful insights into the statistical nuances, which I think we all agree are very difficult to gauge. So thank you so much, sir. We'll be having our next session at 10:45 a.m. So we will see you then. Thank you. Now we have a session in Hall A as well, so we can all attended. Thank you. Without saying. So these are some of the employer strategies for digital mental health. So foster a culture of openness about mental health, offer flexible hours to reduce digital fatigue, and provide access to mental health resources. These are next slides are going to be some of the apps which I've used, which have worked wonderfully along with the mental health. Number one is Headspace for work. I'm sure most of us seen it in Netflix also. There's a series of Headspace worth watching, has worked for a lot of people. Calm for Business, another mindfulness app. It offers a variety of relaxation techniques, sleep stories, and breathing exercises. BetterUp is another, this app works only in iOS, so only in the iPhone. This app combines mental health support with professional coaching. Then we have Ginger, Happify.
And Visa is something new. Visa is an AI-powered app that offers anonymous support through conversation with an AI chatbot, but this would be a paid app. So as a conclusion, technology definitely can help when balanced, though it is in the digital era. Thank you so much. And attaching a picture, one of my first mental health in digital era, I've tied up with Convalescence Global. They are the first people who have given me the opportunity to do this. Thank you so much for this. Thank you.
It was a nice presentation, Dr. Priya. Thanks for completing in time. Now, we are open for questions, and the best question will be awarded. It's already been announced by the organizers.
Hello. Respected Chairperson, myself Dr. Sagar from Kerala. My question is to Professor Dr. Ashok sir. Sir, in a workplace, what's the important stakeholder is workers' union or employee organization. What's a role of this sort of organization in a workplace? Because they try to, maybe ensure the various rights of the employees and all. What's your comment then? Okay, thanks.
Basically, the workers' unions, they strengthen the workers by giving a common voice, a platform which can act as a voice which is taken seriously by the employer, compared to if only one employee goes to the employer and discusses the problem. So organization, the workers' unions, the role is to mediate between the worker and the employer. So they can take all the issues, discuss with them, and discuss with the employer with a congenial environment, not to just fight. But usually the things go on, like usually they will be fighting with them. They should not go and fight, but they should discuss the issues and get the redressal and solutions for them. That will be the role. It's mainly a mediation role. Yes, unions have a great role. They get the bargaining power. The individual cannot go ahead and discuss, whereas if the union, it is reference to a union, it's taken seriously by the employer. It has a better role. Of course, every entity will have bad and good. More good is projected nowadays because they'll be mainly fighting more than solving the problems.
Sir, you said that as per it is also involving some of the production issues. How much of, for example, tire in the automobile industry, how much of tires have to be produced? So that bargain also is made within the working hours, specific working hours. And of course, what's the wage factor, overtime allowance. So like that, so many issues are being worked out between the union and the employers. Next question, I think is... please introduce your name, madam.
I am Dr. Joyce from Kerala.
Name?
Dr. Joyce. It was a wonderful presentation by my professor, Dr. Droisar's team, and my student, Dr. Priya. And my two questions, one is to Dr. Smita. I am fully supportive of your presentation about stress of women in workplace. And as an expert, what are your solutions, like personal aspect, like improving the coping skills or resources of a person, women, working women, other technical arrangement like a clean bathroom or daycare facilities for kids. What are your suggestions to improve as a mental health expert? And second question is to my student, Dr. Priya. We ourselves, psychiatrists, are much stressful making EMR because our establishing rapport therapies and interview itself take lot of time, and recording in EMR in digital era it will ruin our relationship with the patient. Can you suggest some solution like any new software like ChatGPT or some whether secretly we can keeping privacy, we can record as well as establish, do a fruitful psychiatric interview. Thank you. Thank you.
Thank you, Dr. Joyce. Okay, so the strategies to improve the workplace mental health of women, so if you are really, on a if you're planning really in a futuristic way, definitely we have primordial, primary and secondary strategies, preventive strategies and interventional strategies. And it varies with the scenarios. Okay, so I was talking about the workplace aesthetics and coffee machines, all those things. That is only one aspect. And if it is for the perimenopausal or menopausal women, they are even saying having a system to reduce the temperature of the workplace, that even improve their mental health. And so definitely personal level, so the workplace management level and policy level strategies must be there, and improving the self-care, improving the perception of our own work-life balance, to improve our cognitions. All these things we can do in the on the personal level, and having a strong network, talking about the taboo topics, discussing our problems and how we overcome our problems with our colleagues. All these things can help at a personal level. And at workplace level, definitely environmental modification, the rules and regulations, flexible working hours, all those things. And the policy level, law and order level, against violence, definitely there must be strong law and justice system to handle the workplace violence. And the policies regarding the for the, as we know that there is maternity leave, abortion leaves. Many of the government employees are not aware of abortion leave. So having policies, having letting the employers know about the policies, that is another thing that we have to focus on.
One more clarification on this question is, many times a female social worker in an industry setup will be able to do a lot of helps in this issue. For example, the sanitary aspects, sanitary napkins, which a male psychiatrist will not be able to handle that.
I would like to differ.
So that is always there. Of course, I was a director of IMH. Once a reporter came, and a press reporter came and asked me questions. Sir, are you providing sanitary napkins to the female patients? This is the question I was able to handle. So that struck me a lot. And then because it has to be periodically reinforced, the stock has to be enhanced. So many issues are there. Anyway, what I thought is a female social worker will be able to do a lot of work apart from the psychiatrist.
Just because you had a social worker, that question arised.
Yeah.
But if as a head of the department or head of an institution, you must be aware of the women's problems.
Overall,
so that and awareness and education of the those people who are sitting in the top,
also necessary.
that is essential.
Overall, you can have. And I think Dr. Shahulamin has got a question. Before, after that, we'll come back to you, madam. Dr. Shahulamin.
To assure it, sir. You said about the RPWD Act, where if there is any discrimination on the grounds of mental illness, they can complain to the Disability Commission and all. So does that apply to all mental illnesses, or only those who have those illnesses that come under the definition of a disability, and those who have a disability card and things like that?
It's mainly about the disabilities only. If they are mistreated because of disabilities, not because they have the mental illness. If the disability is the issue, then it is covered there. Not just having mental illness like anxiety, depression, it doesn't come.
Thank you, sir.
Hi, I'm Dr. Sabina Rao. I'm a psychiatrist in Bangalore. I work in Manipal Sarjapur Road, which is the IT capital side of India. And my thought is that, Dr. Roy, thank you for your very crisp presentation, sir, because I think you mentioned super important points. My question is, neither NIMHANS nor any government sector, hospital or branch or even private sector offers women part-time work. And it has been shown in evidence that part-time works very well for women because they get really efficient in half the time. They'll finish the work and they'll go home because they know they've got a job at work and they've got a job at home. And in Indian society, since I've been working for 20 odd years, there is very little contribution from the man. And so I would be very excited to hear what you think of that.
Yeah. I think this is an excellent proposal, excellent suggestion. I think we will fully take it up. We will take it up to the level of the World Federation of Mental Health and WHO. It's an excellent suggestion. Part-time work for women, excellent. Thank you very much.
Can I ask a question? Dr. Sebin from Kerala. Regarding, I work in a medical college. Sorry? Will complete.
Hello, you can tell your name sir, loudly.
Oh.
Give a mic, please.
Mic.
Give a mic.
I am Dr. Selvarajan from Tamil Nadu. I worked at JDNCD for 5 years recently. I retired. I come to know that Vikasa committee is always should be present in women working places. It should be made available in all places. That is one thing. The needs of the woman should be aware of. When I was worked in jail duty during teachers' agitation, one woman lecturer came to me and asked the napkins, as he said. I forwarded to the superintendent of the jail. So the needs of the woman should be sought out. And third one is inhibition. Inhibition in culture is always a problem to the mental health and physical health. When we admitted one case for attempted suicide, she said she had that is CA service. She could not express by herself and she started attempting the suicide. So the inhibition should in the culture should be erased. And also the ladies, the hormonal changes always affect the workman in the working places. So this needs to be, and many times the labor inspector of the companies will not allow us to enter in the company for any the counseling or this assessment, etc.
Okay.
So we should have rapport with the labor department.
Sir, a request for audience to ask questions. Comments we will probably take it later.
So Dr. Sebin from Kerala. My question is about
Name,
Dr.
sir?
Sebin Kumar. Conflict of interest. I work in a medical college. Suppose my colleagues in medicine surgery, they have an issue. Now if they approach me and I diagnose a mental illness, now how do I deal with that, and what is your suggestion for that?
So you're talking about your colleagues having mental illness and coming to you. As a psychiatrist, you have to provide the services, but you have to maintain the confidentiality with the authorities. You need not reveal to them.
Now if they ask a certificate.
Certificate about what? Illness?
They want to take leave.
Right. If every patient has the right to ask for the certificate. But while giving certificates, we have to be very careful. One is we have to take the application from them, including what purpose they are taking the certificate. We have to mention for what purpose also. And we have to mention very clearly for what purpose we are giving there. In their request, they should mention the purpose. In the certificate also, we have to mention it. So you may not give total details of the illness. You may just say that he is suffering from illness, psychological problem, and he is under treatment.
Shouldn't I write the ICD diagnosis?
No. Administration is not bothered about ICD codes. ICD codes are only bothered by the statistics department to send the mental health data to the higher ups. Administration is not bothered about ICD codes.
Thank you,
You need not reveal. The purpose should be mentioned very clearly. It is for the leave. He is suffering from mental illness. So many days of the leave is maybe given. That's all.
Sir, your name, please. Sebin. Kumar.
Yes, Christina again from Kerala. Sorry for monopolizing from Kerala. A little reductionist question, the debate between the mental health of the worker, workplace versus individual, Though I know as professionals we say it is a balance of both, in our society, I feel there are two schools of thought there, Is it the workplace or the individual responsibility? It's a reductionistic question. The other thing is, in India, most of India, some workplaces can be very understimulating. boredom, nothing to do, and actually the reverse of what is happening in IT, it doesn't matter what you do at all. Okay? Are we addressing that? Because that is also meant to be a cause of burnout, you know, like you keep doing the same thing over and over again for 50 years and maybe 5 years and you wonder why you're doing it. So it's the opposite of the very rewarding kind of IT or corporate world. So these are my two questions. Thank you. Oh, I've not directed it to anyone.
Question is to whom?
Right. Maybe I'll go for Dr. Reddy for my first question and Dr. Priya for my second one.
Your question is for two speakers.
Yeah, okay, I'll just cut through. Dr. Priya then, she's the youngest.
Thank you, ma'am. I think what I understood from your question is we are seeing one phase of IT where they're always hectic. They all have their own, packages and everything, and the other sector, boredom and everything. So for such reasons, there are multiple programs out there. Personally, what I have seen in Hyderabad is type with Royal Avenue travel programs, where even in places where there's boredom, they tie up with such institutes. There are groups they do, it's called as social prescribing. The term used, it's actually used in UK, but yet to come to India. There's actually an information leaflet on the RC Psych website called as social prescribing, where it's just a phone call away to form a group with gardening, trekking, walking, all such kind of activities. I hope this helps. Thank you.
I'll just add one component to this. This underwork and overwork, what you were just commenting. It is natural actually. It's not created. Like if any organization is growing to start with, always is underwork. That's natural. When it grows too much, overwork will start there. So it is responsible of the institution to plan in such a way that this is balanced. Our role is only to educate them what are the effects about it. We cannot go and intervene there.
The first question about workplace versus individual responsibilities.
I didn't understand that question. I'm really sorry.
Dr. Smitha?
You asked that which we have to give priority.
It's a reductionistic question for a professional, but for the society, sometimes they do tend to take sides.
That, of course, personal perceptions, right? That what makes you comfortable, that is, of course, there. When somebody comes with burnout or difficulties in front of us, definitely we can give them the options and the choices theirs. So personal perceptions are important. I already stated that how we are finding it, which area. For a young mom, maybe for their priority may be taking care of the baby. Of course, most of especially in the IT sector and all, most of the young mothers are moving out of the work and coming back. So it's a personal priority, I think. I cannot answer that, can give a black and white answer for that, of course.
This will be the last question. We'll conclude the session with this.
Sir, I am Dr. Arun B. Nair from Kerala. My question is to Dr. Ashok Reddy. My question is about bonded labor. Some of the IT companies are resorting to this bonded labor, as a result of which even if the employees go through a burnout, they are not allowed to take a break. And that is worsening the mental state. But the similar situation is persisting in our medical sector also, unfortunately. So just because a person has performed well in a competitive examination, the establishment, whether it is a government or even some of the private organizations, insist on bonded labor or compulsory labor. Doesn't this amount to human rights violation, blatant exploitation, and isn't it a glorified form of slavery which should be abolished?
See, as per the laws, there is always a provision. If somebody is overworking beyond what is expected, they have to go for the redressal mechanism. That is there already. If somebody is forced again, they have to approach the redressal authority and then get the solution. Have I answered your question? Bonding also. Yeah, if the bond says your working is for 1 year and they extend beyond that without proper extension, it is illegal naturally.
So my question was that during that 1 year period, if they have a serious mental health issue, they are not given an experience certificate, the certificates are not released, and such kind of an exploitation is happening both in IT sector as well as in medical sector. My question was specifically about that. So,
That's right, sir. There is a violation of human rights there. So they have to approach the redress authority and get the redress sorted out. Provisions are there in the law.
Okay, thank you. We'll conclude the session. Over to organizers.
Price, sir.
Yep, price.
Only one. Only one. I think too many good questions.
So, with great difficulty, we have concluded. The award goes to Dr. Arun for bonded labor. Arun B. Nair, bonded labor in workplace.
Congratulations, sir.
We thought about this particular question and had a debate among ourselves. Among the several issues, this bonded labor appears to be an important concept which has not been addressed even globally and also from the other point of view. It is emerging very drastically now, particularly the migrant workers. We see even in, I think it's applicable to all states. In our states also, from Bihar and other places, from other states they come and they are put in a dungeon room. They are given food and shelter and they cannot go out also or go on leave. And we don't know what to call it as. So many issues are emerging now. This appears to be an important issue. There is another, Dr. Sagar also is a very good question about the workers' union, the role of workers' union, how far it can be constructive, particularly for mental health. We have to involve them for the mental health. Unless you involve them, it cannot work out. So that we thought two questions are equally, or if you can, is there any tie if you can give both? Already you given a prize.
So we'll keep that in mind in next conference.
That add to that, see, this bonded labor construct, what he was mentioning towards medical profession, it's quite true regarding postgraduate training, regarding senior residency. That's what he was trying to highlight. And sir told that readdressal system is there, but generally it's kind of a bullied role what will be played by a readdressal system probably. So the problem is still quite at large and is not handled well. That's why we thought probably that is the best question he asked.
Okay, so I would like to thank our chairpersons for chairing this session, wonderful session with a lot of questions and discussion. I would also like to thank all our speakers for their valuable insights about the mental health in workplace, including that of women, which reminds us, as we could see that many of them were taking snapshots of the app that ma'am had displayed, that it applies to us mental health professionals, psychiatrists, anybody, just as much as we want to teach and preach to the world, right? So thank you, sir, and thank you to the entire panel for this.
Yes.
Can you please give a round of applause for the speakers?
Switch the screen.
Background should be on. Projection can be off. Go, other lady one, go to the other side. So you know about
Moving on to our next session, Dr. P. Raghurami Reddy Best Research Paper Award. I would like to have a brief introduction of our chairpersons, starting off with Dr. C. Radhakant. He has completed his MD from Andhra Medical College, and later he has worked as a professor at Maharaja's Institute of Medical Sciences, currently a consultant psychiatrist at Apollo Hospital, Visakhapatnam. His contributions have been great. He has developed computerized versions of psychological tests and rating scales. In addition, he has also started schools for dyslexic, autistic children as well. He is an orator, a teacher, creative person, sports enthusiast, indeed a multifaceted psychiatrist. Next, we have Dr. Arul, professor and head at SRM Medical College Hospital and Research Center, Changalpattu, Tamil Nadu. He has 18 years of teaching experience, with his areas of interest being bipolar, obsessive compulsive disorder, addiction, psychiatric education and research. He is the editor of Indian Journal of Mental Health and Neurosciences and IGPM. He is also a convener of RCBC committee. I would like to invite both the chairpersons onto the stage with a round of applause, please.
I should have said good morning, but now it's afternoon, so good afternoon, everybody. Before we tell about the details about the research award, I would just like to pay my respects to Dr. Raghuram Reddy, sir. He has been a leading psychiatrist of, senior most psychiatrist of Hyderabad and for the erstwhile Andhra Pradesh also. He was very much interested in research and psychodynamic aspects. Now, regarding this award, it was sponsored by Karimnagar Psychiatry Society. It is being given to those who have already published a research paper. So they should have published it in either IGAPM or Indian Journal of Psychiatry or state journals which are indexed by Scopus or PubMed like that in the past 3 years. So these authors should obviously mention the journal, year and month in which their paper was published, and also there is a selection process. First a notification, and a chairperson will constitute a panel of 3 judges. They're there somewhere in the audience, and they will give the marks for this. And the presentation carries 20%, 80% for the writing of the paper. This award will be declared during the AGB. We have 2 presentations for today. Right, sir?
A warm welcome to each and everyone here today for Dr. P. Raghurami Reddy Best Research Paper Award. Without much ado, let us please invite the first speaker.
The first presenter to please come onto the stage. With a round of applause again.
Good afternoon, everyone. I am Dr. Natarajan. So the topic of my research article is titled Publication of Studies Registered in the Clinical Trial Registry of India, an audit of mood disorder research protocols from 2009 till 2019. Introducing the topic, I mean, globally across the world, when we look at national trial registries, so all the trial registries have published protocols and not every one of them land in publication. It has been seen that less than 50 of them land in publications, and this has various implications. When we look into the selective publication of studies, it has various scientific, ethical, and public health implications. For example, a study which shows a positive finding gets published, and a study which shows a negative finding, it doesn't get published. It has a scientific implication. And ethically, when we do not publish studies which involves free participants, So then it is an ethical issue. So we in India, we have the Clinical Trial Registry of India, which was started in 2007, and it made mandatory prospective registration of clinical trials from 2009 onwards. So with this in mind, we decided to carry out a study where we looked at the proportion of CTRI registered mood disorder protocols that are published in literature. Not only that, we tried to evaluate the frequency and nature of protocol deviations in the published articles and whether these deviations were reflected in the CTRI database or not. So we carried out this study with the following inclusion criteria, that we included all observational and intervention studies of patients with mood disorders or their caregivers. Now the clinical trial, we included the clinical trials. The interventions which we mainly included were drugs, lifestyle modification, psychoeducational treatments and behavioral treatments. So we took into account the trials which were registered in CTRI website from 2009 till 2019, and we excluded those protocols which were related to the Ayush and primarily not conducted in patients with mood disorders. So this is how we carried out the search strategy. In the CTRI website, there is an advanced search option. So in that, if you go about it, there are 3 subcategories under scientific title of the study, health condition or the problem studied, and intervention in the comparator agent. So we took into each option into account, and there we tried to input various keywords with related to mood disorders and the treatment which I told earlier. So we tried using these sort of combination of all these keywords using the OR option, and 2 authors independently ran through the search, and we pulled in the final list of studies. So after this, we tried to search through the published article. So we earlier retrieved the protocols. Now we look for the published articles through the Medline search, where we search the PubMed and the Google search. So initially we used the study name. Followed by that, if we could not retrieve that article, we used study keywords and various combination and the last names of all the authors. Even then, if we could not retrieve that article, we classified that this article is unpublished. Again, this was independently done by 2 authors so that we do not miss on any other things, and it was independently evaluated by a senior author. These were the outcome variables. So the publication of study corresponding to the registered protocol, whether it was published or not, and if there are any protocol deviations in terms of sample size, objectives, and primary and secondary outcomes. When it comes to statistic analysis, we use descriptive statistics for the categorical data. And we went ahead with the multiple variable logistic regression. So here, a priori, based on consensus, we decided on 4 clinical variables, like study design, whether it is an RCT or not RCT, it is a multicentric study or not, whether it is funded or not, or whether it was retrospectively registered. P less than 0.5 was considered to be statistically significant. We did not obtain any ethical clearance, as this was an analysis of a secondary data which is already available in the public domain. When it comes to results, so out of, we retrieved about 129 protocols. So out of this, majority of them were interventional studies, about 82% constitute the intervention studies, and most of them were prospective studies. Again, when we look into the specific diagnostic category-wise, major depression constitute the major chunk of the trials which are registered in the CTRI website, followed by bipolar disorder, then bipolar disorder, schizophrenia, and other recurrent depression. When you look into the other characteristics, the major intervention type being studied was the usage of drugs, and nearly 50% of them, 50% of the trials registered in CTRI website were a part of a postgraduate thesis. When you look into the funding status, about 50% were non-industry funded studies, and when we looked into the CTRI website, whether it was updated, whether the study status is completed or not, we found that about 50% only stated that it is completed, and roughly 2/3 of the protocols and did not result in any publications. When we again retrieve the publications, there are only 43 publications out of the 129 protocols which we received. And out of this, about nearly 58% of them had protocol deviations, and they were in terms of the sample size, primary outcomes, and sample size, followed by the secondary outcomes. So sample size was constituted the main deviation. And lastly, when we did a logistic regression analysis with the publication status, only one thing was found to be statistically significant in terms of retrospectively registered trial with the publication status. So studies which were retrospectively registered were more likely to get published. So coming to the main findings of the study, so less than a third of the registered studies eventually got published, and more than half that were published with protocol deviations were not at all updated in the registered protocol in the CTRI website. And this was primarily in terms of the sample size and the outcomes. And study completion status was not updated in most of the registered trials, and very few had updated the publication status as well. So this has major implications, like I told earlier. So non-publication of trial or study findings implies a huge wastage of resources, and selective publication of trial results in systematically it distorts the academic literature. For example, when we later conduct a meta-analysis, only the positive finding studies are published. Studies with negative findings are not published. This can distort the effect sizes in the meta-analysis, and later it can have various implications. So this also represents a violation in terms of ethical responsibility of investigators towards trial participants. And we also found that nearly half registered in the CTRA database originated from the postgraduate thesis. And more than half of these 3/4, let's say more than 75%, was funded studies and which were eventually not published. Registered study protocol again was not modified, and most of the publications had a deviation in the sample size. So this has been consistent across literature, even in the Western studies or in the US register, clinical registers. It has been seen that either the selective outcomes are modified or omitted, or there is a selective reporting of outcomes. So, and we also found that retrospectively registered studies were more likely to be published than the prospectively registered ones. Coming to the strength of the study, it's possibly the only study we could retrieve that it had where mood disorders protocols have been studied and the likely publication status has been evaluated. The limitation of this study, it was a conservative estimate wherein we included data up to 2019 only, and major chunk of this 129 protocols which we retrieved, major constituted by intervention studies, and our publication bias could have colored our findings. When it comes to the future implications, there are two major ones. One, in terms of policy and ethical reforms. So we need stricter mandates for to publish completed trials and update them, the protocol deviations in the website. And in terms of improving the research accountability. So linking funding release to the publication and reporting the requirements is required. So finally concluding it, 2 out of 3 mood disorder registered protocols registered in India do not translate into the published research. So this coming from a country like India, where there is a decreased spending on health research and development, raises concerns about the unpublished data and futile patient participation. Thank you.
If there are any questions to the presenter. Do we still have that cash prize for the best question? That's the reason.
Yeah, I have one question. This is CTRL is basically for prospective, right?
Yes, sir.
You also said something about retrospective, I heard.
So CTRA website was established in 2007, sir.
Yeah.
And from 2009 onwards only, they have made that prospective registration mandatory. So many trials which were carried out even previously had registered like it was retrospectively registered. So that's why the data has come like that.
That's why, but it will be all biased in that case.
Yes.
Can you tell us how many of this research was funded and how many were public funded? That could have been one.
So when we non-industry funded projects were about 52%, sir. And studies which were funded by the industry constitute about 30%. The remaining things were not at all funded.
Because we are more interested in the public funded research. Yeah? Any of them? They have an ethical obligation to publish.
Yes. When we tried this logistic regression analysis, what we found was that with respect to the funding status, it neared statistical significance, but we could not do it. So it is something which needs to be excluded.
One question.
Any study which was funded and where negative finding was there?
So here the objective of the study was we just looked whether the study is funded or not, whether it is published or not. We really did not go into the findings of the study, whether it was a positive finding or a negative finding. We just looked at the publication status and the trial was registered. So trial is registered, it's published or not. Only that, we didn't dwell into that. But that's an interesting point, yes. We could look into it.
If there are no more questions, thank you, doctor.
Thank you, sir. Thank you, sir.
Thank you so much. Inviting our second participant onto the stage, again with a round of applause.
Respected chairpersons and the audience who are sitting here. This is the title of the publication, Association of Depression and Cognition in Acute, Chronic and Recurrent Cerebrovascular Accidents. It's a cross-sectional study. It's a primary study. It is cited in the Indian Journal of Psychological Medicine. Stroke is clinically defined as a focal neurological deficit caused by local disturbance in the cerebral circulation. It can be either ischemic or intracerebral hemorrhage or subarachnoid hemorrhage, and it has got different phases. That which is within 24 hours is the hyperacute. First 7 days is acute, then first 3 months is the early subacute, 4 to 6 months is late subacute, and after that it is the chronic. The common neuropsychiatric problems which are seen in are cognitive impairment, depression, anxiety, apathy, emotional outbursts, pathological laughing, crying and fatigue. About 10% of the first stroke and 30% of those with recurrent strokes develop post-stroke cognitive impairment. And patients with post-stroke cognitive have much greater degree of cognitive depression. Those who also have cognitive impairments. Global studies have shown that about 10% of patients with first stroke and 30% of those with recurrent strokes have more of cognitive impairment. And those with post-cognitive depression have higher cognitive impairment than stroke patient without depression, and the meta-analysis are also shown this. And there are several other studies. But from the Indian data, there is not much of enough Indian data on this particular aspect, especially depression association with the post-stroke depression. There is 1 or 2 reports in Chaurasia has found out independently on cognitive decline without considering depression, and Jana was looking only at depression, but there are no studies looking at both. So our aims and objectives is a cross-sectional study, examine the association and comparison of depression and cognitive impairment in patients after stroke in acute, chronic and actually recurrent. Subacute could not be, but that was the aim. Methodology was gathered 30 male and female patients diagnosed with stroke from medical and psychiatry units at a tertiary hospital. According to the eligibility criteria, ethics committee approval was obtained. Inclusion criteria are cortical and subcortical strokes diagnosed by physician, ischemic hemorrhagic strokes involving internal carotid artery and vertebrobasilar or cerebral artery. Then evidence of stroke on CT or MRI of the brain. Then patients aged between 40 and 80 years, both males and females, given written informed consent without any previous severe illness, and ability to understand the questions and all that. Exclusion were people with significant head trauma, intracranial neoplasm, AVMs and aneurysms, and patients with rapidly evolving stroke symptoms, hyperacute we did not consider, with the previous history of severe mental illnesses, and patients cannot answer the pro forma and aphasia. These patients excluded. Tools used were socio-demographic data capture with the latest Kuppuswamy scale updated by 2019, then Barthel index of activities of daily living and instrumental activities of daily living, DSM-5 criteria for diagnosis of depressive disorder due to another medical condition, patient health questionnaire PHQ-9 for depression, Addenbrook cognitive examination ACE-3 in the Telugu version has been used. Sample size determination, as it is shown in this particular slide, the sample size which I have calculated is about 30, because here the P1 is depression is only 0.33. The precision we have taken is about 10% and the power is 0.95. With that the calculation is 30. This is from the literature. Statistical analysis. Normality assumptions for continuous data are tested by the QQ plots and Shapiro-Wilks test. Frequencies, percentages were assessed with categorical variables. One-way ANOVA for group comparisons with the least square difference, LSD, was used for post-hoc comparisons. Spearman's non-parametric correlation was done and matrix plot was also plotted. Significant p-value is below 0.05. Table 1 here depicts the age, Barthel index and PHQ-9 scores across the different types of CVAs. You can see that age means are also matched. Barthel index score is matched. And PHQ only, we find they are matched, but they are all in the moderate depression area, that is between 10 and 14. And table 2 depicts in the ACE3 scores across the 3 different types of CVAs. You can see that there is a difference. The lower score means that more cognitive impairment. So you can find the significant in chronic CVA. On attention and on others we could not find. That is on memory and fluency. On language there is a lower score in the chronic CVA. And visual, there is no difference between the different groups. Non-parametric correlations have been done. Why? Because there are 1 or 2 variables where the Shapiro-Wilks test was positive. You can find that PHQ-9 is negatively correlated with most of the ACE parameters of attention, memory, fluency, language and all that. But significant you find in acute CVA is on memory, language and visuospatial. For chronic CVA, similar type of negative correlation has been seen with all these ACE variables, significant on attention, memory and fluency. Non-parametric correlation in recurrent CVA has also been done, where again a similar type is mentioned, except you don't find any negative correlation on attention and memory with PHQ-9, but on fluency it is positive negative correlation, others it is not significant. This is a matrix plot depicting the same correlations on this particular plot. You can find most of them are falling in on the central line, on the best fitting line. So our study and the discussion, our study find no statistical significance between the different groups of the on Barthel index, and all 3 groups had better daily affliction. There is a study here which has been quoted. Mean PHQ-9 scores were in moderate depression range with no difference among groups. So there is one particular study which has been quoted here also. So a significant correlation was found between higher depressive rates and deficits in memory, attention and fluency, language and visuospatial areas. In descending order was chronic CVA highest, acute CVA followed by recurrent CVA. Such type of relationship has been shown, one of the, this one by Kang and Blomgren. One particular study from India is there, Arunima. Nearly 50% of the stroke patients, even with good functional recovery, continue to have cognitive impairments, and 33% had depression 2 to 3 years later on. But that particular correlation with depression and cognition has not been seen. There is one meta-analysis which has also been quoted here. So post-stroke depression and post-stroke cognitive impairment are high in the first 3 months and of the vascular event, and also it continues on. So the conclusions are, our studies show that depression and cognitive impairments were prominent in chronic CVA group even when the activities of daily living were better. Acute and recurrent CVA groups also had these impairments. There is a need to regularly assess for depression and cognition in all CVA patients. It is not regularly done even in any of the hospitals. So regular cognitive and mental status examinations in hospitals and follow-ups, especially functional deterioration, could lead to better management of the CVA patient. Otherwise, these people are getting neglected unless they go into very severe depression. So these are my references. This is a supplementary table, the Shapiro-Wilks test which has been done only you can find in the only two particular variables where the Shapirovil's test is where it is more significant, suggesting that only these two variables are not falling in the range of null hypothesis. That is, they are not in the normality range. That's why we have done the non-parametric test. So, thank you very much.
Thank you, sir. The floor is open for discussion. Yeah, Dr. Ravindra.
Do we have details about gender, education, occupation of the participants?
Yeah, actually, what has happened is our main aim is actually look into that, and we actually from the literature also, the socio-demographic data and all that is not that much different, and we do not also have sufficient subgroups to examine all these issues. So hence that will be only non-parametric comparison. So hence we did not
education status of a person, whether that would have had any effect on this. Also occupation, skill, non-skill, whether that could have had any effect on this. That is my concern.
Yeah, they were all at least primary educated and they could understand the scales and the local language also.
Yeah. So that data would have been better. Then also, how did we rule out from pre-existing any of the psychiatric disorders, let's say depression, anxiety, and any of those things? How were they ruled out? What methodology was adopted?
Ruling out is not actually, we have been, from all the patients who have collected data whom we have seen, and then administered the scales, and then got these values what we have got. So
pre-existing, because they might have had depressive episodes in the past also.
Yes,
so
we have
how
asked.
Have we ruled out?
Yeah.
Let's say addiction also, how have we ruled out?
Yeah, that is the exclusion criteria actually. We have gone into the history and all that, and then we have gone into the case records also, if they had anything, and then that's how we have excluded. So that's an exclusion.
Sir, when you are trying to classify them into chronic and recurrent CVAs, how did you, like, for example, put it into the group of, like, someone is having a recurrent CVA but not a chronic CVA?
Okay. So as I have shown in this slide, this is a classification and there is a reference for this, and this is an internationally followed reference. See, this is the one. So the reference is there here, number 2 is there. So this is how you can classify into the chronic phases. Now regarding the recurrent is actually there is no particular reference for this, but people who have repeated strokes, you can take it as recurrent. So chronic there is some definition, but people have, so that's how you know about the recurrent strokes.
Thank you.
Thank you.
Depression and all that. Is there any death or uncooperativeness?
Yeah, patients who are uncooperative, who cannot comprehend and all that, or those who had aphasia and all, they are all in the exclusions. So, uncooperative or those who have some other problems were not taken into the consideration. Or those who had a lot of limb difficulties and all that.
How did you determine that someone is having a stroke since, like, last 6 months? Like, how did you clinically or by
Yeah, so these are the patients who are actually coming to this particular tertiary center, and depending on, you have the case record. So when you go to the case record, then definitely you know that how long the duration, because stroke is something, is a sudden event, easy to find out, unlike mental illnesses where they can have prodrome and continue on to a particular phase. So it is easy to know about the duration of the illness from the case records.
Okay, thank you.
Dr. Keshav, Hyderabad. Any particular reason for choosing PHQ as a scale for depression?
PHQ is a valid instrument for assessing depression, which has also been used in several studies, especially in these particular stroke patients and others. So that was what was used.
Is a Telugu version available?
Most of these were translated, but there is no published, as far as I know, Telugu version. So this was translated and asked. It was asked to the patients.
Thank you.
Any more questions? So thank you, sir.
Thank you.
very
Thank you,
much.
chairpersons.
And I hope the judges will give their points to the concerned authorities. With that, thank you. We can wrap up the session.
With me on the, just take a snap, one, with the background. Yeah. Me with the background. Right? Thank you.
There's plenty of time. You can take some photos for us also.
Thank you, both the participants. I would also like to thank the chairpersons for chairing this session. So we have come to an end of this session. We'll be back at 3 p.m. for yet another interesting discussion. Thank you, everyone. Welcome, everyone. Welcome, everyone. Welcome, everyone. So, this afternoon, we have an empowering panel discussion titled Dialogue with the Divas. Now, as interesting as it sounds, it features inspiring messages from the women leaders in mental health. So, our distinguished panelists include Dr. Prabha Chandra, Dr. Radharani, and Dr. Purna Chandrika. Moderating this discussion is Dr. Aruna Yadial, Professor and Head, Department of Psychiatry, Father Muller Medical College. Please join me in welcoming these esteemed speakers. And a round of applause, please.
Hello everybody. Today we have with us empowered ladies, Dr. Prabha Chandra, Dr. Radharani and Dr. Purna Chandrika. I request our advisor from Team Samanvi, Dr. Endumati R, to give a brief introduction of the panelists of today.
Good afternoon everyone. I am more than happy and proud to be here and introducing all our prestigious panelists. So first one, can you showing the slides? Dr. Purna Chandrika ma'am, she is a professor, Department of Psychiatry, Institute of Mental Health, Chennai. But apart from professor, nearly 5 years she worked as a director of the Institute of Mental Health. That is the most important thing. To manage more than 1,500 inmates with more than 100 professionals and staffs, especially the wardens and all, it is very, I studied there only, IMH 2002 to 2004. I know how difficult to manage the institute and people there more than the patients. So that is the main achievement we see in Purnachandrika madam. Actually, she is the speaker at various institutions, bar councils of Tamil Nadu and Pondicherry. Apart from that, she was a guest speaker in Guntur Medical College on suicidality in women. She played a quiz master role, and she created mainly employment opportunities for those recovered from mental health issues. And she is very much interested in rehabilitating and integrating them into mainstream society. Actually, when IMH is imagined, the green color gown only with the people, that only remembered. But madam has removed that uniform, and it is her main achievement, we say. And another one is getting the voter ID for the mentally ill recovered people. So that is the two of her major achievements. We are very proud of her. Welcome to the panel discussion, ma'am. We are happy to hear from you. Next one. I'm happy to introduce our mentor, Dr. Prabha Chandra ma'am. Ma'am has done MD, FRC PE, FRC Psychiatry, FRC OG, FAMS. Recently, madam has returned after receiving her FRC OG, the first woman to psychiatrist to receive that. And Senior Professor of Psychiatry, Dean Behavioral Sciences, NIMANS, we all know. And madam is the President, International Association of Women's Mental Health. More than that, we no need any other position to talk. So, welcome to introduce ma'am. Happy to introduce you. Thank you. And next one will be our Radha Rani ma'am. She is a consultant psychiatrist, Surya Hospital, Visakhapatnam. Madam is former professor at Andhra Medical College and former superintendent at Government Hospital for Mental Care in Visakhapatnam, AP. She made substantial contributions as the State Nodal Officer for Mental Health and as the Member Secretary for the State Mental Health Authority of AP. She had done extensive work in child psychiatry, and she played a pivotal role in reinstating the district mental health program in all districts of the newly formed AP and securing the sanction of Center of Excellence for the Institute of by the Government of India. So we welcome you, ma'am. Thank you. So I hand over the session to Dr. Arunaya Diyal for moderating the session.
Just a small announcement. We have a cash prize for the best question after the discussion. So, yes, ma'am.
We are also allowed to ask questions.
Thank you, Dr. Endu. At the onset, from Team Samanvi, I would like to thank all the panelists here for being there with us. We have been inspired by you before, and we expect you to inspire the younger brigade which is there out there. So with this brief introduction, let me just carry on with the questions or the conversations we are having today. The first question would be to all three of you. All three of you, in spite and despite of being very clinically relevant and doing good clinical work, you have also taken up administrative roles. So would you recommend that to the younger brigade of psychiatrists to take on administrative roles, especially if they are women psychiatrists? And do you think that has empowered you more in any way? If yes, why? If no, why?
You're the biggest administrator here, sir.
Hello. At the outset, let me thank Samanvi for giving us this opportunity. And when Madam Indumati Madam first called me and said, it was like I was a little bit taken aback and also honored to be on the stage and with the title of this diva. That's what, and my friends are actually teasing me. So with that, this question has got, that's why I was waiting what the other speakers would say, so that let me also, then I have also add this. This is one platform and one day I didn't prepare anything. I said, let me speak from my heart. So whatever I had experienced and whatever I had gone through all these years and how I landed up here now. So for that question, I'll say it's not for the faint-hearted. I know what the other two speakers will say, but for me, it is not for the faint-hearted. As Indumati Madam gave an outline, Institute of Mental Health is a place by itself. So we cannot compare it to NIMHANS. NIMHANS is a central government institute and ours is a state government institute. And we have the up and down of it. Like there will be some fund, there might be some fund deficit, there will be a lot of issues. So we taking it up, women from the clinical side taking up an administrative work and trying to change or trying to put our thoughts into action will have to overcome a lot of hurdles. And I'm also talking slowly because I'm still in service. I'm still in service and tomorrow I have to go back to the hospital. So, so I'm placing my words and I'm thinking and talking, but till I haven't prepared. So it's not for the faint-hearted, and it'll have a lot of hurdles, and it is not easy, and you have to be prepared to sacrifice our time, and it comes with a lot of work. But at the same time, that happiness and that contentment that we feel. So when she talked about this voting and the dresses that have to be changed from the one color to a different one, which the patients can have the options of whoever gives or whatever government procures, we can, the colorful dresses. So all that comes in steps. So initially when we try to tell it, it will have a lot of opposition, but slowly and steadily, if we keep on doing it, we will get there. We will get there. Would I recommend it? That also I'll tell you an example. So there were many days when I was very dejected, but on one day, with a lot of thoughts in my mind when I was entering into IMH, as to thinking of what am I doing this, why am I doing this, what is happening. So I saw one of my inpatient going out of IMH. He was going for his work. And no one from the outside of the community can say that he is an inpatient of Institute of Mental Health. So I thought, okay, for this person, for them to have this much of place in the community. So we are somewhere a small part of it. And that made me happy. So that if any one of them here has that thought in mind, they can definitely do it. But not for the faint-hearted.
Thank you, ma'am. That was a wonderful answer. I think by taking on administrative roles, you tend to touch lives of people without, expecting anything back from them. And that is the truest gratification a clinician can also have. Dr. Radharani and Dr. Prabhachandra.
Good afternoon, and I thank Samanvi for giving me this opportunity. As Madam said, it's, being a director of the institute is definitely challenging. Like, as clinicians and as academicians, we'll be very comfortable, and as clinicians, we'll be empathizing with the people and their relatives. We can counsel them. All that gives us a lot of happiness. And as academicians, we'll have a lot of students, PG students, UG students, spending time with them, teaching them, naturally will give a lot of satisfaction. All of a sudden, once we go into the administrative post, in some institutes it is on rotation, in some institutes by DPC, depending upon the seniority. And for us also, it is a peripheral hospital which comes under a teaching hospital, like Andhra Medical College. So whenever in the peripheral hospitals, like specialty hospitals, whenever one superintendent completes his tenure, service tenure, once they retire, the senior most professor will become the superintendent of that hospital. That's how I became. There will not be any selection committee or anything like that. All of a sudden, from a clinician to become an administrator, I thought that we need some training. And as medical this thing, we will not have any training in management side and managing financial status or accounts, all those things. It will be a sudden burden on. That's what I felt. it will be definitely burden. But over a period of time, we'll learn everything like. But once we get into that administrative post, we'll not get time to see the patients or for teaching, which I lost, felt very bad for losing my professorship actually. After becoming an administrator, even we try a lot to continue our teaching, but we'll not get time. Especially during my tenure, it was the period which when the AP state got separated from Telangana, everything is new for everyone. Nobody knows in the administration side, directorate side, from government, they do not know what is mental health and who are the in charge of mental health there. Nothing was known to them. And at the same time, a Mental Health Care Act came into act, and they wanted, and the policies have taken, mental health policies were taken around, and everything should be, mental health should be given importance. And for every small reason, they used to call me. I used to run to Vijayawada capital, from Visakhapatnam to Vijayawada on, twice a month, or sometimes to Delhi. So most of the time I was keeping on traveling from one place to another. Here nobody knows what is mental health. We have to tell them everything, and we have to, and at the same time we cannot take any decision. Naturally, they should take the decision, and without understanding entire thing, they will not be able to take any decision. And keeping everything plain, I used to go to Delhi to attend meetings, and whatever they tell, we'll just inform back, that's all. So certain challenges will be there, definitely. But naturally we'll be missing a lot of family time also. Most of the time, like even after we go home, naturally we have to be on phone, we'll be getting phones and lot of difficulties. But in spite of that, I feel that once we get into that post, definitely if the interest comes, and we'll, as women, I think we'll be able to manage well, and that empathy, whatever we show to the relatives or patients, that can be with our staff also, so that they'll cooperate and coordinate with us in managing the entire hospital. Of course, there will be certain lacunae like financial things and all, definitely very difficult for us to manage. Still, we have to.
Thank you, ma'am. Ma'am, Prabha ma'am.
First of all, thank you for inviting me, and such a great opportunity to share the platform with both of you divas. So it's my privilege. Thank you, and thank you, Indu, for the invite as well. So I think, they have covered a lot, and I think that they probably did more admin than me, honestly. My role has been as head of department, and I'm the current dean and the controller of examinations. To me, the controller of examinations is the most challenging part, because it involves a lot of very difficult admin issues, as well as working with students and working with the academic section, making sure things happen properly. But I do think that everybody should have the opportunity and should actually take on admin roles. In fact, I feel that even when you're much junior, you should volunteer for administrative roles, because it gives you a very different perspective of how systems function. I think one of the problems in our country is that for a long time we don't get exposed to the functioning of systems, procedures, clinical governance. We don't have those opportunities till we are much senior. And by then, we haven't learned anything, and then we are put on the spot. So I think if the younger professionals start taking on these roles at a much earlier age, then they are much better equipped to manage. So that would be my, something that I would really emphasize. For example, in places like the UK and NHS, you get so many opportunities. In Australia, even at a very younger level, you get opportunities of managing a unit, being the director of a service, handling certain aspects, which I think gives you a better systems perspective, which, and that is the challenge that both of them are talking. that, you know, you kept seeing patients, you kept doing clinical work, and suddenly you became the medical superintendent, suddenly you became the director. You had no idea how to do, like, what is a tender, how to open a tender, how to, you know, negotiate with people who come and, you know, offer the vendors. I mean, there are so many little things that you need to understand, and people are looking at you because you're the authority, and you have to learn from scratch. So my suggestion to the younger generation is to start off very young. Any opportunity you get to have admin roles, don't think this is boring, this is, you know, non-clinical, it doesn't give you that much of a kick, that much of a joy. It doesn't. But it will also equip you for further roles. At the same time, I would also say that even in associations, societies, we find that women are taken as tokens, and especially in India, and also they take themselves also, they don't sort of apply for too many higher positions. Only if there's a reserved for women position, they feel a bit more confident. So there's a lot of the imposter syndrome in women themselves quite often, because that's how they've been socialized, that's the culture. And I think so that also holds people back. So trying for positions, applying for things is something which is very important, and that's when you start talking about yourself. You know, we as women, we hesitate to talk about ourselves. If somebody asks you, please give me your CV, you'll say, no, this is too less, and you know, you kind of don't really want to put yourself out there. It's very hard for us to project ourselves. And I think if you apply for positions, then automatically you have to sell yourself, sell your abilities. And I think that's when you recognize that you're as good or better than many of your contemporaries. So I think it's that's the charm, that's the joy of holding an administrative position. And to me, I remember when I was taking over as head of department of psychiatry at NIMHANS, part of me was like, how will I do this? You know, because it's a very male-dominated department. There are even now very few women in leadership positions. It's just 4 or something faculty. And nobody you can really sort of, you know, there was only one role model. We all had Dr. Shobha Srinath. Other than that, we didn't have any role model. She was in child mental health. There was this huge department. How do you negotiate with these men who don't agree on anything in any departmental meeting? You know, there'll be fights and you'll be like, what are you doing? But I think it was all about learning how to conduct a meeting, as simple as that, you know, how to resolve conflicts. I mean, I learned conflict resolution so much, because there will be conflict, there will be dissent, and that is how you grow. You know, you can't have everybody saying yes, and just because you're a woman, nobody is going to sort of say, she's a woman, let's give her cut her some slack. So you're going to be on the spot. So I think that's something that I learned over time. So the other big thing which I wanted was that younger women should have role models. And I think it's very important. And I know that so many women will come to me after meetings and saying, ma'am, why was there no speaker who was a woman? Why is there no, executive committee member or president where are you all? Why don't we see you? You know? And that to me was very important, that it's important for the next generation to know that you can hold leadership positions, that you can be at the helm of affairs, and still have fun, and you know, and do a lot of things. So it's not like it's going to spoil the rest of your life. But I also want to say that, you know, I know you're going to ask a question about, you know, the journey of reproductive health. But I also want to say that the leadership positions come at a time when women go through perimenopausal and menopausal phases. And that's a huge challenge. And I think people don't recognize the relevance and importance of those changes when at work, when you're in senior positions. There's a lot of all that also happening. You know, there's many things happening in your brain. There's many things happening in your body. And at the same time, you have to be delivering things. So I think that's another angle to it, so having a very good peer network, I think, is important. And yeah, that's my response.
Thank you, ma'am. And we thank all of you for being, walking the talk. And we get to stand on the gate of shoulders. We don't have to be the pioneers that you have been. with that question, I will move on to a little bit a politically sensitive question right now riling the world also. With biological reproductive years in a female overlapping with the same career advancing years. So there has been a lot of clamor in the world that why women are not keen on having babies. So the answer to that and your thoughts on that, and how do you think the situation can be made better with the increasing number of women choosing the field of psychiatry?
A lot of questions in that. So there was an article in Times of India last week where it talked about this marriage penalty, where the female workforce has dropped down to 13% post-marriage, whereas the men's workforce is climbing up and their wage also increases. And there is also this study which said that in that same article, the GDP rises to 51% if the female gender wages or the workforce joins it. So, and they also say for women, as we keep saying, it's a triple tragedy in terms of females with mental illness, getting married, being a female, getting married, and having a mental illness. In the same way, otherwise also, it's like being a female, getting married, having a baby. That itself, and that, I don't know how many female postgraduates here. I can relate to the stories of sometimes on compulsion of their in-laws, or even if they don't want to have a second baby, they'll say that we want to finish the course. But there will be compulsion from their side to have a baby as soon as they join the course. So there are a lot of times the choices that we make depends not on our interest, our wish, so it is more of others' wishes, what others want to do. And that's India we are in. Maybe slowly it's changing. We talk about freezing the woman, freezing and maybe having a baby later, which maybe can be done for the rich, but not for the poor or middle socio-economic status. So unless otherwise there is we have to talk more about this gender equality wherein women have to. But that also talks about, Tamil Nadu government gives us a 1-year maternity leave. I don't know about here or the other states. So that is actually addressing these issues. So more of these policies wherein women can have stay back and continue to be in the career, wherein the policies help, will make sure that this goes on. Maybe also a shift for women being a little bit more flexible. Now we have this NMC wherein we have to keep it there at 8 to 3 or 9 to 3 or 9 to 4. Maybe a little bit flexibility on that part, wherein, because when as an administrator, before this came in, as Madam talked about conflict resolution, there are people who will walk in a little bit late, but they'll continue and stay and do the job. But there are people who turn up on time, but the job won't be done. So this flexibility can be in terms of everywhere. So if more of flexibility and more of maybe having a crush in the workplace, all these policy changes can bring about a change in it. That's my...
I think for that, the answer in the first question answers that. If more women are in administrative roles, they are more empowered to bring in policy changes. So with women ending up having an ovarian penalty or a reproductive penalty, what would be your take on that?
Like this age of joining into postgraduate courses and the age of marriage and childbirth all coincide at the same time. And usually, naturally up to post-graduation entrance, they'll be working hard, and at the same time they relax, and they also feel that there's the time to have children. And mostly we'll be seeing after joining into post-graduation courses, they'll become pregnant, and sometimes they'll not get any leave or anything, so they have to forego their exams. We'll be seeing many people that they're foregoing their exams, like again after 1 year or so they'll be coming back and taking up the exams. And even in the otherwise, like after completing post-graduation courses, once they join into their either as a consultant or assistant professor, then then also, like government policies are there, like in AP state, there are, now they have increased to 6 months, I think. Previously, as we were as assistant professors, we used to get only 3 months of leave, maternity leave. And now it is increased to 6 months. And there is a childcare leave which is being introduced recently, and that is for 2 years, but that cannot be taken at a stretch. Like once in 2 weeks, not more than 2 weeks for 2-3 months, like that. So childcare leave is there. Those are all government policies which are helping people to continue in career. But for post-graduation also, if they can give 3 months of maternity leave with extension, like they'll be coping up with things, and definitely they need a family support to continue into either in the career or like continuing their post-graduationship. And you were telling that women in the administrative, this thing can be changed, having the policies. But these are all the policies which are to come from government side. As an administrator to the institute, we cannot implement anything. Only thing, as madam said, we can be flexible to some extent and give them. But from government side or organizational side, whatever it is, from a central institute or everywhere, from the organization side, there should be some policies like they get a shift system or flexible timings, or they can have a paid leave for few months so that they can work later. Compulsory, they can join back and they have to continue, something like that. And having a daycare or something like that within the organization itself, so that they'll feel comfortable and they can visit the baby once in few hours at least, if it is within the campus. They'll get some time. Such policies, if they can bring, then definitely it will be advantageous for the youngsters who are in career. Thank you.
Ma'am, your inputs.
So I think I feel very, very strongly about this, because I think if, first of all, a woman is not defined by her, the fact that she's a mother. That's one of her many roles. And if somebody chooses not to become a mother, then that's their choice. And I think the choices are very important. That's number one. The second is, it should never be called a ovarian penalty or an ovarian or a reproductive penalty. It should be, in fact, the other way around. It should be an ovarian reward or a reproductive reward. You should reward women for adding to society, and when anybody says that, oh, she'll go on maternity leave, we are recruiting her now, and she'll, look, she's pregnant, within 2 months she'll go off on leave. I'm like, she's doing something for society. Having a baby and bringing a baby into this world is contributing to society. So if you people have to do extra work for that, then think that you're actually supporting to enhance society, and don't feel resentful about that. So I think that women should actually be rewarded for doing what they're doing. And that can happen through many of these schemes, but it can also happen through other ways, in the sense that, increase the age for women to apply for posts, for example. So if a woman takes a break for 2 years or 3 years after her MD or whatever, then it should not be the same age cutoff for a man and a woman, because she may take a childcare break for some time, and she may need that time to, focus on the one hand, we say that, childhood is the most important, early childhood interventions and, preventive work. On the other hand, we are kind of not trying to support the woman. Like, it's such a paradox. So that's one thing. I think that as much as possible that the systems support women during this period is important. Second, I think we should have more paternity leave for men. Because why is it that men are not able to equally participate? Because they also don't get leave. So many countries are giving paternity leaves up to 3 months for men. So increase paternity leave. Automatically you'll find that women will be able to manage better, because after all, it's a parenting role. Either can do it, except for the breastfeeding part of it. Everything else can be done by a man. So including, like, you go to airports, so the child changing rooms are near the women's toilets and they're not near the men's toilets. Simple things like that, where equitable distribution of childcare, because that the whole issue is childcare. You know, so I think these are certain things which we need to change our mindset about. Give the women that little bit of, advantage, that because they are contributing to society by choosing to be a mum. Improve the involvement of fathers. Glorify fathers also who cannot glorify, but at least acknowledge the involvement of fathers. Right now, I know a lot of my women colleagues will say that childcare, nanny is not come, my problem. You know, maid has not come, my problem. Handling mother-in-law's emotions, my problem. You know, because I need somebody to look after the child. My job is less important than my husband's. You know, so in so many ways. So I think that whole culture needs to change. And I think it's going to be more and more like that. We are going to see it. And if a woman decides that this is not for her, then I don't think anybody in society should, look down on that as well. So let's talk about reproductive reward and ovarian reward rather than penalty is what I would say.
Definitely, ma'am, definitely.
I think most of the women postgraduates who complete, they don't practice in the evening. The clinical practice also, they cite reasons of looking after the family. Where the men who will be doctors will look after the clinic, and our female force will stay at home. That is also happening, and we are seeing. So that also has to change.
With the keeping in the global trend, India is also following the same trend where more women are choosing the specialty of psychiatry. Your thoughts on it, and also empowering messages to the younger tribe of women psychiatrists who are choosing it as their specialty.
So for this question, I went to IJP and I was searching for women psychiatrists. In 2010, there is an article which has come. After that, there are no articles that has come on women psychiatry. Mamta Sood has written it. And in that, she talks about at present, and again doing a Google search, I think 15% they are saying women psychiatrists. I think that number, nowadays I see only girls who are joining psychiatry. Women only are taking psychiatry more. There's a research needed to say that the current number of people. But nowadays, there is even a joke around when during examinations, we used to send our male PGs to pick up the examiner from the airport or bringing him from the airport to the... Nowadays, we see that since there are more of female PGs, we have a second look and we think about it and we keep joking. At least for that, male PG should be joining the psychiatry, so make our jobs easier. That's a usual humor that's going on. So then in that article, there were few women, and in that it was said, from 2000 till that time of the article, that was in 2010, no woman office bearer was there. But of course, after that, we have Dr. Sabita Madam took over in IPS President Tamil Nadu 2-3 years back. She was there. And then we have Dr. Savita Malhotra, and I think there are more office bearers now. And there is even, for the past 3 years back, I called up some office bearer and asked him about what about women who are there. He said now South Zone has brought about this women specifically for the past 3 years. So, and Samanvi is there and we are all here. So definitely we are taking it forward. And as for the why women take up psychiatry more, I think they think there are lesser number of... Earlier there was always this, when I was about to join psychiatry, the one thing that came up in everyone is this violent patients. How will you handle the violent patients, the aggressiveness, and how will you... And also there is this generalized talk whenever you say I am a psychiatrist or we are going to take up psychiatry, they'll look at you as though you are different. And they'll say you psychiatrists are all different. Even in UG batch get together, when you say the psychiatrist, they'll have this laugh, which will be like a little bit of, to the nature of, as to why that thing has to change. So, and all that, and being from Tamil Nadu, yes, we have had Dr. Sharada Menon Madam, and I've had the honor of being around with her, and she was quite active. Till her 90s, she used to come around, she used to be so very, so seeing her being interested in rehabilitation. So I think she motivated quite a lot of people. in bringing. And nowadays, women taking up psychiatry is like that flexible working hours, the lesser amount of emergencies, which they say maybe we can put a phone call and say admit the patient or tell the friend to take a look, and tomorrow we can walk in and we can have treat the patient. So I think that thought has come around, like dermatology. Psychiatry also is taking a higher place among the women workforce to say that we can choose. We can choose a timing. We can choose when and where to practice and not be exhausted. So unless otherwise we are an administrator. So that trend is there, and that is bringing the women are becoming psychiatrists more in India. And of course, foreign countries, there was in that article itself, it talked about Canada and US, there are about 45% women. But here, the exact number, I think we have to take a recheck and do a lot of research on that.
Currently, ma'am, it is standing at around 57% of PG residents globally are females. And the same trend is being followed in India, maybe in tandem 10 years later on. It is following the same trend. What we found when we did a research for the Samanvi Symposium is we are bottom heavy, and at the top there are very less men, and we are coming in more quantity than quality, because wherever decisions are to be made, wherever policy is to be taken, there are less females. Like Pratima Murthy ma'am, who gave the keynote address yesterday, noted that other than her, there was nobody on the stage in the whole of IPSOCON. So these kind of things keep happening, and Madam pointed out, only reserved seats we are keeping for females, and in the general part, no, again, leadership positions are being taken by females. Maybe that Radha ma'am and Prabha ma'am on this.
Coming to the women in psychiatry, like as you said, general women joining into all courses have increased, especially if we take the medicine in UG. When we were as students, only 20 girls used to be there out of 100 batch, 80 would be the males. Now if we go for teaching 200 batch, only 40 will be boys and all the other 160 will be girls. So in everywhere that is like that, and even in PG courses, all the toppers are women. They're, except in gynops, in all the other branches, women are joining. Gynops, they're not preferring to take mostly. But again, it has they have increased, but in between, they never used to take it as a choice to join in gynops, because it's a very difficult job for a woman to take care of both, like into family life as well as the professional life. So many stopped joining into gyno post-graduation. I have seen few people saying that. And of course, it's welcoming for the younger generation to join in psychiatry, more women in psychiatry. When I joined into my post-graduation, Dr. Jaya Nagaraja was the director of my hospital institute. And then she worked as a IPS president also. And prior to that also, there were two women before her. I think one was Ajita Chakravarti, and the other was Professor Roshan Master. I met her as a postgraduate when she was after that presidentship, and few more like Deepali Datta, and only 4 or 5, like we can count on fingers, who worked for IPS since 1976 or so. And then after that, there was a huge long gap. And now they're becoming, again, contesting. And still, now with so many women in the psychiatric society, I can say it is very less number in the IPS. So what the, younger generations, choosing psychiatry is good, but at the same time, they have to be more empathizing. And other thing, what I suggest them is they have to focus on research work. Now, with technical advances, they have scope to do that. When we were postgraduates, if we want to present a paper or publish a paper, to get the material also, we have to go to somewhere to get the material. Material in the sense, the literature. To get the literature, we have to move from one place to another. We used to come to Nimhans to get the material, literature and all. So like that, now that is not needed. So that is easy for them to take up this paper presentation, publications, and to get into research work, and also into the IPS executive thing. Okay.
Thank you. Rama ma'am.
So I think like what Dr. Radharani mentioned, generally girls are more in medicine. So it's a reflection in psychiatry. It's a reflection of what is happening in the undergraduate course. It's just a natural consequence of that. In fact, if you look at, so in NIMHANS now, we have 115 courses which we run. A large number are in critical care, DM, neuroradiology, neurosurgery, neurology. And it will be very interesting for you to know that a large number of DM candidates are women. In fact, 70% of them are women in places like critical care, neuroradiology. In neurosurgery, this time we've had 8 girls, you know. So I think what is happening is that we are breaking those barriers. No, now there's nothing which says that this is a male-dominated field or a female-dominated field. I think by virtue of the fact, which was what was predicted, that if you increase the number of women in the workforce, in the sort of basic levels, you will see a change. And psychiatry is that way, you know, in a bit of an advantage. Like most of our male colleagues are fairly empathic and nice-natured and things like that. So we don't really face too much of a problem. Whereas people who come to neurosurgery, gastroenterology, some of those other surgical branches are finding it a big challenge, because these specialties have not had, conventionally have not had women. The men don't even know how to behave with them. And every other day I get a complaint from either side that, you know, the men, they don't know how to behave with the women. So these are learnings which are happening, you know. So I think in that way psychiatry has been at an advantage, because psychiatrists have always worked in multidisciplinary teams. When you train with social work, psychology, so you kind of know some of those things. So I think in that sense, it's just a natural consequence. I think it's great. Eventually, I'm sure people will come into leadership position. It's only a question of time. You know, of course, I mean, research is one part, but the more I look at the way, you know, medicine is practiced in India, psychiatry is practiced, I think we all need to also be part of other group systems, you know, not think that only having so many papers or so many publications or doing something highly scientific is very prestigious. It should also be about how you can be a very good leader, how you can be an entrepreneur. We have several among us who have, you know, who are heading organizations, who created organizations, you know, women. And that's fantastic, because then you created something very new. So I think it's important for women to also recognize they have many strengths. And if they're coming into psychiatry, they can actually be, you know, really very good in several spaces. You don't have to necessarily compete in the same area, which requires a lot of, if you have that time and funds and all that, that's fine. But there are other spaces you can occupy and be equally influential and actually make a difference. So I would encourage that more women come into psychiatry, and I think that helps men also, and that helps women also. So that's what I think it's a great sign.
That was a very inclusive answer, ma'am. Thank you. We are coming to the end of the session, where I would want each of you to give a take-home message to the younger tribe here, not just to the ladies, to the men and the women, towards women empowerment. After this, we will be taking questions.
Okay. So from my heart. So today you are calling us divas and all that. So on one day we are diva. All of us are divas. And on some days, doing an administrative work, from my experience of past 4.5 years, suddenly one day a charge popped up against me. So that was the worst charge in Tamil Nadu government service. So I had to fight for 2 years to end that charge. So not always you will be gifted with bouquets or bouquets of flowers and meeting and panels like this and being asked us, but there will be a lot of fights and battles on the way. And also, at the end of the day, it's a man's world. So viewing a female leader and a male leader is definitely different. And Next point I'll always say is always have your, don't lose your touch with your friends, family. The family, whoever it is, it could be your friends, it could be someone whom you are in touch with, because they'll help you keep you grounded, and they'll be with you in through times of distress, and also they'll be the ones who will say that even if the whole world says that you are wrong, and they won't believe us that we have done wrong, and that keeps us going. So always don't lose that touch. So have time for you. It's not all work. Keep that work-life balance. Even whichever position you are, wherever you are, keep that work-life balance and take it day by day.
Both of you, ma'am.
So, what I would like to say is that there is this myth and misconception, and people will say it, that, oh, two women cannot get along with each other. You put two women together and they will fight. I want the younger people to completely refute that particular myth, and that's one principle I've always worked by, that I will support my women colleagues come what may. I will never say anything bad about them in public or to anybody else. I will not criticize them. Not that they cannot do wrong, but to have that solidarity, that female solidarity, is very, very, very important. And to break those myths that, you know, we don't get along with each other, or we're always competing with each other, or talking nasty about each other. I think that's something that we need to break completely, and that's something that I constantly live by. And I'm very careful, you know, not to criticize somebody's dress, not to criticize somebody's way of talking, or to be backbite. I think female solidarity and networking and strength is very important, and I would say that that's one message I would like to give the younger women colleagues, that be there for each other, and make sure that you put up a very solid together front, because that's extremely important.
Definitely, ma'am.
After my colleagues speaking too much, after that I have a very little to say. Like, what I say is, like, take help from others, and at the same time give help to others also, your own colleagues or whatever it is. Especially being in a psychiatry, like in the initial stages of our psychiatry practice, we feel very much tired, exhausting, definitely. Once we get into that, we'll used to that. At that stage, many people will say, my God, we are unable to cope up with this psychiatry. Many postgraduates I've seen. It will be exhausting. But definitely once you know how to come out of it, once you're out of the situation, you should know how to relax, how to come out of it. And like sharing with friends, talking to friends or to the family members, taking support from them whenever need. That will help them a lot. In the similar way, you can help others who are joining new. You can help them by supporting them. That's what I wanted.
Definitely, ma'am. With empowering ladies, empowering others, probably when women lift up other women, there's the answer to a lot of questions. Now the stage is open to questions from this. Remember that there is a best question award too, so ask your questions. Please introduce yourself beforehand so that we can mark the questions also. Questions can we take? Okay.
Hello, good afternoon, all the panelists. First of all, I'd like to thank Samanvi for such an interesting and inspiring discussion, and with the very inspiring panelists today. I'm Dr. Sana, and I want to ask this question, like I want to ask the panelists' take on the menstrual leave. Like few of the sessions and boards have this discussion, so I want to know the take on that from all our panelists today. Thank you.
I think that for many women, having a period can be a very distressing time, can be very painful, can be, they need some time off. So I personally feel that it is good to have been given the option of having menstrual leave. I'm quite sure that women will not misuse it. You know, women, most girls and young women and older women are quite ethical about what they do. And I think those women who need it should be given the opportunity of getting that time of rest or time off so that they can, because I have seen women struggling. Um, Having said that, it's also equally important to have enough women toilets, clean toilets, sanitary products available freely in hospitals and places of work. I mean, all of that have a place where they can rest. So even if you want people to come, then you have to provide the facilities which can enable a woman who is having a difficult time to work even for a few hours that she can work. So I think it's about creating that kind of an environment, not just leave or no leave. Because just giving menstrual leave doesn't absolve you of responsibility of all these other things.
Thank you. Thank you.
Hello, ma'am. This is Anusha. My question is, how do we tackle internalized misogyny among women itself? So, among women, there are many who have rigid ideas, and they can even sometimes perpetuate misogynistic beliefs. So, how do we tackle that?
How do I tackle it? You don't have to go and tell them all this and also try to do therapy and all that. That doesn't work. It will create the rift more. Easier one is, if possible, stay away and stay away, and your life will be peaceful, and our journey will be at no risk of any further engagements with the other person. But in case we have to work in the same place and day in and day out you have to see them, then if the other person is in the position of power, we have no other way than to adjust and make sure that you go along without not much of hassles. Otherwise, my initial one, stay away.
It's a very good question, and I think it's a problem. I completely acknowledge it. I think it's related to patriarchy and generations of patriarchy, which is going to be very hard to remove. I'm hoping that with the new generation of so many young women psychiatrists, there are many, it's not just misogyny, there are so many other biases also, right? About sexuality, about so many other things. So I think it's all these biases within us. I think having sort of reflective groups, we have two people at the back who run Ballant groups, Dr. Arun Kishore and Dr. Matthew Verghese. And I think having groups like that, which kind of make you reflect on your clinical practice, on your teamwork, on the way you are towards your patients, because misogyny is not just with colleagues. It can reflect on patients also, the way you label patients, the way you talk about women, patients who come to you for help. So misogyny can come through various ways, and I think just creating that space for reflection and discussing it openly is very important. But my sense is that as patriarchy comes down, this will also come down.
We have time for one more question.
Life balance. Work-life balance, ma'am. That is the thing. Regarding you told about the ovarian penalty or the whatever the uterine penalty, I think why don't we prioritize what we want in life? That is what. See, we have to cross many phases, right? About a PG, then getting married, about our motherhood. When you say about children, it is parenting. The mother plays a very important role rather than the father. That is, I think in the Indian scenario at least. So why don't you prioritize what do you want? And we'll have to stand for it after that. That whatever you want to career, whatever might be the thing. Might be there is a small break. I don't think so. That is not going to not empower us from becoming a career-oriented female. Because everyone would have faced that. That 1 year or something like that, I think, why don't you prioritize that thing? To say that we need... that is not at all required. That is what that I am telling you, ma'am. So prioritizing in life is very important. What do you want? I want the comment on that, ma'am. That is what I am asking you.
It's more of a comment than a question. So
Maybe I think it's all about choices.
Yes, ma'am.
Every woman, every man is, entitled to their choices. If they choose not to have a child, that's their choice. So I think it's something, and I think that both parents have an equal role to play in a child's upbringing. So I think the unnecessary burden on the mother should actually come down. It should be equal parenting.
And also the men should be educated about the empowerment of the women, ma'am. Rather than women speaking about women, I think that is more important, because sometimes it happens so, and it becomes a family when it does that. Okay, right, when the female leaves or when she wants to go and for a conference or something like that, I think the family oughting to be taken off. So they should be also educated to empower the females, sir. That is what I wanted to
Thank
tell.
you, ma'am, for that comment. We are grateful to the people who are there, both ladies and men. We need all of them for women empowerment. I think we are run out of time, and now we will be closing the session. Thanks for active participation. I thank the panelists once again for being there with us.
Thank you very much.
You will announce. You have any other choice? Anusha. I think the best question, with the consensus of the panelists, I didn't take much of their consensus, I just took them along, goes to Anusha, who talked about internalized misogyny. Her name, did I get it right? I don't know. Ma'am, please. Stage, ma'am. I request Dr. Endumati to hand over as a part of a memento, an endeavor which we did from Samanvi, where the whole of content creation was done by women. We empowered them by creating academic opportunities for all women psychiatrists. The editing and the authorship, everything, the whole of content creation was by women. And we thank the whole of EC of South Zone IPS for giving us this opportunity and carrying it to fruition.
of repeating futile investigations of increasing complexity and cost, and then telling these people there was nothing wrong with them, it's something which still happens, Balint taught active search for causes of anxiety and unhappiness, his own words, and treatment by remedial education aiming at insight, rather than medication aiming at the suppression of symptoms, is how he saw it. These people met in groups, and such groups provided opportunities for GPs to discuss with each other. At that time, remember, the number of psychiatrists, even in the UK, was very small. To discuss with each other and with him, that is Balint himself, aspects of their work with patients for which they had previously felt ill-equipped. Since Balint's death, the continuance of his work has been assured by the formation of Balint societies, and the Balint Society exists in a number of countries across the world. We are on the anvil of starting a Balint India Foundation, thanks to Dr. Arun Kishore. More about Arun a little later. The Balint approach does not disavow medication and other physical modes of treatment. We don't say that those are not important. But clearly, in a Balint group, the focus, clearly in the forum, to discuss, this is not the forum where we would discuss these. Rather, the focus is on psychodynamic aspects, including intrapsychic ones. What hang-ups do you have within yourself? These are some of the issues that could be handled, could be addressed. To help the healer improve his or her skills with a given case, as well as generally improve skills. Vicarious learning also occurs to other members in the group, while the presenting person focuses on her or his improvement. Now, Balint groups are formed with not more than about 15 members to a group. The number varies quite a lot, but in order to give everybody a chance, it's important to restrict the numbers. There is a trained leader who is the first among equals. He does not become a dictator of any kind, to ensure smooth running of the group, ensuring that each member gets a chance to participate. And it is encouraged that everybody contributes to the group. Meetings are scheduled at a fixed frequency, twice a month or weekly once. The group that I am a part of, thanks to Dr. Arun Kishore, we meet on 2 Saturdays in a month, which are fixed, and last for about 1 hour on each occasion. Very rarely are meetings postponed or rescheduled. Nowadays, the groups, and that's the only relevance to the theme of the conference, we meet not only in person but also online. Our group tends to meet online. The mode. What happens in this group? Without pre-scheduling, the leader invites any member to present their case briefly, and we are very accommodative within a group. If one person has a case, then that person, whoever comes up first, generally goes ahead. But if somebody has a burning problem and says so, that person is given precedence. To present their case briefly, then state what the hold-up or hold-ups might have been. The presenting member, after clarification sought from the group, mutes him or herself or sits facing away from the discussion led by the leader. The presenter does silently listen to the discussion going on but does not participate at that stage, then returns after being called by the leader to respond to the group's inputs, especially if any new insights have been gained. The leader then brings each session to a close at the decided time interval, usually an hour or an hour and a half. Needless to say, confidentiality regarding the case and the group dynamics are vital, and they are well maintained. Generally, there are no case or discussion records. We don't keep any documents, except in the realm perhaps of research. Very occasionally, a Balint group may not take up a case for discussion, but may delve into discussing practical psychodynamics, new insights or difficulties in therapy, without any overemphasis on theories are important, but we don't emphasize those, or any schools of I am Jungian, I am Freudian, I am behaviorally oriented. That does not come into the picture. What is the practical problem and how are we practically going to handle it? So no emphasis on theories or schools of psychology or psychotherapy. This is what a typical Balint group looks like when they meet in person. I couldn't get a picture of a group online. The aims of the Balint Society are to focus on clinical practice in medicine and psychological disciplines, with special reference to the health professional, patient, or client relationship. We disseminate this knowledge beyond the society for improvement of healthcare to the public at large, which has not yet happened in India. promote and advance research, studies, and training in the psychological aspects of healthcare. Today we have the following format. After my brief introduction, we have balanced groups in postgraduate training, a presentation by Dr. Arun Kishore, who is the most experienced among us in this modality. And experience of balanced groups in training in India, Dr. Shivakami from Chennai will address us on this. And then we actually have a demonstration balanced group happening over here. After which, Dr. Arun Kishore will, who is our first among equals, lead a discussion. Thank you, and over to Dr. Arun Kishore. Let me just introduce Arun. You have the slide for him. Dr. Arun, needless to say, is an alumnus of NIMHANS, a consultant psychiatrist at Sussex Partnership in the NHS Trust at the UK, medical teacher since 1983, been in psychiatry since 1990, interest in child and adolescent psychiatry, currently adult neurodevelopmental disorders, group analysis, reflective practice in teams, and that was a term left out of my presentation, reflective, that's the most important term, which Prabha used earlier. And balanced groups are his current areas of interest. Supporting doctors with professional stress is another area of his interest currently. Over to you, Arun.
Thank you, Ajit. Could I have my slides on, please? So, my task over the next 7 to 8 minutes is to present to you the relevance of balanced groups in postgraduate training and to try and convince you that it is relevant. So let me start with a question. So, and the way I'm hoping to do this is by asking a series of questions. And these questions are to myself, so I'll be reflective and I try to answer that, which is what we do in balanced groups. The next slide, please. So if I ask a question that in psychiatry training, it should help develop well-rounded psychiatrists who are knowledgeable as well as empathetic and reflective in their interaction with patients, would there be anybody in the house who disagrees with that? I suspect not. But if I emphasize 3 words in that, knowledgeable, yes, we do impart knowledge, but how do we impart empathy? How do we impart being reflective? What part of the training ensures that? I'd like you to hold that question in your mind. The next slide, please. So, Ajit has made this very simple. I will not stay on this slide. He's spoken about balanced groups at length and also spoken about the processes. Could I have the next slide, please? So, balanced groups, do they exist in postgraduate training? Yes. So, in the United States, 54% of training programs, psychiatric training programs have balanced groups. It's higher in the UK, where it is mandatory that every first-year trainee attends sessions and they are assessed on that. It's the first part of psychotherapy training in the UK. And similarly, it does happen in other countries. You'd be interested to know that Japan has a balanced society and they have balanced groups. This actually answers the question, is it a purely Western phenomenon versus a Eastern phenomenon, or will it work in the East? The next slide, please. So, a second question that might come to the mind of most heads of departments and faculty of psychiatry departments is, we already have a case presentation. And isn't that enough to impart this sort of a training? How do case discussions compare with balanced groups? I'm sorry for the slightly small lettering on the slide, but essentially, in a case discussion, the emphasis is on the clinical aspects of the case. And the goal is to improve the diagnostic reasoning and medical knowledge and clinical management skills. Whereas the focus in balanced groups is on the emotional and the relational dynamics of the doctor-patient relationship. If you look at the content of case discussions, it is prioritized, the content is prioritized, and the emphasis is on a systematic presentation. In balanced groups, the process is prioritized over content, and you'll see that in our group as we go on here. The focus in a case presentation is on peer learning and knowledge dissemination, whereas in a balanced group, the focus is on the participants' sharing challenging cases, and focusing on their personal experience and their emotional responses to a doctor-patient relationship. Could I have the next slide, please? So another question would be, how do Balance groups actually help in postgraduate training? I'm sure these lights are very distracting, aren't they? They are to me at least. Sorry. So we have, and I'll summarize this to say that in postgraduate training, there is research to say that there is definitive evidence for increased reflective activity, there is improved empathy, there is enhanced communication skills, of feelings being supported, and stress reduction. There is definitive evidence for this. So what I'd like to emphasize to most faculty in postgraduate departments of psychiatry is that this is one way to help residents reduce their stress. There is increased self-awareness and personal growth and better management of complex cases. And if that is not an argument to start a Balance group, I have no other arguments. The next slide, please. So what could Balance India do for you? And when I say Balance India, we are all a part of this Balance India foundation. And what we could do for you is, as individuals, if any of you would like to join a Balance group, please contact us. I'll give you the address you can contact us on. We can support your development as a Balance leader, and we can help you to participate in Balance-related events. For postgraduate departments, what we could do is we could support the training and development of faculty or senior residents as Balance leaders and help you to carry that on in your department as a part of your curriculum. We could offer continued supervision if needed. We'd also support setting up of Balance groups in training. So that's our offer for you today. Next slide, please. The question that does come to mind is, will Balance groups work in India? And this is a question I asked myself, Matthew asked himself, and I think 5 or 6 years back, the two of us got together and said, we'll give it a try. So I started a Balance group, and thanks to COVID, this is the only thanks I'll give to COVID, is that we went online. So I started a group about 7 years back, and this was in Kannur, a group of psychiatrists from Kerala. We ran the group for three and odd years, and it worked. I mean, people gave me a feedback that it worked for them. Their approach to cases changed. They stopped thinking of just diagnosis. They could relate to their patients much better, and they did develop empathy, and they started to reflect. And remember, in Balance, the training is to reflect internally. See, most of our reflection is on something. Something happens in your clinic, something happens in your department, you reflect on it. This is reflecting internally, and I think that's important. So that is the first group that we started. The second group has now been running for 5 years, thanks to all of you in Bangalore and you in Chennai, Shivakami. We've been running this group successfully. We have regular twice a month sessions. Dr. Shivakami has been running a session for postgraduates in psychiatry in Chennai. And that will tell us whether it works in the departments here. So I'll hand over to Shivakami in a minute. Do come over, Shivakami. I'm finishing anyway. So we've had various groups. So I'd say that we have about 12 and now perhaps 14 groups that have run in India for the last 5 years. And that is evidence. We'd say we're going to write it up. That is evidence to say that Balance groups do work. Perhaps the format is slightly different. That we will describe later. Next slide, please. So those are the contact details. I leave you here with this, and I'll hand over to Dr. Shivakami, who will talk to you about running a Balance group in a postgraduate department of psychiatry. Over to Shivakami, please. I need to introduce you, I think. Okay. Is your CV on? Yes. So this is Dr. Shivakami. She's based in Chennai. Dr. Shivakami is one of the psychiatrists who does just psychotherapy practice, which is amazing. She's trained she was trained in CMC Vellore and then in Cambridge, and she practices CAT therapy, cognitive analytic therapy. I won't embarrass you by reading too much. Over to you.
Hello everyone. So I'm going to say a bit about my experience of leading a Balance group. So I'm just going to take you through, say a bit about the Balint groups that I've been running at the Institute of Mental Health in Chennai over the past 3 years. So I will be using the Balint Leader Evaluation Form, which is a structured tool that helps the leader collect some feedback about the experience in the group. And I also have some feedback from PGs who have been part of these groups. So I'm sure IMH needs no introduction. So the Institute of Mental Health in Chennai is a very large teaching hospital with a postgraduate training program. And at any given point in time, there are approximately 50 PGs training and working. So all of you here must be very familiar with the postgraduate education system here. So PGs form the backbone of the system and carry out a large part of the clinical work in most teaching hospitals with supervision from more senior doctors. And there is regular clinical teaching and supervision in place. So Dr. Arun was wondering what Balint groups offer over and above this clinical teaching, and I hope to show or share what my experience has been. And there are usually weekly programs in most institutes to support this. So in our case, we started around December 2021, again during COVID, but this was still in-person groups. We started weekly groups. We had every group went to up to an hour. And we had a circumscribed time. So we had specific time allocated by the department for this, which I think was a very important aspect that helped the program sustain. And the group typically comprised of PG postgraduate trainees from across the years. And so like in many other hospitals, trainee doctors work in smaller groups called units. So we had a system in place where people could take turns to attend the group. So overall, there was an element of flexibility that was required to make this activity possible in that setting. So we had group sizes sometimes sort of ranging between 2 and 6, and that also reflected on what PGs, whether they could attend or not, depending on what was happening for them otherwise. So depending on workload in the hospital, availability of PGs in the main center, sometimes they could be posted in other places. And even number of trainees enrolled at a given point in time, because during COVID, we had a lot of impact in terms of admissions. So I have never formally trained as a Balint leader. However, so I'm a trained psychotherapist, and I started using the model to reflect on the doctor-patient relationship. So sometimes, not just the patient, sometimes we might be thinking about a family member who might be involved very closely in the care. And my personal experience of Balint group started in my PG training in the UK. So what we did was to follow the typical Balint group method. And so somebody was invited, so the group was asked someone to volunteer to share a particular experience. And then explicit guidance was given with regards to encouraging the person to speak to the group and not to present to me. And so PGs were encouraged to speak outside the typical case presentation format. And even this turned out to be a new experience for all of them. And then I had the chance to join Dr. Arun's Balint supervision group, which enabled leaders. So that was very important for me to become more confident with this method. So just to quickly share about what it was like. So it slowly started emerging into an experience where there was a lot of uncertainty in the beginning. And this was also from inexperience, both my own and for the PGs. But slowly we started finding a space within that larger system. I think within the group, there was always a temptation to enter into discussions around diagnosis, management, or desperately need a solution for whatever is being discussed. So it was as if there was a constant pushback. So now I'll just use the evaluation tool to think about some aspects. So slowly we were all able to come together, sit more comfortably with uncertainty, stay with difficult situations that didn't have straightforward solutions. And this turned out to be a significant experience in itself, considering how the traditional doctor-patient relationship, the doctor is expected to demonstrate a very high level of certainty, no matter what. So this became a different experience where the doctor was allowed to at least voice some difficult feelings. And then we were able to share the uncertainty as a group, and it slowly started becoming more rewarding. And it was particularly rewarding for me when I saw trainees sort of being very generous with each other and come together as a group. So I think one of the main focus, as it is in most Balint groups, is to think about what's happening to me in that particular interaction. And I think slowly the group started emerging as a safe place to consider and express such reactions. And it was as if a trust developed. And given that new PGs come in, it felt like slowly that got passed on to people who were joining in for the first time as well. So feelings like fear or anger that may not be otherwise allowed in the traditional role of a doctor slowly started becoming just something that can be experienced and then safely expressed. I think this part was a bit slower to emerge in terms of linking back with the particular interaction. And I think attending the Balint supervision groups helped me stay more with the movements in the group and allowed me to become more effective in responding to that. Because I think the temptation is always there to fall into a teaching role. And without being able to stay with, okay, what might be going on right now in this group. I think this has also been a challenge. So there's always that pull also to learn psychotherapy as such. How to do psychotherapy for this patient is a very frequent question, or a clinical dilemma that just needs to be addressed. And I think the other thing we were able to bring in was to think about the wider system, because there are a lot of pressures in a busy hospital. And I think we were able to slowly think about how to operate, including that pressure, having that pressure in mind. And I think the Balint group space started becoming a stable space. And I think we were able to think about the pressure of the workload and many other factors that can impact the space to be reflective. So in a way, I think we were trying to stay with the reality also. So we were finding ways to think about this. And that, I think, allowed us to develop within limitations as well. So this is some feedback. This is what PGs think about the program. I think a lot of them agree that we were able to focus on what was coming up for them in different interactions. And trust is another important element, I think. So they've given some of their thoughts. I'll maybe just read out a couple of them. I think one thing that stood out for me was how somebody said it was a different experience for us to how to go about our own thoughts, feelings while dealing with patients. Makes me think better on how patients might think or feel. Somebody else has said, great initiative, need to explore more on one-on-one sessions. I think that's the other thing. What I saw was there's always a huge appetite to learn psychotherapy, and actually Balint groups can be, or in many curriculums, it is recommended as the first step moving into psychotherapy training. So nothing is without challenges. So I think some of the challenges have been about creating space for this. And there's always the need to be mindful that this doesn't become an additional burden on the trainees. Because I think in most training programs, PGs are faced with a lot. So something about being aware as a leader that this activity can also be exposing for trainees in a unique way. because they're being invited to think about themselves. This is not mandatory in their curriculum. So I think it's particularly remarkable and rewarding to see that there is still interest, but I think it's also a challenge in terms of making it sustainable. So in the last 4 months, specifically, for example, this might be a fluctuating phenomenon, but in the last 4 months, we've had, for example, fewer attendance. There have been competing demands in the curriculum, like research, elective postings, rural postings. So we've made a bit of an innovation. We've tried to move to an online platform where some of the PGs thought if it was at a different time, they can actually make it. I'm sharing this just to show that there might be a lot of flexibility needed to make this possible, depending on different, whichever setting we are thinking about. I think there's a lot of interest in psychotherapy training, and I hope that the making balanced groups mainstream will sort of move in that direction. And I think wherever this is being set up, it's really important to think about resources there. And so I think this is a really nice occasion for all of us to come together and celebrate whatever we've achieved so far. So on that note, I'll end my talk and move into showing you what a balanced group actually looks like.
Thanks, Shivkami. We're going to take questions and doubts right at the end because the organizers have said we have to finish by 5:30 because there's a general body meeting here. So we're going to demonstrate a live balance session. So it's in some ways a role play. So I'm going to invite people who have been part of the balance group since 2020, some of them, to come up here. So there's about 8 of us here, I think. And the balanced group format essentially has 3 or 4 components. The group meets, the leader usually decides, it's mutual decision as to when people are going to meet, and there's a particular time and there's a reminder that's given. So when the group meets, the leader starts by saying who might have a case for discussion. And then if 1 or 2 people have cases for discussion, they come up and talk about cases for discussion. The leader chooses which case will be discussed. Then are we short of chairs? Then what happens is that the person who's present in the case talks about the case for about 10 minutes. No notes, just from what you remember off the top of your head. And then once that 10 minutes over, then the group asks certain questions, whatever questions are there. And then there's a pushback where the presenter is asked to stay out of the group, and then the group, without the presenter, discusses what's going on. The presenter is only able to listen in and watch what's going on, but there's no response at that point of time. And that takes another 10-20 minutes. And then the presenter who made the presentation is called back in and asked to give his or her comments. So that's how a balanced group goes on and end. And a typical balanced group is about an hour, but we'll do only about 45 minutes for time. And so I'm going to, so what I'm going to ask is, we're going to imagine, to make this role play as perfect as possible, we're going to imagine that there's going to be a one-way mirror here. So we're going to darken the whole hall. Can you darken the whole hall? Full and okay, you've got lights here. That's great. No, idu beku. The audience matter. So that's what we're going to do. Usually there's a leader and a co-leader. For today's session, Arun Kishore is the leader, and I think Shivkami is the co-leader. The co-leader basically functions in terms of keeping the group on track, timing. So Shivkami will sort of time us for about 40 minutes or so. So we finish by about 45 minutes, and then we throw it open for the last 15 minutes to the audience. All right? Adu beda.
Hello? Hello, group. How are all of you today? Good. So I'm going to start by just asking all of you to give your name and your profession, and then we'll start. Okay? So introducing yourselves. So would you like to start?
Dr. Bino, Additional Professor, Psychiatric Social Demands.
I'm Arun Kishore. I'm a consultant psychiatrist.
I'm Abhinav, I'm a psychiatrist.
I'm Lakshmi, I'm a psychiatrist. I'm Shweta, I'm a psychiatrist.
Matthew Varghese, psychiatrist.
Sivakami, psychiatrist.
Sabina, psychiatrist.
Ajit Bede, psychiatrist.
So this is just for you, just to introduce us, but now the curtain goes down, and that's one-way mirror. So there's no more interaction with you.
So we have a homogeneous group here today. Could any of you think of a case for today? It doesn't need to be a detailed case. It could be somebody you saw recently or in the past. And there might be a reason why that person comes to mind.
I might have a case if nobody else has.
Okay. Would anybody else have anything urgent to bring? No? Okay. Over to you, Matthew. Please.
So I want to describe a client that I've been seeing over the last 10 years or so, on and off. This is a lady who came to me more than 10 years ago. She was referred by somebody with some depressive symptoms. And when she came to me, she said that she was separated from her husband. She had been married for about 15 years or so. And she had actually come to the child services because her child, who was about 6 or 8 years, had some behavioral problems. And in the course of that discussion, the child psychiatrist discovered that there were some problems and parents were going through some issues with regard to separation. And that's how she got referred to adult services. So when I saw her, she was quite distressed because the child had a problem, and she was psychologically minded, and then she discovered, she acknowledged that it was because there were a lot of fights going on at home, and she had just moved out from her husband's house and moved into her parents' house. So I saw her, and then I took a history, and then I discovered that she was depressed. And she also described that she has an issue with her moods and temper, and then that she would get angry very easily and sometimes fly off the handle, and she had made a few suicidal attempts and all that. And so, but she didn't say, and I couldn't really make out that had caused a problem with her marital life. She said that her husband was essentially, to describe in her own words, an MCP, and he was really not caring about her emotions and her feelings. So I saw her just for some supportive work over about 4 or 5 sessions, put her on some medicines for depression. She got better. She also had some problem with her mother because she had some difficulty engaging with her mother, because mother was very critical of her and said that, see, you are not adjusting to your husband, and it's your problem, and so on. So mother also came in on a couple of occasions, and I had a few sessions with the mother and her. And mother, of course, said that she should adjust. And she got better, and then she saw me for about 5 or 7 sessions. This is about almost 10 years ago.
And then she got better, and then she went away. She lost contact with me. I lost contact with her. She didn't come back. And I think on and off, I got a couple of messages saying, "Hi doc, I'm feeling fine, I'm doing well. Shall I continue the medication?" and so on. So I said, "Yes, continue the medication. Come and see me." Then this year again she surfaced. So this time she came and said, "Hey doc," she sent me a message and said, "Hey doc, I want to see you. I'm again depressed. I'm having some problems in my relationships." So then I said, "Okay, come and see me." And then she came into the OPD and she saw me. And then she said that she was separated from her husband for the last 10 years. A child had now become about almost 12 years, 15 years, and was doing well in school. And she had gotten into another relationship, and she said she was having difficulty in that relationship. And she had said that this new person in her life had said she should go and get her mind fixed. So I said, "Okay, will this person," so I saw her. I said, "Will you," and I reviewed her medication, and I discovered that she was taking some of the medicines. She was not really depressed, she's doing well. She had done well in her job in the last few years. So that's, in that sense, she was stable. Then I said, "Will this person also be able to come in and see me?" So she said, "Okay, I'll talk to him and then I'll fix up a time and all that." And she went away, and then about 2 weeks later, I had her card again on my table. And then when I called out, I found a man coming. So I said, "Who are you?" And he said, "No, I'm the current partner of so and so. Who's your patient?" So I said, "Why have you taken out her file?" He said, No, I've told her that I'm coming and I want to talk to you about her." So I thought to myself, should I talk to this person or not? Because she's not there, and I don't know what has transpired. So I said, "I'm not going to talk to you today, but please come in together and see me." And then I said, if you set up a time, I can see both of you together. So then he went back. He said, "Okay." And then he said, "I want to tell you a few things about myself." So I said, "Okay, you can tell me a few things about yourself." So he sat down for about 10, 20 minutes, and he said, "Doc, I think my partner has got some psychiatric problem, and she's told me she's got a psychiatric problem. She's got depression and she's got mood swings. And I think she needs to get fixed because that's getting into the way." And he said, "I can understand very well because I also had a psychiatric problem in the past. I've been treated for schizophrenia in the past, or something, schizophrenia, bipolar or something. And then I'm well. I'm not on medication. I've gone off medication. I've sort of cured myself, and so on." So I said, "Okay, that's fine. Set up a time and come." And so they set up a time, and then I said, "I can see you online," because it was convenient. So I saw them about 2 or 3 times online. So it transpired that about 7 years ago, 5 years ago or so, these two had met on Tinder. And they started communicating, they met, they got into a relationship. And then about 3-4 years ago, he had moved into her house. It's not actually her house. He was staying upstairs and she was staying downstairs. And she was staying with her daughter. And when I went to the story, I found out that he was also separated from his wife. Now, I discovered that both of them are actually not divorced. So they were separated from their spouses for about 10 years. And his wife, and he also had a child, was about 10. They were living in the US, and he had a chance to go to the US with them and be there. But I think she was a citizen or something. But he didn't go because he had started this relationship. And then he said, "Oh, I didn't want to go," and then I stayed back for her, for this original patient of mine. And he said, I can't get along with her because she goes off the handle and so she said, I can't get along with him because he's too sort of methodical and he wants things done in a particular way, and he's got a bad temper, he's shouting at me, he puts me down, he doesn't let me, lead my life, I want to do, and he just wants to come, and every day he comes down and we spend the evening and the night together. But through the day, he's on his own, I'm on my own. We're both doing our own jobs. Seems to me that he's just coming just to be with me. She didn't say for sex, but for the relationship. He doesn't care about my family. She said that I think my husband is not involved with my family and my child, but he seems to be involved with his wife and child who's in the US because he does things. So he clarified and said that I'm committed to the child, not to my wife. So they went on like that, and then so I said okay. So I said somewhere we had to find some kind of wire media, and then I remember in the last session, he got very angry and he said, "Doc, I don't think you understand that this is again online, so it's obviously not in a. I'm in a safe space. I felt I was in a safe space because he was really very angry, and he said, Doc, you don't understand that, you have to really do something to treat her. You have to really fix her because without this, I'm out of it. I'm not here. So I said, we'll discuss it, and, I said, I'm not here really to fix both of you. I'm to discuss how we can live together if you want to live together. I said, we'll fix up another appointment. So this is about a couple of months ago, and then we fixed up another appointment, and then soon after, next day or within the week, he wrote a very angry letter to me. I think he didn't copy. I had insisted that they would copy all letters to me. The three of us. The mails would be three-way. We would communicate by mail. So this time he wrote to me separately, and he said, I don't think you understand. I think, you are not, so, I mean, he was basically, he was not abusive, but he said that you don't understand and I don't think that you're a sort of, you've got the thing and, I don't think I want to come for session again and this is the end of it. If he doesn't fix the problem, then I'm out of it and so on. And he said, I'm not going to come for sessions again unless she goes and fixes herself. And then she wrote to me and then she also messaged me and said, what do I do? This person is not coming for sessions. He said I should fix myself. What should I do? Should we end? Should we, is there a closing session? Should we leave it hanging? And so on. So that's where I am. I don't really know what to do. I don't know whether I should write to them and say, come in again for a session. I'm still undecided because I'm in a bit of a dilemma, really, because if I write to them and say, okay, come in and talk to me, he said he doesn't want to come in and talk to me till I fix her. And she's willing to talk, but she's willing to talk only if he changes and becomes more sort of amenable. So I'm in a predicament. Should I write to them? Should I get them back? What should I do?
Thank you, Matthew. Shivkami, I'm just wondering about time.
Yeah.
And should we do away with the questions? Should we go straight?
Maybe we'll just restrict ourselves to a couple of questions.
Okay, maybe a couple of questions.
Just a couple of questions.
Sure. So, group, any questions of fact, and could you keep it brief, please? Just two.
Matthew, when she said that her husband was an MCP, could she substantiate that?
Yes.
Fair enough, as long as she could substantiate it.
No, I mean, she said that he was only interested in his job. He wouldn't really care about the child. He would want me to be the traditional wife, in the sense that I would have to serve him food and he would just come and sit there. He wouldn't help in the house. she wanted a more kind of equal relationship. He felt she didn't have that. And she felt that he was emotionless to her and not really caring about her.
Sir, did she tell you about her struggle with the new partner? What kind of issues does she have?
So she said mainly it was his anger and insistence that everything should be done in a particular way. He would fly off the handle and then say, shout at her and scold her, and she felt that she was being treated like a inferior person. He wasn't really worried about her emotions and what she wanted.
Okay, thank you then. I think could I ask you to sort of push your chair back a couple of centimeters if you want, and then, yeah, thanks. You're fine there, you're fine there. Okay, so interesting case, lots of issues. What comes to mind?
As I was saying, I could just think of a couple of scenarios of my experience where I'm not sure whether I'm doing individual therapy or couple therapy. They would initially come as individual. So our focus would be that, okay, I'm going to help this individual or support this individual. But through after some time, we realize that all their problems are related to relationships. And then I've thought of like calling the spouse, talking to them. They wouldn't agree for a formal couple therapy. But then here and there, they would just come, go. And after some time, I would be like really confused as to what am I doing? Because they're neither doing a formal couple therapy, nor they are like following up individual. And I think that's the clarity that, I don't know, we would want to put to them as to why are you here? Is the lady here for her depression? I mean, basically therapy for her depression, or is this relationship work? I think bringing some clarity into this by asking them would help us progress, I feel.
I have a thought. I'm thinking like her previous relationship and this one have a common theme of men not understanding her. So I'm just wondering, it would be to me, it would be like, what is her background? Where does she come from? What experiences has she had that has a sort of almost attracted to her to relationships that sound invalidating without having specific, well, there doesn't seem to be violence in the relationship, but the second partner seems to be very vehement about her needing fixing or her needing treatment. So what is in the relationship that makes him feel that she's the one with the problem? So I wonder about, first of all, the background of these two individuals, and secondly, when she gets irritable, angry, that was mentioned, what is the level and grade of, is it violent? Is it just screaming, shouting, neighbors can hear kind of thing? So I wonder about that also. That would probably dictate how this relationship is going to progress.
I wonder how that might contribute to the dilemma that the presenter brought in about, should I see them, shouldn't I see them?
One more thing is that this man seems to be kind of used to issuing ultimatums, both, to the doctor, fix this or else I end my relationship with her. And, to her also, fix yourself or else, or I'm going to end my relationship with you. So in one way, as a treating doctor or as a treating therapist, I think, like I don't know how the rest of us would respond to such an ultimatum of any sort from a patient, and also like it depends, like as a treating doctor, who is your primary patient? Is it the woman? Is it the man? Or is it the relationship that you are fixing? So what are you trying to save when you are faced with such an ultimatum? Right? Like, is the woman's welfare, not just personally more important, but in this relationship, faced in a situation like this, is she better served by not giving into that ultimatum and saying no, I will take my time. I will take my time with her. You have to adjust, right? Or by not caving in as such, but kind of saying, okay, come back. We can keep working on this. I don't know which approach would probably work better here.
I mean, for me, it felt like it's almost as if there's a huge pressure to choose, like as if like a pressure to choose, as if like sir was being pulled one way or the other. Maybe that kind of reflects what's happening for them. But I also wanted to share how I was struck by how I was feeling. I don't know whether it's something about the way sir narrated or whether it was just the events themselves. It felt like scene after scene there was like a twist unfolding, which was becoming drastic, and it started simple enough but became kind of very, very confusing and exhausting, actually.
I think my first thought was I was just wondering about, apart from this man she's in a relationship with, how was her relationship with others? How was her relationship with her daughter? I think sir mentioned it, not a very great relationship with her mother. And in that context, then, how important is this doctor-patient or a therapist-client relationship to her? Because I think if I were to put myself in this dilemma, that would be the first question I would ask. How important is this relationship to this person? I don't know if it was ever clearly, was it always that this man is accompanying this patient or they are working? I don't know if that was made very clear. And I think that the doctor here, you get the feeling of almost risking yourself, right? If you're giving that invitation to get rebuffed, you're putting yourself out on a limb, and you may end up feeling kind of unwanted in that way. So yeah, I think personally, if I was to answer that question, I'd start off with, what do I think of this relationship? I also noticed that the doctor's assessment of this lady's life was a positive one. Things are going well, not that man's assessment. So how do I introduce this assessment into that conversation?
I personally think the patient has a good relationship with the doctor, and she seems to want to keep in touch with him. For a long time she does, even to say that I'm well. And there is a healthy positive transference over there, and I think Matthew is in a position to continue the relationship with her as her therapist. I'm not sure that I get what exactly the quandary is. But I also noticed that this mother has possibly conditioned this woman into feeling inadequate. And sometimes this plays out in the mind that I am inadequate and I become inadequate in various relationships. I think that is a dynamic I'd pay attention to and try and work on.
I have two observations. One about the lady. The both intimate relations, her mother and the current partner, they both actually told Matthew sir that we need to fix her. The mother actually said that you are actually not agreeing and there is some problem, which would allow me to actually look at her personality and how this lady actually takes things around. The second aspect is also, she has actually been in touch with Matthew sir for the last 10 years. And then she was off, on, and then had some messages. However, when I was actually looking from that husband and the current partner, he's her doctor, and our sir knows her for the last 10 years. And somewhere when he actually had his first meeting with sir, I am still doubtful if that actually went right, the first meeting with sir, because sir was actually not in a position to actually accept him, take him in for therapy. Probably he would have come with certain expectations. And then from there onwards, you actually see the last message is that that man is actually very angry with sir. And it is actually not going very well with the therapy process that sir wants. So I have these two things.
That's interesting. What might be going on, I wonder, in that man's mind uh, about the therapy and his partner?
I'm just thinking like he's healed himself or he's treated himself and from a what is described as either bipolar or schizophrenia. So I'm thinking like what kind of thought process, and he seems to have some rigid ways of living his life. So I'm wondering how much that impacts her life, and therefore how would you approach such a couple? On one hand, this is a self healer and probably lives a specific rigid life so he can stay in control of his mind, if one is to assume those are his diagnosis and he's not on medicine. And so what can he give to the relationship with her? And it also makes me wonder, why does he want to why does he want her to be treated with medicine, but he himself is not taking any?
You know, thinking on similar lines, this seems to be a person who's like, you know, I fixed myself, why can't you? So there's this, you know, overall in keeping in line with his personality, like I think Dr. Matthew mentioned that she makes him feel like an inferior person. You know, so this is just a part of that you can't even do this much. You know, you've been seeing a doctor for 10 years and you've still not been able to fix yourself. There may be a little bit of that attitude, I don't know.
I mean, I was thinking how Dr. Matthew was actually inviting them to reach out, but it's as if there's only one person who can have the problem. It's as if there's no possibility for all of them to sit together. So he was saying how he's insisting to be part of the communication. So that seems really challenging.
He seems to be berating the doctor also, that you can't fix her, she can't fix herself. And, you know, so
we might take your comment and then perhaps bring Matthew in, do you think so?
No, I was just thinking the goals of which why these two people are coming may be very different. I was just wondering if the partner thought that, you know, doctor is a male. I don't know if it's a male to male thing, that he'll understand how difficult it is to deal with this female, and I would like describe all my problems about her and he'll fix her. But then he didn't get that from the doctor, so I don't know if that is the reason for his anger and disappointment.
That's a good point to bring. Matthew, would you like to come back in and sort of tell us how the experience was and anything else that you gleaned from the discussion?
Yeah, so I think my thoughts are that I think this man tried to form a kind of alliance with me because he came to see me without her and tried to have a session with me. And I said that it might not be appropriate that I talk to you about her without her being present. I was very much aware of that at that point of time, and I said I'd talk to both of you together. And so those 3 or 4 sessions were together. All of them were together. They were not. Once I started seeing both of them together, I didn't see anybody separately. And I think what some of you said about he tried to align with me, and then I think he discovered that I'm really not on his side. I don't think he thought that I was on her side, but definitely I think this thing of fix yourself, unless you fix yourself, I don't want to do anything, was in some ways also a sort of rebuff to me, saying that, you know, you haven't fixed her, you fix her first. So it's almost, I remember thinking to myself, now looking back, that I felt in my head, you know, back of my head, see, hey, she has actually changed, because from when I saw her 10 years ago and now, she didn't seem to have that emotionality, which then I thought might have been a kind of, you know, emotional, unstable spectrum, which she herself said she was like that. But now in 10 years' time, I really don't know what has happened with the mother. I think the mother is out of the picture. And it's just she and a child. And she's been managing fine, and she's been working, all that. She's not had a problem. She's had a stable job and all that. So, to me, in my mind, it seemed to me that she had fixed herself. But, and then I also thought that they were in a relationship where, see, despite all these fights, he was not moving out of the house. He was there. And even today, I have not got a notion that they will move out. I mean, I, after listening to today's conversation, I think I will write a general mail to them and say, hey, now it's 1 month or 2 months, whatever it is. How are you all doing? Would you like to come back for a final session? Is what I'm thinking. Because then I would actually, because they have had time to think, I've had time to think, I've had some insights. And I put this to them and say, here's this incomplete, let's complete the chapter, let's decide. So actually, in 1 or 2 sessions, I actually said that, I'd actually told them that, I think you have to think of things with each other, adjustments, without really fixing each other. I said you can't really fix each other. I think it's in that response that he wrote to me an angry letter saying that I think she needs to be fixed. I have fixed myself. She needs to be fixed.
Right. Thanks, Matthew. I think we'll bring this session to a close. Thank you all for the participation, and let's hope all of us gain from it. I will now request all of you to stay here. Could the audience lights come on, please? We'll take questions from the audience, but please be aware that we wouldn't want to answer any questions about the case discussion here. That session is closed. We'd be happy to answer questions about balance processes or the process of what you saw here. Okay. Any questions at all?
Also, disclosure here saying that this particular case that I presented is not a real patient. It's a mixture of many clients that I've seen, and I put it together. So I think it seemed like might have seemed a little more colorful. I did that to make it more,
Yeah. I think what Matthew's trying to say is it was a mock session. This is a truncated session. Yes.
Yeah, one question is, I thought Balance Group is talking about the context of the patient and talking about what is it doing to me emotionally, therapist. Like probably because of time, you didn't go into that. So that's the understanding I wanted to have. Briefly, can I say there was similar, like parents want to fix the child, whereas child has a real problem, and the child was like telling uncle, can you tell them please? They took him out of the school without talking to him. Then he said, can I at least go meet my friends on Sunday? And that also they were not doing. They moved the house 20 kilometers away. And I was trying to tell, can you at least do this Sunday thing? And they were very reluctant. Their thing was fix the son, because son had some behavioral problems. And I felt extremely helpless. So I thought Balance Group, I talk about how helpless I felt. And the next appointment, a leader died, so that day they didn't come, and then they conveniently did not come. I knew parents' thing was fix him. So I thought Balance Group will be talking about what it does to me as a therapist, like helplessness, frustration and all. That's a question I had.
You're absolutely right, Mohan. We sort of reflected on the presenter's frustration as a group, but we couldn't go into the depths. That's just because of time. You would have gone on for an hour, actually, but
this particular the process that we saw, there were a lot of personal biases probably stemming from the various backgrounds from which the various the therapists came from. It was not a neutral advice to the case presenter as such. And nobody actually thought of telling him that who is your patient and what you want to do with him and what are the ethical and legal issues involved in this particular case. seeing, you said, can I transgress your this thing for a minute? Unless we discuss this particular case, like for example, seeing the husband without the patient and talking about the personal details is a no-no, whoever it may be. And if the person who is my client, who wants me to talk to the person who is her partner, then she will have to come along with him and talk to me. Without, no, but you said, you acknowledged that you understand who
could I
is he.
just gently point out that we will not go back to the
Yeah,
case
that's it.
because it will raise more controversy. But
Yeah.
one question I'd like to answer is, Balance groups do not give advice. You do not give advice.
Okay.
Because what I do or what Matthew does is depends on the situation, and there are rights and wrongs. So there might be various viewpoints. There are various viewpoints which we entertain, and I think that
And then
enriches them.
the only thing that came through Matthew's presentation was that he didn't know how to go ahead about it. There was no particular psychodynamic problems he was facing as a therapist. It was just a matter of what should I do from here. What created that problem? It will have created to anybody.
I think one of the things that, and sir, you can also obviously, this is not the point of, it's not about neutrality as much as point of view. And what might be called bias is different angles of looking at the case from someone who's never seen a case with no direct response to the question asked. It's a dilemma. Do I call him back? Do I whatever? So it's just, if I was to sit and listen to a case that I've never seen before, what goes into my mind and what are the thoughts I have about what I might want to know, how I'm feeling about it. And that is what the balance is about. Less to do with even psychodynamic formulation. If there's more time, sure, but for the most part, it's about my experience of the case I'm hearing.
So precisely, it is because of the presenter's dilemma. To me, it is still an open book. So dilemma was, I had not said anything. I had not said come for therapy, come for last session. I had not said anything. I just left it. There was no communication from my side. So I was wondering whether I should call them, not call them, close, send them a close email. Till today I didn't. But when I brought it up, because it is because of that discomfort that I had not closed it. And so, having talked about it here today and having listened to everybody here, the conclusion that I came to is that I must find some closure for myself. Meaning, to me, it's something which is still not closed. It's not. There's no finality yet. There may not be finality, but there's no closure. So to me, today, I think that there should be, from my side, there should be some closure. I should write some mail. Whether they come or not, that's a different matter. But I should get them into one session, if possible, to talk about what they want to do.
Before further question, there is a cash prize for the best question. So please introduce yourself before you're asking the question.
Very sorry for the late announcement. Would you like
Hello,
to-
yeah.
Just one point. We can never avoid discussing the case, despite what you said. Just to say that 9 opinions here and a 10th one, balance never ends.
Good evening. I'm Dr. Madhavi. I'm a senior resident in NIMHANS. So this was great, especially the demonstration. It's something that I always felt during my training. We do have good supervisory groups, but the discussion about your interactions with patients and your reactions is something that I felt that really needs to be done, because especially in India, a lot of psychiatrists don't go through therapy themselves. So, I mean, that reflects. It reflects in the therapy as well sometimes. So my question is based more on, because I am currently in an academic setting, that this was a more or less homogeneous group, like sir has mentioned. So when it is in a group where, like ma'am has done it in the college setting with the postgraduate students, where there's some hierarchy, where there's actually an obvious hierarchy, where the leader is their teacher, then how will this function? That's the first part. Because I'm looking at it as a, I have read about balanced groups before, so I'm looking at it as a alternative to the traditional supervisory group. So, so that is one part. And second, coming to from that, how are if there is a disagreement in the group, especially now we are looking at a hierarchy, and will the teacher also be with the leader also be sharing their cases, and how are we going to manage this? Because there will be times when there's a disagreement. So do you come back and discuss the disagreement as well? So, yeah. Thank you.
I think I'll take that question. So in my case, I'm an outsider to the setting, so I don't work at IMH. So it turned out to be a different dynamic in a way. Because I think I was just looked at as a strange person for a while. But then I think we all got a focus around what we are doing. I think what I want to say about the hierarchy is, if I think of my training in the UK, where my supervisor was somebody who I worked with, for example, I think the first among equals, I think the role of the leader is more to facilitate the making the experience more conscious. And the disagreement could be part of that experience, and it's viewed as such. And the group is not, the aim of the group is not to problem solve or come to agreement in a way. Sometimes the group might end with feelings of very contradictory feelings, for example. And I think part of the role of the leader is to be able to be comfortable with that, and so the group also becomes comfortable with that. Does that answer your question?
Yes.
I think they do. From whatever I've read, it's not happened in our group during my time, but I think they do. I think I wanted to address what Dr. Patil had raised about each of us having our personal biases. By and large, we take an eclectic approach, and we come to some kind of understanding. Thanks for the music. I think we are very clear that we have our biases, and there will be disagreements. You're very right. We are not here to homogenize everything. And we have had meetings even recently where there have been disagreements about the approach to take with a difficult case. And I think the presenter is free to choose from all the options that have been presented to him. That is always the case. None of the above is always an available option. But it's not a multiple choice of one.
The balance between working out the case and a safe space to expose your vulnerabilities. Which one? Which one? I don't know whether you can say precedence, but even so, if you were to choose, is it about working out what to do with the case and bouncing around ideas for that, versus a safe space to expose our vulnerabilities and us being frail human beings?
The priority is for the latter.
Is the latter?
It is for the latter.
Yes.
When when you say what to do with the case, it isn't about management.
No, yes,
in
I
that
understand.
sense, but
It's
it
how
might be about
how it is with you. Yes.
what do I do
Yes,
in this situation.
in this helpless.
Also, when the leader says, who has a case today, sometimes there's a pregnant silence which goes on for many minutes because nobody wants to present a case. And then invariably, somebody presents a case. And I think the person who presents the case presents it because that is pressing on their mind. It's something which is sort of, there's a niggling sort of doubt in their mind about something. That's how they present it. And so invariably, there is a question that you're asking yourself, what should I have done? What should I do? And you may or may not get the answer, but but you will hear different opinions. And this whole pushback, and when you sit back and sort of see the group interact without you, about you and your case, that's a very, very powerful experience.
Yeah, there's one more question. I think we might. How are we doing for time?
You're good.
You're doing good? Yeah.
Very good, actually.
Oh,
Yeah, please go ask.
oh, sorry. You had a question? There's one from there. Yeah.
It's not on.
Hello, sir. Good afternoon. My name is Dr. Vainika. I'm a DNB resident of psychiatry. My question being in the conversation that you had, at one point there was a statement that if I put myself in the shoes of the client, this is what I would have done. I just wanted to ask, based on that, how important it is to put yourself in the shoes of the client in a psychotherapy session, or should we just get into their world and see it through their background and with their own view? Should we put ourselves or should we not in their shoes while administering psychotherapy?
Oh, you're saying in generally administering psychotherapy, not for balance groups?
Generally for psychotherapy, not for balance groups.
I don't know if it's relevant.
For psychotherapy, I think that's the beginning of empathy. And unless you put yourself in their position, you would not understand them. You can never put yourself fully in that. But you try to. You try to understand their context. And I think that is the beginning of a relationship. And psychotherapy, I believe, is about relationships and less about technique. Just to answer your question with relevance to Balint, all of us try to put ourselves in the position of the patient and the presenter. And that's a twin, I'd say even paradox that we try to put ourselves in, because it's important to see it from both sides. And that improves the doctor-patient relationship. It improves your understanding of the patient. And hence, I think the patient starts to relate to you better.
Thank you, sir.
Good evening, everyone. I am Dr. Evangeline from Institute of Mental Health, Chennai, second year postgraduate. Rather than a question, I would just like to share my experience of attending balance sessions in IMH for the past 2 years. I have been attending sessions with Dr. Sivagami ma'am for the past 2 years. We used to meet once or twice in a month, and initially I was in the listening session, and currently I am on the presenting session for most of the time. So on both roles, I have felt I have gained a lot of perspectives, which I think it is very much essential for a psychiatrist or a psychotherapist. And then the second one, the session has been titled as Relevance in Postgraduate Training, and I think it's very relevant. And I would like to recommend the sessions to other postgraduates in other colleges, because on my experience I have this has changed my perspective over time, and there has been communication in a better way. That's it, sir. Thank you. I just want to share my feedback, sir. That's it. Thank you.
Thank you so much.
So this is Dr. Magilvendan from CMC Vellore. I've been talking, this is also not more about a question. I've been in contact with Evangeline. I mean, I know her personally. One of the times I asked, where are you coming? She said, I attend balance groups. I didn't know what it meant actually. So when I asked, there is a session which few of us attend when we are stuck in a conversation, we talk about our difficulties to the group, and somebody will say how to approach about it. I felt why it is not mandatory in all the institutes. That's what I asked with her. So I also felt there is a question with ma'am asked, is it more about negative counter-transference, or the feelings about the negative feelings about the therapist, or about the management of the patient? So I believe once you go to the consultant level, it's about the management of the patient. But once you are stuck in the starting level, it's about how to start. Most of the times you get stuck. There are a lot of negative counter transferences. So I think it should be in everywhere. It should be mandatory for all the institutes to have a balance group, something like that. Because once you cross the line, it's a privilege. But for people like starting postgraduate therapy, it should be mandatory, is what I feel. Because
No, you have the right person here.
Okay, noted, Magar. So when I put the proposal to HOD, I'll get all the PGs to sign on that. Yeah.
So, yeah, it is on the slide. It's on the slide which you can share. Anybody, you can have a copy of our slides. The address is there. Abhay, we started 10 minutes late, so I'll take 2 more minutes.
10 minutes? I'll
Yes.
give you 20 minutes if you allow me 1 minute.
That's a bargain.
trade-in.
That's a bargain.
A trade-in. Excuse me, sirs. For want of quorum, the AGB is adjourned. We'll reassemble at 6 p.m. 20 minutes.
Fantastic. Thank you so much. No. Okay. Okay. But, so, group, what, should we wind up? Is it time?
Talking from the perspective of a medical college teacher, like sir has been in touch with us to start for students. So when we start for PG students, they come in, they don't know much about diagnosis, the psychiatry at all, no? Like patients having dissociative symptoms or, what should, as a teacher, should I keep in mind when I start a balance group for PG students? Maybe directly to...
So the balance group doesn't address diagnosis, management, psychotherapy, no. It is not about that.
So we were asked to judge the best question, and we think Dr. Madhavi asked an excellent question. Thank you so much. So with that, I think we will wind the session up.
Thank you.
Thank you all so much. And yeah.
Thank you
Welcome
to
to
all
Balance.
these speakers for this one-of-a-kind discussion. Thank you to the audience as well. Please give a huge round of applause for this.
Geeta, come quickly. Otherwise, Geeta will get angry. Come first. So there is one. I'll ask for more copies. Yeah, please come this side. You'll get your photographs.
office bearers, and my colleagues. Thank you for giving the opportunity to serve the society. I am the President of Psychiatric Society South Zone, IPS South Zone. And also previous body also, they did a wonderful job under the leadership of Dr. Abhay Matkar. And we continue the legacy of the same. We will be do best in the future with our team. And other EC members also, they contributed very well. And I request whatever the future this conference CM is, anything is there, please coordinate with the IPS South Zone office for better smooth functioning without any problems. Regarding whatever the arrangements or anything, even the speakers, allotment, all those things also, in coordination with the IPS South Zone, we can do that. And with this, I thank all the members for once again giving this opportunity serve the society as the President of IPS South Zone. And today's agenda is, next agenda is condolences, if any.
Good evening, everyone. So I would like to bring to the notice of AGB the condolences for this year. So we have there are 7 condolences for this particular year. Dr. A. Amin from Kerala, Dr. N. Subramanian from Kerala, Dr. O. Somsundaram from Tamil Nadu, Dr. D. Sesi from Kerala, Dr. P. Ravishankar from Andhra Pradesh, Dr. Ananda Krishna Kumar from Tamil Nadu, and Dr. Janaki Ramaya N from Karnataka. So these are the condolences I have received. So if I have missed any, please let me know.
If not there,
So not there,
if you want to say something about any person, please.
This is regarding Dr. Janaki Ramaya, who was our teacher, one of the finest teachers at NIMHANS, including his disciples include people like Dr. Raghuram, Sripati Bhatt, etc. Extremely simple gentleman. He is one study where he compared patients with depression on medication and patients with medication with Kriya Yoga. At the end of 6 weeks and 12 weeks, patients who were with yoga therapy responded better, and he is the man who coined the term Sudarshana Kriya Yoga, popularly called as Sky. And that is what has been trumpeted all over the world by Sri Ravi Shankar. And the father of that Sky is none other than Dr. Janaki Ramaya, who was an excellent clinician and a good teacher, extremely simple human being, and we miss him today. Thank you very much.
About Janaki Ramaya garu, he was also my teacher. He was called as Telugu Devaru. All the Telugu people from Hyderabad to this belt, Anantapur, everybody who speaks Telugu reach to him. And then he takes care of as if they're all his family members. Very great of him. And another point, when all his children left off, he has kept one mentally retarded child in his home to take care of his and Janaki Ramaya's needs. it's surprising. So he's the model. He's the best psychiatrist when he was there, and he taught us a lot of good psychiatry to us. And about, can you say Ravi Shankar Pasam? He was the past president of AP State Branch. He was called as student teacher. I don't know what it means. He was always with the students, take care of all his needs, and then comes to the department. And he goes to a hostel and whatever psychiatry department existing is because of students. That's what he says, and encourages us a lot. And very good psychiatrist. Thank you, sir.
And this is regarding Dr. Ananda Krishna Kumar. He is from Madurai. So he was a professor of psychiatry initially in Thaini Medical College, and just before his demise, he was transferred to Madurai Medical College. So he passed at a very young age, around 54, I think 53, 54 years, and he's a teetotaler. One fine day, he had a brain stroke, and he was almost for 1 year in a vegetative state, in a coma, and he was treated in CMC and so many places in Madurai itself, and he was almost like on the vegetative states. And at last, during one fine morning, he had a small MI and got collapsed and passed away. And he was a very good teacher, good friend for all the psychiatrists in Tamil Nadu. And he had two sons, and both of them are doing medicine. And it is really a surprise for all the psychiatrists in Tamil Nadu because of his loss.
I would like to pay my homages and tribute to Professor O. Somasundaram, sir. Professor Dr. O. S., as he was fondly called, as a father figure in psychiatry with regards to the state of Tamil Nadu. He was the teacher of all our teachers, and his enthusiasm towards, not only towards academic psychiatry, but also towards the Tamil language is something which set him apart. He was born in 1924 to Diwan Bahadur O.T. sir, who was then the president of the Madras Presidency Corporation. And as a visitor, he used to come to IMH. After his MBBS at Madras Medical College, he then did his TPM at NIMHANS. Then it was All India Institute, and then following which he joined the government service, and then he, along with Professor Dr. Sharda Menon Madam, whom we lost recently as well, they were the two pillars of the Institute of Mental Health at Tamil Nadu. And even after his retirement, he would regularly come to IMH for all the clinical meetings which were held. And he was an inspiration to most of the youngsters who entered MD Psychiatry at IMH. We deeply miss him. May his soul rest in peace.
About two persons, Dr. O. Somasundaram. I was associated with him in IMH. Though he got retired, he used to come. He had a very good knowledge in legal psychiatry, so which I got interested with him also. And because of him only, I presented a paper for the SS Jairam Award, for which he was instrumental in that. And then he was interested in the clinical acumen, whatever might be the thing, the phenomenology, and he used to come till his 90th age. He came for the clinical meeting at IMH, and so he used to give some valuable contributions. And about the Tamil literature in suicide, and then what is the psychotherapy that is available, that and all, he has written some many books. Okay, that is what. And so he instigated all the youngsters to do it also. That is the one with the OS. And Dr. Ananda Krishna Kumar, when he did his second year DPM, I joined my first year MD at Madurai. Now I was a skilled PG as such. Okay, then he joined MD in IMH. I came as an assistant that time. It was really disheartening actually to note that he suddenly fell ill, because both of them got promoted as associate professor at the same time. But he had to leave his native place from Madurai to Thaini. So he felt very bad. So he had to travel and all. But that time he could withstand everything. When he came back to Madurai, then that became really problematic, I believe. And I think I really lost a very good friend, because anytime you call him any help, he is ready to do it. That is the thing. Though we are not speaking very regularly, that is the thing with Dr. Anand. I think my heartfelt condolences to both of them and to the bereaved family. Thank you.
I'd like to share my memories with Professor Dr. O.S. sir, with whom I had almost a daily conversation for the past 4.5 years, the tenure when I was in the director of IMH. That room phone number, he used to daily call me at around 9 a.m. When the phone rings, we all know it would be your O.S. sir. And also his firm belief in this Dravidian ideology. His father was a founder of Justice Party, which was one of the leading, which was the Dravidian in Tamil Nadu. And so when we visited him just 1 month prior to his passing away, he was wearing a red kungumam on his forehead. So when we were surprisingly seeing him, he gave an embarrassing smile and said, "It's family, ma. What can I do about it?" So till the last, he stood firmly by his ideal, and his humor also is iconic. In every clinical meeting, we used to watch and wait for OSR's statement on the case, which usually will be filled with laughter. And also on that occasion, the last time we saw him, he was reading. Till the last month, he was reading a book on the history of South India written by a Japanese, and he also showed us references as to how it was, the facts had been distorted by another writer. That was how clear he was. So we miss you, sir, and condolences for the family.
Yeah. Hello. I deeply mourn the death of Dr. Amin. I knew him to be a very jovial person, he and his family. That's how I knew him for many number of occasions, most of the conferences. I pray his soul rest in eternal peace. Thank you.
I fondly remember Dr. A. Amin, who was very active in Indian Psychiatric Society and was the EC member, and but he was also active in social circles. He was a politician. He once contested for the post of MLA, and he was in various other posts. He was a leading psychiatrist from Kollam and had his own hospital. Dr. N. Subramanian was in health service, and he joined psychiatry late. He was a good writer. He had written many books about in the interface of psychiatry and literature, and that was well acclaimed. And I fondly remember Dr. O. Somasundaram. I was a student of IMH for a short time, and he had inspired generations of psychiatrists. And I still remember him seeing in the IMH case conferences. And even after that, even though my acquaintance was very short, he was very fondly remembering me and talking to me whenever I meet him. It's a great loss for psychiatry, but his model is for everyone to follow, I think. Thank you.
So anyone else?
Regarding Dr. Ravi Shankar, he was when he was assistant professor, he used to meet me along with our colleagues regularly. Myself and Dr. Mayurnath Reddy, everybody got the promotion as a professor at a time. So that time regularly he used to call us. Even though he's age-wise is senior, he used to say sir for everybody.
so much humbleness was with him. I think his soul rest in peace. Yes. Okay. So with all these memories, we'll. So you want to say, sir? Okay, for 1 minute silence. Thank you. Next is the agenda is the confirmation of the minutes of AGBM 2023.
So I have already shared, but I'll just go through fast. Yes. So, any doubts in the page number 1? I think I have included everyone's name in this. Page number 2, welcome remarks, the condolences. I have included, because there was some confusion, I included only the names who were all members of South Zone. So AGBM 2022 minutes were read out and accepted. Honorable General Secretary report was presented by me, and it was accepted after being proposed and seconded. Honorable Sir. Sir. No, 2022, sir. Oh, I think I'll add, sir. I'll just check out and I'll add. I think Dr. Ashok Red's surname was there. So I'll add it. I'll add it, sir. No, definitely, sir. No, that. Sir, page number 3. So, Honorary Treasurer report, Honorary Editor's report. So then the election results. Sir, actually our original name is Rayurala only, R-A-Y-I, but as per records it is R-A-V-I only. So she is my classmate, so I know it. Then the awards were, details of awards were presented by Ramanan sir. Then regarding oh, so actually, sir, no. Did you get that, sir? Oh, yes, sir. 2 times. Yes, sir. This I'll remove, sir. No, no. Second time again.
No, you have to just only announce the result.
Yeah. I can stop there, sir. This is about the IPS South Zone events for this year, sir. Then any other business with the permission of the chair? So last year we took only 1,000 for the members, postgraduate members who have become IPS South Zone. We have joined IPS South Zone. So anything which I have missed, anything?
This is Rabis.
Sir, thank you, sir.
Okay, seconded by Jagdish. Next agenda is reading and adoption of Honorary General Secretary report.
Yes, sir. So notable is we have already, as I expressed on many platforms, we have won the best zonal branch for 2023, sir. The condolences, IPSOCON 2023 at Guntur, midterm CME at Kurnool, annual PG training program held at Thiruvananthapuram. Registration renewal was done completely online without any financial burden. The EC meetings were held regularly. The journal, still we hold the best impact factor compared to other journals in the country. And the other important is one issue completely dedicated to academic psychiatry. Samanvi, the notable is they bring out a publication on gender trauma exclusively by all women psychiatrists and both the editors and the authors. And RCBC, we have successfully completed fourth edition of BCPR course with about 50 participants with 2 contact sessions, in-person contact sessions and other Zoom sessions. So publication committee, apart from the Samanvi, and psychiatry in medical education is another issue which is being brought up. The wellness committee, we have conducted a seminar on bliss brain on the occasion of World Yoga and Music Day. Dr. BNG sir was present. And suicide prevention committee, we have lecture titled From Chaos to Clarity, Surviving and Thriving After Suicide Loss was well appreciated actually. It was delivered by Dr. Nandini Murli, who has suffered and shared their experiences with us. And membership committee, actually till yesterday, even after preparation, it is 194 members have joined our society in the last 1 year. The postgraduate committee has formed a committee to bring out a consensus on the history taking and diagnostic formulation, which was presented yesterday in IPSOCON. So the website committee has updated all the website. The internal audit committee was very active in scrutinizing all the financial activities of the zone and regularly. And election commission has worked hard and they have conducted successfully the IPS SZB elections 2024 online. And the CMA committee was active in formulating all the scientific sessions for all the programs. And the community awareness activities where they encouraged all the members to actively participate in various awareness programs. And all the state branches have conducted their regular scientific activities, EC meetings, regularly, and the notable is Telangana state has won the best state branch award, which was in for the year 2023, along with us, along with the zone. So it was presented in ANSIPS at Kochi. So these are the state branch activities. And these are some of the personal achievements of our members. Dr. Chandrasekhar CR, he was honored with Padma Shri Award by the Government of India, which is an honor to us, he being our member of our society. Dr. BNG sir was appointed as Chairman, National Medical Commission. Dr. Pratima Murthy, she was awarded with Doctorate DSc by University of Health Sciences, Andhra Pradesh. And on behalf of being the director of NIMHANS, she has received the Nelson Mandela Award which for health promotion, which was given to NIMHANS. And Dr. Indlaram Subbareddy has awarded the Dr. YSR Lifetime Achievement Award from the state of government of Andhra Pradesh. Dr. Karirama Reddy, he holds the distinction of being the first PhD scholar in yoga therapy in the country. So in general, broader field of yoga, many have PhD, but yoga therapy is something special for him. And Dr. K.S. Pavitra received Senior Fellowship on Dance and Mental Health by Ministry of Culture, Government of India. And she was also been awarded Ravi Datar Award for her work in the field of humanities. Dr. Ramana Neeraj sir, he has received 2 awards, one being from the Shalom Institute of Mental Health and the other being Dr. D.S. Raju Memorial Oration Award by the state of Andhra Pradesh. And ANSIPS 2025 is being held in Hyderabad in the month of January. So with the theme Neurobiology of Illness to Wellness. So as I close, I express my sincere gratitude to the President, Dr. Abhay Matkar, Vice President, Dr. M. Umashankar, entire EC members, all my seniors and colleagues for wholehearted support and guidance during my tenure as Honorary General Secretary of this prestigious zone. So any shortcomings are purely unintentional. I request if there are anything, please excuse me, and I am very thankful to the society for giving me this opportunity. Thank you all. Long live IPS, long live IPS South Zone.
Proposed and signed by.
I can't do this. Sir. Sir.
Yes. Yes, that's right.
Sir. So it can be still brief, sir. So, as a matter of in the document, I am just keeping it. Because, sir. See, yes, sir. Whole tension.
Very notable. It was like a national level
Sir.
program.
Yes.
So something like that should be highlighted. So
Yes.
that incoming General Secretary can take note of this.
Yes, sir.
And make it more concise and see that what's the more, other than routine things what they have done.
Yes. But we are trying to collect everything so that, because one
Understood.
only
Understood.
the mass is going to win us the best. Yes, sir. Yes, sir. Definitely. So, yes. Yeah.
No, what we are telling is make it concise.
Yes, sir.
Make it concise.
Yes,
that's
true.
The same report will be sent to the national level also.
No, each state will send it.
No, sir. We have to send a zonal report. When we send the same report, Honorary General Secretary's report gets expanded and sent. And most of it is digital form. I think this just gets a motivation to the states who have sent the report. So, should not be a problem. Sorry, sir?
There is a competition for the states also.
Yes, sir.
So they will be also sending.
Yeah, that's true, sir. That's true, sir. But what I'm telling is, it's not.
But I am trying to say this is a repetition.
What he is trying to tell is, when they come to the competition of zonal level,
They want to see what activities are done under that umbrella. I don't know what's the constitution say, whether they look into only south zone, south zonal branch activity or the zonal constituent states activity.
No, no. They see independent South zonal activities.
That's right.
They
So we
don't
can-
add up to the
Thank
members' activities of the states
So
for
then
the zone.
That's why. That's
Yeah.
what I'm
Exactly,
saying.
sir.
So we should condense and make only 4 sentences of each.
No, but even the IPS guidelines say that the zone has to collect the information from the states and forward it. So, but definitely it is concise, sir. Okay, thank you, sir. So, someone to. Sir.
You attended last.
Secretary, Dr. Ajit Bide, sir. Dr. Gangadhar.
Next item is reading and adoption of honorary treasurer's report and the statement of audited accounts for the year 23-24.
Shall I open it?
Good evening, sir. At the outset, I'm privileged to take up the task as a treasurer. I thank my chief, Dr. Ramakrishnan sir, and past president Ramana Nerad sir, Abhay Matkar sir, and current president Uma Shankar sir, and secretary, treasurer, and our editor also. The outset, this is a statement for the last financial year, that is from April to this year, March 31st. Our opening balance was 7,95,000. And our closing balance was 8,73,000. And we have an FD whose current worth is 7,86,000. And we had another small account which has been, that is IJPM account, which has been closed now. So we are running only one account, which is in Union Bank of India. Regarding the income and expenses, I have summarized the income and expenses in the last 2 years so that to have a glimpse of what is happening. And this income and expenses have been splitted into 3 parts. One is a total income. In that, it is further divided into 4 parts. That is general, IJPM, and then BCPR, and then publication income. So this is just for our clarification. Well, otherwise, we had good number of people who became members, and around 128 members joined IPS in the last financial year, and through which we got the membership fees around 2,56,000. And last year BCPR program we had 1,25,000, and we also had a BCPR program this year, that is by January, and where we had increased the registration fees up to 10,000, and we could collect from 50 people, and so our general income has increased up to 5,06,000. And then we had savings bank interest, and we also had an excess amount from Tamil Nadu chapter for the midterm CME 2022 and PGCME June 2023, which is amount to 1,27,000. We also had 1 lakh contribution from Kozhikode midterm CME, and we had around 6,30,000, which is total amount was 7 lakhs. After deducting TDS, we had 6,30,000 from Ipsocon Guntur, which was a huge amount when compared to the last previous years. And we also had advertisement journals from, not from pharma companies. We also had advertisement journals from Mansa Hospital, and recently we also had advertisement from Asha Hospital, Atma Hospital, and we encourage other people to give more advertisements for our publication books or IJPM. And then regarding expenses, we had last printed one publication, Rehabilitation Psychiatry. Apart from that, we have printed only now, that is Samanvi book. Otherwise, other payments like in the form of website, then voting, that e-voting, and Sage publications, we had paid 10,76,000 last year, and auditor fees has been paid, and then expenses with respect to editor has been paid. BCPR payment will come next. And then income tax, we had paid 2,60,000. So the reason behind, oh. Yes, sir. Sir, actually, last year it so happened that we had, that is 2022-23, we had 18 lakhs of profit, and out of which 3.5 lakhs has to be paid as a tax, payable tax. So 1.3 was collected as TDS, and we had to pay 2.6 lakhs as income tax. Whereas this year, that is this financial year, which I am reporting, 23-24, we had 8 lakhs of profit and 90,000 as TDS, and 80,000 only payable, and we had returns of 11,000, which has been credited to our account. And then regarding our, otherwise all payment has been done up to date, sir. Pardon, sir? It is all in the report. Auditor statement is there, sir. Is there, sir?
It's not there in that report which you have.
Okay, sir. I'll write it, sir.
No, it is distributed.
It is distributed.
It is not there. It's not there.
Okay. Okay, sir.
Looks like.
Yes, sir.
Yeah, you have given only the auditor report. There.
This also I have presented. This also I have presented. Sir, actually, that clarification I got it from the auditor recently, orally, sir. I have not mentioned in that. Yes, sir. I didn't get that.
You are reading the auditor report till the March 31st, 2024. There are two things. What is circulated is annual and one is this quarter.
I got it wrong.
Some didn't get one. Some got only 2 pages. No, sir, one is from April 1st April 2023 to 31st March 2024. The other is from April 2024 to September.
I'm reading the last financial year.
Financial year.
I'm reading to 30. Yes, sir.
Next year.
Yes, sir.
So that's an unaudited account.
Yes, sir.
Unaudited account should not be presented in the general
Yes, sir.
body. Only audited accounts of
Yes.
2030, 34, 54.
Yes, this one.
This paper
You,
Oh, yes, sir. Sir, I'll continue, sir. Yes, sir. Thanks, sir. Thanks, sir. I'll continue, sir. Sir, we have around 16 term deposit, and I have mentioned the account number and the opening date and the remarks which were filling into which one. And many of the deposits I am not, because it was done well past, not able to identify which belongs to whom, which we will clarify a little later,
just
sir.
present the audited report.
Yes, sir.
only,
Yes, sir. And then, yes, sir. So regarding BCPR, this page, sir. 20. Right, sir. BCPR payment, we did not pay anything in the last 2022 because of Professor MV Ashok sir demands. Otherwise, we paid all the dues 2022 in the last financial year, around 90,000 honorarium was paid. And then 2023, we paid entire amount for the faculty travel and faculty expenses also. 24, we have to pay this year, sir. Otherwise, the expenditure, other things have been paid up to date. And regarding membership, sir, as I said, the last financial year we had 128 members, and current status I have mentioned, sir. That is, as on today, we had 1,416 members, sir, out of which 946 were LF and 470 are LOM, as per last week, sir. And these are the state-wise distribution. And last 2 days, I've collected another 16, sir, which I have to tabulate. And we had, as I said, we had around 39 PGs who have been registered for the membership. We collected 1,000 rupees from them. More from Karnataka and few from Tamil Nadu also, sir. And regarding, yes, sir, that's all. Regarding awards, we have around 80,000 per year annual expenditure for awards regarding various cash prizes. And for Sage publications, we have to spend 10,76,000. And other expenses are another 1 lakh. We have a huge corpus amount, or we have a good amount of corpus amount, but that comes in a cumulative deposit, sir. I inquired the bank person. Since it is in a cumulative fund, we are not able to withdraw anything from that. And the interest adds around 5,74,365 was the interest which we gained in the last financial year. And this interest just adds on to the main corpus amount. So far, we have been managed without getting anything breaking from this. But whereas we could get some funds from various other pharma industries and now from hospitals, also from the memberships and other things, sir. So we are running in surplus only, sir. There is a suggestions from to do what to do with respect to the corpus fund. I mean, there is as I have divided them into general and endowment funds, sir. The current general, yes, sir. And yes, sir. You want? Yes, sir. Lastly, I thank Internal Audit Committee, Dr. Gangaram sir, Thomas John sir, Kannabiran sir, who meticulously, we had a WhatsApp group who used to give me inputs and verified the account, sir. Yes, sir.
Any clarifications?
Yes, sir. For 9 people, we couldn't identify the state. There were 1 or 2 people from West Bengal, UK, and other that addresses we couldn't contact, sir. So that it's kept abeyance, sir.
No, others in the sense.
Not from our
address
state.
is still there. Where in the many EC meetings we have discussed actually regarding that. So unless they inform us, we cannot remove their names from just based on the history. They may be still residing in the sense residents may be here, working may be there. So that's why we couldn't remove this.
Yes, sir. Yes, sir.
Coming to the income and expenditure statement. The assured income of the association is only 5,79,000 rupees. That is 18%. I am looking at the income and expenditure statement. Please check that. Actually, our permanent income, our assured income per year is only 5,79,000. That is FD interest received.
Yes, sir.
But we have got a lot of expenses which we are committed.
Yes, sir.
Like award 61,000 rupees, journal 10 lakhs. And I don't know how will we manage
Yes,
unless we generate income from the conferences, which is going to be difficult in the future with a lot of restriction by the government of India. So I think we should increase the corpus amount. So I think minimum it should be around 2 crores corpus we will need to run the branch activity. Another thing, printing and stationery, why you spend 2,55,000? I think nowadays we better go for online, digital. Avoid this printing and stationery. We should avoid it
yes,
maximum as possible.
It was a sponsor given by IPCA Pharmaceuticals, sir. 4,90,000 they had given in 2022, sir.
Okay,
So hence
in
we have to
future
spend.
I think we
Yes,
should
sir.
see that.
Yes, sir.
Yes, sir.
That
Only
should
if there are
drastically come down this.
any sponsor is there, only we are printing, sir. Otherwise, we are not printing.
We're going for it.
But you see, we can,
yeah.
it is good. All what I'm trying to.
Yes, sir.
These are the items we can reduce the expenses. Because some of the items are permanent, we cannot reduce. Like award money, how can we reduce? Journal, we cannot reduce. This is a totally committed, and we have to raise those funds. So whatever is possible to, the website, are we running? Have you got a contract with the website people?
Yes, sir.
So again, 46,000 rupees we are committed.
35,000. 35,000.
So
renewal
our
it's
permanent
not.
expenditure is quite high.
Renewal, it's not.
This corpus fund will not be sufficient.
Yes.
Yearly 47,000, I think, 47,200.
No.
It is written here.
No,
Website charges.
That was the initial charge. No, that was the initial one, sir, I think.
Even renewal we will have to give because unless you pay money, they don't.
No, they will not.
11,800.
In our local branch, we pay money.
Yes, sir. Yes, sir.
Others, they don't.
Initial was 35,000 and then renewal 11,800.
11,800.
Whatever it is, what I'm saying. What is this traveling expense?
Sir, for BCPR program, the traveling of the speakers, that the expenses, that's sir.
Then faculty payment, that is again for
Yes,
the
for BCPR. Honorarium of the BCPR.
That's it.
Do we get any income from this? Registration charges.
Yes, sir.
Yeah.
Does it even out? Does it?
Yes, sir.
Sir, it's plus, sir. 2 lakhs plus. I think Dr. Shah will.
Then I think our aim should be to increase the corpus fund to a sufficient level so that we generate sufficient interest to meet the regular expenses, not anything extra. Like giving award money, maintaining journal, maintaining website. This should come.
Yeah, sir. Little. Sir, but I think all the.
No, this is the one we are discussing this income and expenditure.
Sir, but a small information, all the FDs are fixed in such a way.
No, I am not talking about FD. FD should go up. This 1 crore is not sufficient. He was telling 1 crore as a very huge amount.
No, the
I am saying
interest.
1 crore is a very insufficient amount.
Sir, the interest which we are getting on FDs is being added to the FDs only. It will not be deposited in the account.
I think we should, once we became 2 crore, the money should come to the association. We should change the pattern of deposit.
But we have
Otherwise, we will not have any income.
Yes, sir.
You will have to break the FTA to pay the money.
Yes, sir. We have
So
just
I think you have
crossed
to plan
1
it
crore.
like new things, new deposits. You put it such a way that you get the interest, every annual interest you should get.
Yeah, that should.
Further FD. Let this existing FD continue like this. Further FD.
Further FDs, interest check it. Yeah, sorry.
In response to Dr. Joseph Varghese' question about the expense for printing and stationery, you mentioned that there was a donation from a pharma company, IPCA. That doesn't figure in this receipt.
The donation was previous financial year, sir, and we could print only this financial year, sir. We spent in this year, sir.
All right. And by Sun Pharma, it says 98,000. What was this, a donation or what?
Donation, sir. General donation. 98,000, sir.
I
2,000 they collect for TDS, sir. 98,000 they deposit into this one, sir.
I think we can pass the.
Okay, if it is okay, we can pass it.
Just regarding the last page of liabilities and assets,
yes, sir.
There is a membership suspense. It is going on carrying for 2-3 years, I think. Why can't you write it off and make it as a asset? Like last page, liabilities and assets. For that, you may require the permission of the AGB.
Yes, sir.
Write it off.
Small amount, 2,975 is written.
Suspense. I think you are not able to find out who's paid that money.
I think it happened from my time also. It is carrying over.
Okay, if it is
Membership
since a long
suspense,
time, I think we can
2,970.
suspend it.
Somebody might have paid money and we could not find out who has paid the money. That's all.
Okay, sir. Then we can.
No, we will not be able to write it off. Actually, we will have to check with the chartered account what can be done about it.
Okay. Thank you, sir. Sir, proposing by.
No, I should don't write my name everywhere.
Sir. Sir.
Thank you, sir. Thank you, sir.
Murli sir. And
thank you. Thank you, sir.
Thank you, sir. Next one is the reading and adoption of the honorary address report. Sir. Okay. Okay. Okay, sir. Congratulations, Dr. Lokeshwar Reddy, for his excellent work, and also Dr. Arun Kumar also done excellent work. I am congratulating both of you, sir. It is the reading and adoption of honorary address report.
Respected Matka sir, and sir, under whom, respected President Matka sir and respected AGB members, I'm just going to focus on the important points in this report. The most important thing was we had released the thematic issue on academic psychiatry, and it was inaugurated by Dr. Gangadhar, chairman of NMC, on 27th October. And the impact factor of the journal continues to be high. For 2023, it was 1.9, and for 5 year, 5-year impact factor was 2.6. And one major change is the Clarivate analytics. Initially, this journal was listed only under psychology category. Now it is also included under psychiatry. That's a major thing. Because this basically implies that the interdisciplinary nature of the journal. And we continue to be in the Q2 category of Scopus, which is considered to be a very prestigious thing. And we had a lot of full text downloads during 2023. And one important another milestone was that Indo-American Psychiatric Association, it regularly publishes its newsletter. So now our journal is listed on the their newsletter. So every time, so this leads to more wider audience. Like now we can focus on more international authors and peer reviewers. So it gives wider readership to the journal. And as usual, like we are trying to continue the good work what has been done by the previous editorial team. And one thing, actually last year we had planned for 2 thematic issues. One was academic psychiatry and another was neuromodulation in psychiatry, that we did not get enough articles even till now. So that neuromodulation thematic issue is still pending. So we are still accepting this article. One issue we wanted to discuss, we had put in the EC and also we want to present to the AGB. Like initially our journal was with Medno publisher, but that time there were a lot of issues. So we had shifted to Sage publishers, but we continue to have a lot of problems with Sage, especially in between for around 40 days. Internationally, all the Sage journals were not functioning. It had led to a major problem. And despite my repeated reminders, they are very slow. And so one suggestion was to go back to Medno publishers, because now it is most of the journals in India like IJP, the Archives of Mental Health of IPS, AP, even the Karnataka Journal, and all major journals of India are with Medno. The only concern here is the coming back to Medno, they said, okay, we are going to consider that. But still, the total amount, what they are telling is still higher than Sage. So if at least not now, we can probably even consider next time. I just wanted to put it in the front of EC and AGB. I would actually get back to them and say that, okay, this is what we are thinking. If you are not going to improve, we are going to change the publisher. So just wanted to put it in the front of AGB. And this financial aspect, we are very grateful to, like especially the previous EC, like for 6 issues for the whole 1 year, the sponsorship was 1,50,000. But the previous EC had given the discount to the members of IPS, South Zone. They had reduced the amount to 1,25,000. So Atma Hospital has been very generous. They have been always contributing, giving sponsorships. Manasa Hospital, Guntur, last time under IVL Narasimha Rao sir. And just day on, I think, 10th of October, even Asha Hospital has given 1,25,000. And we really want to thank the IPSOCON 2023 organizers, IVL Narasimha Rao sir's team. They had donated, this is actually a mistake, it is not 7 lakh. This is 30% of this amount is for the IJPM. So it is 1,89,000 something. And we have been trying to do the good work what the previous editorial team has done. And we hope that we'll continue to do the good work. And again, from this platform, I want to request all the members of IPS South Zone branch, especially those who are owning hospitals or nursing homes, to actively consider sponsoring the journal. Thank you so much.
Two particular aspects I would like to highlight and compliment the editorial team. The indexing has been excellent. The work which the editorial team has been doing has been excellent. The impact factor is much above the national journal also. The second thing is he has discussed in detail in the EC meeting as to why the need of changing to MedNo as such. I think it can be considered when it comes due next year. I think it's due next year if I'm
Yes,
not.
sir,
Yeah. So it can be considered during this time, whatever is going on with the SAGE, we need to continue.
Any doubts? Any? Please, sir.
Okay, we'll pass it.
Kulakarni.
No, it's just for proposal and second.
Okay, sir.
Oh, sorry. I'm sorry for that. We'll change it. Sorry. Thank you.
Kulkarni. Okay. Okay. Thank you. Congratulations to Rajshekar sir for a good work, excellent work. Thank you. And announcement of results of IPS South Zone elections 2024 by Dr. Mayurnath Reddy, chairperson of this election commission. That number is not available. Okay, sir is Alfred Samuel. Alfred is not there. Alfred Samuel is not there. Yes, sir, please.
Respected President Dr. Umar Shankar, respected past President Dr. Abhay Matkar, office bearers and other members, my colleagues. The online elections went on smoothly from the notification to publishing of the results. Some people had some difficulties in voting regarding OTP or something, and we helped them and we make them voted. So everyone received this time message for all the people, all the members got message through SMS as well as email. Now, elections declare. Dr. Y. Arul Prakash is elected for the post of Vice President cum President elect.
Come on to the desk.
Come on.
Congratulations, sir.
Dr. V. George Reddy is elected for the post of Honorary General Secretary unanimously.
Certificate. Congratulations, sir. Please welcome. Please sit down.
Dr. R. Mahesh Gowda is elected for the post of Honorary Treasurer. Welcome, sir. Yes, sir. Very well. All the best. Congratulations.
Congratulations, sir. Welcome to the team.
Dr. Ravish BN is elected for the post of zonal representative to IPS national body unanimously. Congratulations, sir.
Thank you, sir.
Total votes, voters are 8. Oh, so, thank you, one and all, for especially my sincere thanks to.
How many total votes?
Sir, total votes are 866. Out of
we can take
556 people are voted. It is 65%, sir. Yes, sir. Thank you. So my sincere thanks to Dr. Umar Shankar, Dr. Abhay Matkar, Dr. Lokesh, and Ramnan Virat sir, my predecessors,
They'll go back to
Sebastian sir, and Kasturi Pandian, and my co-members, Dr. Nasima Reddy Garu, Dr. Alfred Samuel, and all my dear friends, give me the opportunity to serve as a election commission chairman. Thank you, one and all.
Thank you, sir, for the excellent job done for this election. Processes went on very well, smoothly, and till the declaring of results. Thank you very much to the election officers, all the three. Thank you, sir. Thank you very much, sir.
Thank you. I just want to say.
Yes, sir, please.
Good evening to all of you. I think this year the burden mostly will fall on me as the chairperson of this election commission. I think for conducting this type of elections, I think we need cooperation from the president, secretary, and treasurer. I think they have done a lot as far as the conduction of these elections are concerned. I expect the same type of cooperation from the coming secretary and the coming treasurer and also the president. So thank you one and all, for all the help the members have done, and I expect the same cooperation for the coming year also. Thank you one and all.
Thank you, sir. Definitely will cooperate, sir. Extend the same cooperation for the future elections, sir. Thank you very much, sir. Thank you. Third, next, sir. We have to select one more person. Yes, yes, yes. Announcement of results of awards. Announcement of results of awards.
Joseph sir, actually we are selecting another member for election commission in this agenda only.
What he meant was
No, not this.
acceptance.
What I'm trying to say that
Acceptance.
for the election result is the next is result of award. Any other matter we can do all that. Next election all that. Award.
Respected seniors and dear friends, thank you all. Thank you all South Zonal branch members for electing me as Vice President cum President-elect of IPS South Zonal branch. And indeed it was an election this time, and I think it's a blessing in disguise. I could make friends with so many state people,
with Telangana, Jaj Reddy and all, Magesh Gowda, and so many people I could meet and become friends. So this is a good opportunity to develop friendship with so many people in South Zonal branch. And South Zonal branch is a very prestigious branch. And the presidents, past presidents, Abhay Matkar sir, and so many stalwarts occupied this chair. And I think I am really fortunate to be a president in future. And I take this opportunity to thank our state past president, Dr. Pani Selvam, who proposed me, and Dr. Sivasailam, who treasurer, who seconded my nomination, and so many friends. With all their support, I am here. And as the president-elect of South Zone, I would like to say one word. South Zone should stay united so that we can achieve more in the national level. So with those few words, I thank you all once again for this opportunity. Thank you all.
Respected seniors, President Dr. Umashankar sir, thank you for giving me this opportunity. I think it's a big challenge to take over from Dr. Lokesh. I'll try to do my best, and anyway he's there to guide, and I'll work in the best interest of the South Zone branch. I thank all my seniors who blessed me from Telangana, Dr. Kishan sir, Kishore sir, Ashok Reddy sir, Mairnath Reddy sir, Chandrasekhar sir, Umashankar sir, and I thank everyone for giving me this opportunity. Thank you.
Thank you, dear friends and colleagues, for having the confidence in me to give me an opportunity to serve in South Zone. I'm not taking over from the current treasurer. I'll be joining him to make sure the work really continues in the interest of the South Zone. Thank you.
I need the blessings of all the seniors and cooperation from my colleagues and juniors. So I will not speak much, only action. Thank you very much.
Thank you, sir. Now I request announce the results of awards. Okay, I request the Dr. Uday Kumar, Chairman of Awards Committee, please announce the results of award.
Very pleasant greetings from the Awards Committee desk of South Zonal Branch. I am really feeling honored and privileged to announce or declare various prestigious awards towards IPS South Zonal Branch. First of all, let me thank all my awards committee members, Dr. Chandrasekhar, Dr. Vidhu Kumar, and Swaminath Malayappan, for their continuous help. And from administrative side in this campus, helped me to conduct smoothly. Dr. Chaitanya, Purva, and Srinidhi Kumar have helped a lot to conduct this various awards session in this campus. Thanks to all of them, and special thanks to Lokesh Reddy and Abhay Matkar and Arun Kumar for their support. We announcing, declaring all the awards, but all the award winners' honors will be done during valedictory function. I request all of the awardees to present during valedictory function tomorrow. According to rotation matrix, goes to Visakha Psychiatric Society Oration Award goes to Kerala. One of the most prestigious awards in the South Zonal branch goes to V.V. Mohan Chandran. He is with us. He is from Kozhikode, Kerala. Gets the award of Visakha Psychiatric Society Oration Award. He'll be delivering his lecture during next IPSACon, Hyderabad. Atma Endowment Oration Award for Women Psychiatrists, according to rotation matrix, goes to Karnataka State Chapter. Gets this award Saranya Devanathan. She's from Bangalore. Dr. S.M. Channabasavana Spandana PZ Quiz Award. The first prize goes to Jabisha Sharmi and J.R. Priyadarshini, Tirunelveli Medical College, Tamil Nadu. And second prize goes to Jerry John and Devika, Government Medical College, Trivandrum, Kerala. Third prize goes to Megiza Vandan and Evangel Mavis Johnson. They are from Christian Medical College, Vellore, and Institute of Mental Health, Madras Medical College, Chennai. D.S. Rosu Memorial PG Award for Best Paper goes to Ajit Jain, Government TD Medical College, Alappuzha, for his paper titled Typology of Self-Injurious Behaviors Among Patients Admitted to a Tertiary Care Hospital. Dr. S.S. Jairam Award for Best Paper goes to Shruti Agnihotri, Assistant Professor of Psychiatry, Gandhi Medical College, Hyderabad, for her paper titled The Silent Struggles, a nationwide study on the prevalence of sexual harassment among women in healthcare. Dr. P. Raghuram Reddy Best Research Paper Award goes to Natarajan Varadarajan for his paper titled Publication of Studies Registered in Clinical Trials Registry of India. Second prize goes to Anand Bogarasgar, probably is here, for his paper titled Association of Depression and Cognition in Acute Chronic Cerebrovascular Accidents. We have RCBC awards. Vinod Award goes to Shreya Marian Salim, Senior Resident Government Medical College, Manjeri, Kerala. And Dr. M.V. Ashok Award Group Captivating Cohort consists of Ganesh Kailash, Sheen Jacob and Shushmita Asta, Rajesh Rayazuddin and Tejesh. And there is another group got second prize, Group Wisdom Seekers, consists of Drastisha, Shreya Mariam, Salim and Tarini Darairaj. We have UG quiz results also been announced. There's a paper called the Shatavahana Poster Best Paper Poster Award, will be done tomorrow morning from 8 a.m. to 9 a.m. Results will be announced in the validity function directly. We have got the UG quiz awards. First prize goes to Sri Surya and Syed Abdul Rafi, third year GMC Nizamabad, Telangana. And second prize goes to PV Vignesh and Brandy, it's a Brandy Samhet, final year Ames, Mangalgiri, Andhra Pradesh. These are all awards towards South Zone branch, and then honors will be done during valedictory function. I request make them be available at valedictory function to receive honors. Thank you, one and all, sir.
Thank you, sir. Thank you, sir, for announcing the all results. Now, appointment of auditors. Okay, sir. We'll find out. Thank you, sir. Next one is amendment. Any amendment to the Constitution, rules and bylaws, if any?
Sir? No. We have not received.
No, not nil. Okay. Resolution from members, if any? Nothing. Okay, sir. Inviting application for the conduct of mid-term CME from Karnataka, annual PG training program from Andhra Pradesh, and IPSOCON 2025 from Telangana.
I would like to announce the applications I have received for these three academic events of IPS South Zone for the next year. IPSOCON 2025, I have received a mail from the Honorable General Secretary of Telangana State Branch. It is going to be conducted at Hyderabad with Dr. Uma Shankar being the organizing chairman and Dr. George Reddy being the organizing secretary. Yeah. So IPSOCON 2025 will be held in Hyderabad, Telangana.
No, I think it is not appropriate. You ask somebody else to be chairman, somebody else to be the organizer.
Okay, sir. We'll do it, sir.
So you can decide. Telangana can decide inform that.
In the sense, it's not mandatory. It's not mandatory.
But it doesn't look nice. It's not in the constitution. I agree, it is not. It is not in the constitution. You can become if you are insisting.
Sir, one of us may be replaced by other person, sir. One will be there, sir. Okay, sir. Because we applied for that, one of us will be joining, another person will be included in that. Sir. That way we'll be doing. Okay, sir. Okay, sir. Thank you, sir.
Regarding the nomination for the IPS South Zonal Branch Midterm CME 2025, it's the state of Karnataka State Branch, and I have received a nomination from Dr. Supriya Egde Arur and Dr. Ravindra Monoli and Dr. Anil Kumar MN. They will be hosting the society on behalf of Mangalore Psychiatric Society in Mangalore. So IPS midterm CME for practitioners will be held at Mangalore. Then the annual PG training program is the turn of IPS AP State Branch. So we have received one application from Government Hospital for Mental Care, where I come from, Andhra Medical College, and we are interested to host the IPS annual PG training program at Visakhapatnam on behalf of the Department of Psychiatry and IPS AP State Branch.
Okay, thank you. Thank you, sir. Any other business with the permission of the chair?
Election commission.
Election commission.
So we need to elect one member for the election commission from the state of Tamil Nadu. So as a rotation, we are just going, sir.
So you can ask Tamil Nadu branch.
That's what we'll ask the Tamil Nadu branch. Communicate anything if anyone from here also, this is don't mind.
Let them find out. Let them find out, sir. Give them some
Okay,
time.
sir.
Give them some
Once they communicate, we'll include it, sir. Thank you, sir. Anything else, sir?
Sorry, any other? Yes.
Yeah, that will come.
No, it will come, sir. It will come in the any other matter still.
Yeah, it will come, sir.
It will.
Yeah,
Yes.
still to come.
Yes, sir. Please go ahead with any other matter.
So as for the South Zonal Tribunal, we are just adding the past president, immediate past president. The one president will take away, and the immediate past president who has served as awards committee chairman will join the tribunal. So as a matter of now, it will be Dr. Ramakrishnan sir, Dr. Ramana Neeraj sir, and Dr. Uday Kumar sir will be the tribunal committee of IPS South Zone. So that is one which we want to tell. Then the EC has been continuously discussing about to increase the membership drive. So in a view to that, certain criteria which we are being followed for the awards. So the EC opined that with the permission of the AGB, that it can be implemented even for pre-papers and posters which are being presented in the various with the conference of South Zone. The criteria would be the presenting author should be a member of IPS South Zonal Branch. 50% of co-authors should be members of IPS South Zonal Branch, and exemption may be given to multicentric studies, international authors, and non-psychiatrist authors like psychologists, social workers, statisticians, etc. So to apply these criteria even to free papers and posters, so that we can increase the membership drive of the zone. That's it. Sir. No, sir. Presenting author should be a member of IPS. Only the co-authors. Only to the co-author sections. Presenting author definitely a psychiatrist and member of South.
Okay, it is a good suggestion.
Yes, sir. The other thing which we have received from PSV and Sharma sir is, can we differential pricing of registration fee who want to attend banquets or without banquets only? Is it possible, but though they are not present in the bylaws? Can it be possible for the as per, sir? Yeah. No, sir. No, sir. It's not there anywhere in the.
In many of the other organizations, example, obstetrics and gynecology, etc., the dinners are very prestigious one, and they will be discussing with all the other speakers, international people and all, and they exclusively pay for that and come. For example, there are 3 dinners, they decide 5,000, 2,000, 3,000. I think it should be left to the organizing committee henceforth to see that the dinners can be. So what happens there? Only people who are interested, and there will be a more social exchange of views, etc. But here we have followed a philosophy that everyone who is registered for the conference are entitled to be in the dinner. Probably that will widen the network and more number of people can participate. I'll leave it to the hall.
And actually, when we start ANSIPs and all, in the beginning, there should be a separate banker charge, separate CME charge we need to pay. I think Dr. Mohanendra and Dr. Roy, they will all remember. Even to have a drink in the dinner, we'll have to pay. That is the situation. Now, somehow suddenly it has become in 90s and 2000, late 90s, things started changing. So I think we can go back to the old system of collecting banker charges and CME charges.
I thought I'll just add here, sir. As an organizer, I was really put to a doldrums here. I have 1,000 registrations here. Yesterday, my dinner was prepared. There are only 400 plus takers, sir. So there were more than 550 people's dinner. I've really wasted. Last moment at 11 o'clock, I've sent it to different hospitals and where I could do some sort of salvage. I think it's really going to affect the food management, and a lot of wastage is going to happen. So somebody, if is paid, I'm sure they will attend. Somebody, if you're giving us freebie, we really don't know how to calculate. So more than 60% of the food was unused yesterday. It really pains for me because I know it's a part of the organization that's paying for it, but I've never wasted food, sir. I think there has to be some sort of support from the bylaws or some sort of conference conduct guidelines, which will make sure somebody who pays really attends, and that will add value for the registration also, sir.
What Mahesh has said is very, very correct. At the same time, we should also encourage a balance, because banquets and these dinners encourage fellowship, especially for the young people. For example, if you go to WPA, you have to pay for every dinner. You have to pay 50 euros, 100 euros. And most people do not go because they're very expensive. So when we make the dinners paid, make it not very expensive. Make it in a view that you encourage people to join and make sure that. Thank you.
So my opinion is, we should not set such an example. I think we have come out of that and we are giving dinner to everyone. And as you said in the initial part, or we can at least we can ask whether you will be joining or not during the registration. But if we give us, if we charge for the dinner, 90% may not come. 90% may not come. Then there won't be any fellowship and friendship.
Hello, sir. Yeah, can I add something?
Yes, sir.
Same topic,
Yes.
sir? I'm Dr. Kesharov from Hyderabad. Actually, I raised this issue in our WhatsApp groups also. I wanted to bring this issue, but it has brought by someone else. And as Dr. Mahesh said, there's so much of wastage. Today, even this number will not be present. In national conference, second day, half the people won't be there. Third day, just empty chairs. In Hyderabad, I have seen in 5-star hotel, Taj Krishna, for one conference, 80% of the people were absent. There were plates, and it was very kind of, I felt very bad. So much food is wasted. And it may be pharma money. It may not be our money. But another thing is now, our numbers are increasing like anything. Previously, there were few members, and pharma used to pay. But now we got so many members, and thousands, and postgraduates, and they prepare for 4,000 people, and 1,000 people come. And by day 2, people want to see. Even if you go to a tour somewhere, that fellow will give a free day. Because people want to explore food in Hyderabad. That fellow wants to eat in Paradise Biryani. He is not interested in your 20, 40 item dinner. So we should put a nominal fees. Don't put a very high fees, but put a nominal fees so that those who want to come, they will take. And we can put it day-wise also.
Yeah.
Thank you, sir.
Sir, in this context, yes, sorry.
Sir, can I just add something? Why don't you think is in a middle formula? Say that only 500 dinners are available. First come 500 people, all others are not allowed.
No.
That is that kind of thing.
We got your point, sir.
I think we put a, say, nominal, say 200.
Sorry, sir, sorry. On the floor.
Sir.
No, sir. No, sir. Now that there is a clarification, we must put it day-wise also. No harm, sir. No harm, sir. See, once we are working, sir, we leave it to the organizing committee and say that day-wise, day 1 you want to attend, day 2 you want to attend. But as a consensus, we take it that it should be nominal, it should not be, the market rate, something like that. Like sir said, you need to encourage people. Yes, it can be a midline. So, yeah.
See, what I suggest is you reduce the registration fee. Because you have the registration fee at 6,000 and then again charge for the dinner. That doesn't look fair. That doesn't look fair. Because in the constitution it says it includes everything. So I think we should not go by that. I think let me suggest. Registration fee should be reduced. I mean, not drastically, at least. If you are collecting funds for the banquet, lessen that amount in the registration.
Okay, sir, that will be left over to the organizing committee, how much they are spending for the food also. That is also important. Suppose some of the cities, Bangalore, Hyderabad, they may be charged more. So in that case, we can give the leverage to the organizing committee. So they will deciding, okay, we can put it the cap like suppose a dinner 500 rupees. If they pay, let them pay. 500, they may not get it, but minimum they have to pay. Like that we can, sir, please.
Most of these paid by the companies, they pay and don't come. You will be ready for that. Registration and all this is paid by pharma companies.
Can I make a suggestion?
Somebody will pay, others will not pay, they will not come.
No, sir, those days are done, sir.
No.
May I make a suggestion that for first of all, there are usually 2 dinners, right? First day dinner and second day dinner. I would suggest that the committee the house can decide that you have only 1 dinner. The other dinner, they can go wherever they want and do what they want. So that is one. Second thing is, whether you have 2 dinners or 1 dinner, you charge a nominal amount of 500 rupees for each dinner. And I think 500 rupees will cover your dinner. It's not a large amount, and don't make it, don't leave it to the committee. You say that any dinner, wherever it is, 500 rupees is the charge for dinner. And if people are paying, that's the amount that they pay, and they come for the dinner.
Sir, one.
Logistics. Logistics.
See, now the discussion is going on like this, and then leave it to the next organizing committee. They will do it, keeping in mind what Dr. Mahesh has said.
Yes.
Because wasting of food should not happen. So actually, now only I felt it. 500 foods at the midnight is urging me not, which all institutions require the food, poor people. So those who want, please keep it in mind.
Sir,
the rest we can discuss whether it is 500 rupees or 600.
I'll take all these valuable inputs, sir.
At least keep in mind that those who register for dinner only, registration dinner will be supplied, so there won't be any waste.
I'll
At
take
least
all your
that
valuable input, sir, and I'll see that there won't be any food wastage. I'll see that, we will see that all my experience in this 20 years, sir, I'll see that Dr. Keshav Rao, sir, Joseph Varghese, all of you have given valuable inputs, and I will see that you pay the nominal and you get the best, and I will take care of, as Mahesh Gowda sir said, I'll be also ready. I'll see that if anything is left, we'll see that it goes on, it doesn't get wasted. Thank you, sir.
Give one suggestion.
Sir.
Just some money, whoever attends, return that money back to them.
Yeah.
Then they will come.
And that you announce before only.
Yes, sir.
No, that is different issue, sir. That is a different way. Different, sir. For PGCME, there is no charges.
I was there.
Yes. Nothing should be free, sir. Nothing should be free. Some nominal charges will be there. Some responsibility will be there, sir.
300 PGs, 500 came for dinner.
Sir, next.
The next item,
Sir,
with
When the conference is more than 2 days, we can have a day-wise registration, because some people want to come only one day. Private practitioners, particularly, that they can't stay away from. So why can't we have 1 day registration? It can be more than the average price.
Sir, we'll think over about this further. Yes. Okay.
No, you can.
There's a new problem in terms of CMA credit points also. Usually it is given as a package, so it becomes a little.
We can ask for day-wise points.
I don't think.
No, they can give, sir. What is the problem?
So one more. We have one more important. Sir.
Sir, suppose if you are going on something other, it will become more complex. It is difficult for the organizers to organize the conferences. Nobody come forward to organize, sir. That is also very important issue. So, sir, please.
Regarding CME points, because all the medical councils have made it compulsory that they have. For example, there is a person from Rajasthan has registered for our South Zone conference. He is telling you, make it hybrid. I am sitting here and listening to all your thing and give me the 6 points. So this is becoming another ethical issue. They are demanding. For example, I will just register somewhere in Tamil Nadu and I get 5 points because I am paying the money. That's what. So this has to, I am bringing it to your notice because somebody from Rajasthan has registered and requesting for that.
No, sir. Now I think we should not encourage that, sir. It is more difficult in the future, sir. Whoever the present for the entire CME or whatever it may be, you have to give the credit physical only. Otherwise, we should not encourage that.
That's the right thing.
Sir, we will.
More expensive as it is not correct, sir. Suppose he put on whatever the WhatsApp or suppose his website, and he will be doing something, so he'll get the credit hours. That is not fair, sir. I think it should not encourage that.
Sir, so if we close.
Sir, if anything is, sir,
definitely it will be taken care and worked out, sir. The other important thing what the EC wanted to put forward to the AGB is regarding the voting process actually. So till now, roughly we are conducting voting process for a period of 30 days. Nearly 30 days or 25 to 30 days based on the dates which we are planning our AGB. So can we cut down it to 10 days or 15 days is one? Because even the IPS National has cut down the voting process. Only rationale would be there will be a cut down of around 30 to 35% in the financial aspect only. Number of days, sir.
15 days may be better, I think so.
Yes, sir. And I mean, just putting forward, not directly we don't change it. Just, sir, we'll 30% will be. So it is around 60 to 60,000 we have. This year we have conducted 60,000, sir. 60. Sir, even the IPS National has decreased it to 15 days, having the number of votings, sir. Oh.
3 weeks.
Okay.
Sir.
The 15 days concept came probably based on the recommendation of our tribunal, because there was a controversy in the election process in the IPS national when Lakshmikant Reddy and Tofan Pati contested. And the process of election was, according to some important sources, there were some manipulations, attempted manipulations, I will say, and frequent phone calls, tapping of the phones, whether you have voted or not, that can be ascertained through this process of e-voting. Whether you have voted or not can be ascertained, can be confirmed. There is some loopholes in that e-voting process. That is why we thought we can cut down the voting period, 15 days. Okay. That is the concept of reducing from 30 days to 15 days. Reduces these manipulations, frequent phone calls, midnight OTPs. Several OTPs have been received by one person.
Yes.
So that can be avoided if you make 15 days. Okay. That is the idea behind cutting that from 30 days to 15 days.
I think.
There will be, if you give more time, they find out who is the person who is operating this e-voting system.
Yeah.
It comes to know. They come to know. They come to know who is operating this e-voting process. They are very clever. One day they can do, but if it is confidential, it is very difficult to come to know who is behind all this. That's the idea behind reducing it.
See, anyone can make allegations, because as Dr. Panudare had said, even we had done, I was part of the committee, Dr. Ravish also was part of the committee. We had scrutinized thoroughly the whole process of e-voting, and we couldn't find any manipulation. We checked the IP addresses, we checked the various other sources of this thing. There was absolutely no manipulation as far as the IT was concerned. The only thing is, we should have whoever is the vendor, we have to have their software, the basic programming. If that is there, we can always verify the process. Because generally, last year, what we couldn't do was, we didn't have the software, the source code. We have to have the source code. If we have the source code, we can always see the entire process of manipulation or anything if it's out there. So reducing the number of days is not going to affect the process. And if it all has to be done, there has to be an amendment.
Yeah, that is true, sir. But now once the AGP says that...
How is it that one person receiving several OTPs? Sir is saying there was no manipulation. There was an attempt by some people. We have recorded. Attempt was there. That is what I am saying. Attempt has been there. That you agree or not? Sir, attempt means suppose I am making a call to somebody, that is an interference in his personal domain. It is your right, your privilege to keep it confidential. How can I send message to you? That is wrong.
So getting OTP, I can explain what's happening. I have the details of the doctor in terms of membership number, phone numbers and email ID sometimes. So I put in this sort of details and try to vote. If the OTP goes through, that means he's not voted, I can actually call him back. If the OTP does not go through, it says that you already voted, they know that it's actually voted. So what they're repeatedly trying to do, I can employ my assistants and actually keep making this sort of attempts to get the data, even if you don't have the IT person's access. So you get 3 OTPs because they're actually trying to attempt to see who's not voted. So unless you filter out this sort of...
you come to know that he has not voted, then you will give a call
keep
and
calling
him.
them and asking.
Then you remind him.
Sir,
you
but
know
the current...
that he has not voted by sending several OTPs, then you remind him over phone.
Sir, but the current
It
software...
is a personal
which
violation of your rights.
Sir, but
That's
the current software which we have used, even if you have voted, we have received OTP. If we log in into it, it says that you have already voted. So there is no way that we can find out just receiving OTPs. Sir, so the other issue...
Sir, I support 15 days for simple reason. that I would rather be disturbed for 2 weeks rather than 1 month. So all this OTP trying will stop.
This is a better option.
So can you work out and come up with an amendment to the next AGB at least? And the other thing linked with this is delinking the election results from AGB, just to prepare the newly elected office bearers, give a 1 month time so that they can prepare the activities once they commit to the action. No.
Please listen to that point, sir.
Subject to ratification by the AGB.
So, no, sir. Sir, actually, AGB will be ratifying their results.
No. In this.
Sir, with due respects, this is what I had proposed in the EC. I have answers for all the queries. First thing, sir, what you said in terms of ratification, this is the exact reason I want that the result should be declared earlier. Let me come back to this issue, sir. If it is declared at least 30 days before the AGB, the new committee starts preparing for itself what activities it has to do and what committee members have to be included in their committee. Gives them time. One, sir. Two, if there is any problem with the results per se, the candidate has enough time to come back to the tribunal or the committee or the IPS South Zone to get it rectified. So in those 30 days, in fact I was suggesting 60 days, in those 30 days it will be set right so that AGB has all powers to ratify it. I am still holding it that it will be ratified only by the AGB, but at least the elected candidates know, especially two persons, sir. The incoming president, of course, and the honorary secretary. They have to prepare themselves for the next. No. This post, sir.
The income president will be always.
The problem would be, fellow who has some problem in an election, they can go to the court and stop this. So nothing can be done in the AGB. That post will be nulled. So be prepared for that.
Sir,
that can happen. But even a day early, if you announce, somebody can go to the court and stop the elections. Yes, this can be done. You can't stop it. So
Raju
this
sir,
has to be done in AGB.
Raju sir, but this can still be done and it has been done before
the
also.
status quo will be maintained. In court, always they maintain the status quo. The fellow is already been in the AGB, so he will be vice president, he will be the secretary. Otherwise, their elections will be null and void. So in the status quo, they will not be coming in. So all their efforts to be elected are lost.
Sir, but there are other associations which are doing it, sir.
No, that is their business, but here that
I fully agree with Dr. Raju. Even a municipal court in any city, I file a petition in Kottayam, and they can stay the declaration of the results, and you will be in great difficulty. So the same office bearers will have to continue for 1 more year. So it's a dangerous thing. Let us go by the same procedure.
Sir.
Okay.
Which is not there in the constitution.
In fact, I'm just telling you what happened at the national level also. Had there been time, I don't take the names, a lost candidate would have gone to the court and stopped it. What answer as a president and presiding of the IGP said, this has been accepted by the AGP, I can't do anything. Otherwise, at the national level, it would have been a big thing, which you have seen all that drama.
Sir.
Sir, regarding what you said regarding the formation of the committees, anyhow, the incoming president was already there, sir.
1 year.
So, 1 year. So, the elected member cannot, will not.
The other office also has to plan.
It is. They cannot take
Sir, President, sir. See, elected people cannot take charge before AGBM. So there is no use of doing that before. They have to take the charge only in the AGBM.
Charge is different. I agree with you. Unless it is ratified, it won't be.
No, sir. Even if you want to planning of activities also.
Okay, sir.
That's it.
Sir, will.
There is really nothing to plan.
Plan.
The incoming president can anyway plan because he is the vice president. It's the president who has to do the planning. So I don't think there is need to do it anything other than at the GB at the point of the GP.
Okay, sir, we'll take the second point as no, and regarding the duration of voting duration, we'll can consider it and come as an amendment in the next AGB. So, yes. So delinking is not accepted, and only the duration of election.
Election process only.
Voting process, voting duration. So next, wanted.
Sir. Anything else, sir?
Dr. Kishore,
Okay,
he wanted to just raise. Kishore.
Dr. Kishore.
Sir.
Yes. President, sir, the National Medical Commission has made a significant change in competency-based medical education in 2019, something which has happened across this nation. I think Dr. Smita is here. They have also made 2 certifiable skills mandatory at undergraduate level. I think we should compliment the commission, the apex body, which took the suggestion that there should be some certifiable skills for the upcoming doctors. So this is totally new arena. What has not happened is that how do we train psychiatry faculty in these areas? So I would recommend that every South Zone there should be workshop for the psychiatry teachers to be trained in competency-based medical education, and also how do we train them in the certifiable skills. So I would recommend at the zone and the state levels that it should be taken as priority. South Zone contributes maximum number of medical colleges, maximum number of postgraduates, and maximum number of undergraduates. So I would recommend that the body should take this seriously and take it.
Thank you.
In continuation of this, most of my colleagues from government colleges, they know, NMC conducts training programs so intensive, except for urinals and some coffee tea, they don't allow them to go out also. So we can certificate also. So we can write to our NMC chairman, our own person is there, to improve the skills among that category, because even the HOD of psychiatry department and faculty will be there, so that we can write to Dr. Gangadhar to see that how what all Dr. Kiran is telling can be included in the curriculum of NMC training program.
So when we discuss this issue, what is not being discussed is that in every medical college there is something called medical education unit, which gives training, and it is mandatory in basics in medical education technology. Okay. The problem is that the way of teaching psychiatry and its application differs grossly. So that's why when we discussed with Dr. B.N. Gangadhar, he said that there should be specific subject-related strategies in the competencies. Only a psychiatrist who has undergone the training in medical education has that ability to ensure that all psychiatrists are able to take that skills. And that's why I should thank the Indian Journal of Psychological Medicine, which put up the entire issue, what should be done. And it is happening at all levels, including the super specialty. So we should ensure that the subject expert should play a role, and if it can be done easily, there are so many IPS members who have been trained additionally, and in its zone, it can happen. So I would recommend that it should be considered seriously.
So, but competency-based medical education, it's a 3 days, very strict program, and they teach only general things, how to prepare a slide, how to take a lecture, how to make a tutorial. They don't talk about any individual topics.
Correct.
Be it medicine, surgery or OG, they don't go into the details. They talk only about the general things, and NMC has some designated centers also, like Jipmar and some Kottayam, there is one center.
That's why we
and
are
we
saying,
have to go to that place and get trained, or we can bring that to our medical colleges and get trained.
True.
But it's I think it's totally different. It's a general thing.
Yeah. That's why we are saying we should do it for psychiatry at the zonal level. We should ensure that the psychiatry teachers should have opportunity when they come for the conferences.
In addition to CBME?
No. In CBME, we are talking psychiatrists.
But CBME is generally done by some pathologist, community medicine person.
No. CBME is for everybody.
Everybody.
Every
But
speciality.
the instructors and the...
That's the thing.
Sir, I think we can.
Sir, I think what sir is talking is about, it should be left to the medical education system itself. Society need not enter there. Because it's a well-formed program is there by the NMC. Every medical college has medical education units independently now. They are governed and every student has to be trained and certified. Only if they have the certificate, they are allowing for examination also. I think we should be left. And second option is what you are telling is about the non-teaching people. If they want to have the skills, probably they can attend the program which are there in the medical colleges.
No, sir.
It's misunderstood. I'm saying that in every medical college, there is a medical education unit. They offer, there is a basics in medical education technology, which is 3 days course, mandatory for every specialty. From anatomy to surgery, they have to undergo. But I'm saying, Dr. B.N. Gangadhar said, and what we have been doing also, the competencies in psychiatry should be taught by the psychiatry fraternity to their colleagues in other institutions. That, if you keep it as 3 hours workshop in the South Zone conference, it is easy because all senior resident, assistant professors, they come to the conference. If you keep a workshop, the skill of the psychiatry teacher goes up, it improves the quality of the care, what the students provide. That is what we are suggesting.
How it will be helping?
No, sir. Sir, may I please clarify? Sir, what Dr.
Yeah.
Sir, there are 2 points here. One is the CBME, what is being offered as part of medical education unit, it is very generic.
Yes.
It is for all the subjects. Psychiatry is no more there except for stress management and all that. What Dr. Kishore is trying to say is depression and also that suicidal part. These are mandatory criteria now. We cannot say no to that. So what he is proposing is as part of IPS South Zone, we should have a dedicated somewhere, some program where our teachers can be trained, something like that.
Yes.
So that's what he is trying to say.
Yeah.
Workshop or this, that is easy to be incorporated. If it, yes.
Yeah.
Do you mean to say that many of our faculties would have gone this training competency-based medical education in their own medical colleges? Do you mean they can be incorporated, they can be drafted in for such a program, in for psychiatry especially?
Yes.
That's what you are saying.
Yes.
I got the point. I think that is a valid point which can be taken up. You can send a proposal and
proposals,
then
we'll take the
EC
opinions
can
of everybody
consider.
and we'll be seeing. We send the proposal.
I propose that instead of having it at the conference is already very crowded. Why don't you do it as part of the midterm CME? Midterm CME time, you plan it. Because conference, there are so many things is crowded. And you are not able to accommodate many people. This special training, because private practitioners won't be interested in that. So for the CME, you plan it that you have this competency-based training in psychiatry.
You can add. Sir, now before conference as a pre-conference activity, we started 2 yesterday. One from thesis to the publication, another on forensic psychiatry. We saw the attendance. We expected with great difficulty we could enroll 79, 80 and half of them attended. No. With coaxing for several times, 79, half attended. So what then came? This can be a pre-conference activity. We did it. Parallel already full, sir. Halls are full. What we are telling. So conference time, let's take any other thing. We can take it as a, somebody can propose because several programs are going on. Somebody can give like that.
Sir, I respected President, sir, and the August General Body. As I said, the action begins here. Since I am the bridge between the South Zone and the National Executive Committee, I want to bring up an important issue that happened in yesterday's inauguration. It's not in the protocol of Indian Psychiatry Society, South Zone, that a person from national office bearer comes and openly tells in front of my health minister, disgracing all the seniors who have been working at the international level as teachers, as office bearers, in a national importance institute, which has been organized by not one person, but the terminology, the words used was against one person. This is a combined effort of Indian Psychiatry Society, Karnataka chapter, Department of Psychiatry, NIMANS. What the person spoke was really uncalled, immature, disgraceful to my all seniors, and hurting all the sentiments of each member from all the state of South Zone. I want this august body to take some action. If not, allow me to take legal steps. It was intimidating. You can live without me, I can live without you. This is totally unconstitutional, drawing a barrier between north and south. I think these things has to be kept personal. Talking in front of such a huge dignitaries, I think this is totally protestable thing, and South Zone having such a highly recognized seniors, I pray that you take some decision or give me permission. I would take suitable action against such persons.
Just a sec, sir, if you don't mind. I'll just clarify a sort of background. No. As a protocol, we sent mail to the office to attend the conference. In the protocol, it's nowhere mentioned that we need to take care of the flight, stay, where to stay, and all that. There is nothing. We have sent our invitation, we have proof for that. He coming and talking of this nature is really not appreciated. Because there is nothing from our side which we have acted against the books. We have extended courtesy. We have gone to the extent of calling him on the stage, asking him to speak, and we also have accommodated the editor of IPS, got them released one newsletter and one IJPM journal also, and we accommodated the speech of the IPS president online also. So from our end, why I am trying to specify is there has been no lapse from this office when I was the president towards the office of the national IPS. This I am clarifying very clearly. So once that is understood by all the members, because unfortunately, this is really unfortunate, that the health minister is asking me, what is this politics? You have politics here also. So why I am telling you people is, today also even people are asking me from my zone only, what is the problem? So I am clarifying my stand and I allow the house to discuss further. You had a mic, sir, with you.
Why do people keep squabbling? These are the same words he said before getting into his car. Now, the most appropriate thing I personally feel is pass a resolution against that in this August House, and it should be sent to the President and published in all the other forums which are there. So many WhatsApp groups are there. He has been condemned, and his resolution has been passed by the South Zone August body and the AGM. That will be the most befitting reply to the person who was not supposed to speak what is not required.
Sir, one thing, sir. Instead of sending WhatsApp, that is not correct procedure, what I feel, sir. We'll send a letter, sir. Condemning letter we can send to the state. Putting in WhatsApp is...
No, with due respect, sir, this whole issue came up through WhatsApp, which was accepted to be a official thing. I don't know the background. But if this is the way it is to be considered, the WhatsApp group, if it is considered official, that also can be made use of. Now the problem is, sir, unless it is stuck to them correctly through the public forum, they will not appreciate the problem. Any mail sent to them, they either keep it like that, or they will have no action because they don't have to. There is only access to only 3-4 people to that.
No,
They will not even discuss in the
it is
other forum.
It is an important issue. Even many of us who are sitting in the front row, we were carefully watching that. But my one doubt is, have you recorded his speech?
It has
Have
been
you got the
recorded.
recorded
Sir.
speech?
It has been recorded.
If it is there, it is very important. Because, yeah.
Sir, Mr. President, sir, since it was a public forum, because inauguration was not only for the IPS life fellows like this AGB, there were pharma members who were invited to come and fill the hall because the health minister of the state was coming. Public, yes. So since it is a public forum, it has to be named and shamed. Because my South Zone getting this kind of political statement, he has told political statement which is anti-national and organization, whatever. I can't stoop down to that fellow. Yeah.
President, sir.
Okay, is it resolution, sir?
I appreciate the sentiments, especially Ravish's. I know everybody is upset about it. I was also thinking yesterday that what the person, an office bearer, said yesterday in a public forum was inappropriate. We are still a body which is part of IPS, right? So if you do whatever you're planning to do now, again it should not become a north-south divide. We don't want that because we are part of the IPS body. Now, in my mind, one minute, let me finish. In my mind, the appropriate thing to do is we express our displeasure saying that it is inappropriate, and we send a formal letter to the IPS central body saying that it is inappropriate and we would like this to be mentioned in the annual general body next year as an inappropriate statement, so the whole general body will know that an inappropriate statement has been made. Don't put it on WhatsApp, don't put it on social media. It is an inappropriate statement which requires addressal by the main IPS body, and if at all anybody has to chastise the office bearer, it is to be the IPS body that is chastised. It is none of us. It is not to be taken to the court. It is nothing to be taken to the court, sir. Dr. Ravish, I know you are upset. It is not a matter to be taken to the court. Wait, please let me finish.
No, sir.
What I'm saying is, please.
It is to the integrity of my nation.
Let me finish, sir.
No, sir. This
Sir.
is the way
Sir.
the youngsters have been gagged.
Sir.
I am a
Sir. In
psychiatrist.
Politicians say so many things.
But he has
Everybody
made
is
a
not-
political statement.
Everybody
He has
is not-
made a political statement.
We are not talking politics here. Please be reasonable and rational.
Sir, I think, no. These are the ways we have been snubbed and we have been suppressed. Let us have the courage to stand up united. We are united as citizens of India, that's all. See, in a federal state, we can't get scared. No, sir.
1 minute. Wait.
I'm sorry, I get sentiment because I wear everything. Yeah, sorry. I'm sorry. I apologize, sir. Right from here, I apologize.
Dr. Matthew,
Sir,
what
sorry.
you said was right. But what happened in the last conference? Sir.
Matthew, sir, please complete it, sir.
Matthew.
Sir, please, sir.
I just want to tell in continuation of what Dr. Matthew said. You can see, only thing what happened last time, I know, that's why I'm giving the thing background and giving it to him. Last time what happened, when they realized that there was a certain things against what's happening in the association, they brought one section of people without allowing anybody, the greatest injustice done by any president of Indian Psychiatric Society at a national level was nothing but last time what was a sham AGB where shouted, he made everybody to shut down. I was the only fellow has to shout, and ultimately they all said yes. So same thing, if I send all the letter and also to be discussed, some 300 people will be sitting, the president will tell, thank you very much, what they are telling is right. So what I am trying to tell is, what you said was most socially or culturally acceptable modesty. There was no modesty in the last conference. If anybody has attended the AGB of IPS, there was no modesty.
They wanted to come in black dress. They wanted to protest as if they are content. It's not a national AGB. It was a West Zone AGB. It was a West Zone AGB. So it was very insulting. So we have to stand up somewhere to see that this cannot happen. Because that's the only reason President did not have the face to come to conference, though invitation was sent. So we should all, those who have attended AGB last year, please raise your hands and touch your conscience. You know how it was protested, how they did, shouted, black dress, well planned. And it was the most shameful thing. That's why. So even if we tell that condemn, the same thing will repeat. But if a resolution is passed, sent and published, I think people will realize this is not the way we should conduct ourselves. We are not against the institution, it is against only the individual.
Whatever all of you are saying about being secular, being divisive, is what we are doing now. This is our body. Wait. This is our body. We don't want an India-Pakistan war in our body. So the right thing to do, constitutionally, is to send a resolution to the next general body meeting. You send a protest letter to the president and say this is not correct. And you send a resolution to the next general body meeting of the ANSIP saying that you would like this resolution read. If you send a resolution, they cannot refuse for the resolution to be read. And it will be minuted. It will be there in the minutes. So that is the right way to do it. Already, all of you know, whatever has happened in one WhatsApp message, everything has been blown up. So, do you want to continue that war? It is like the Palestine-Israel war. Is that what you want? Remember, this is part of the same body. We are a subsidiary of the Indian Psychiatric Society.
Sir, I would like to add here, sir, for all technical reasons, we keep saying that we are under the national body. Currently, for all purposes, we are an individual registered body. We have our own PAN, TAN and all those things. We have our own constitution. We have our own AGP to decide things. We should not always keep thinking that we are under national body. We don't have to think that way, sir. We are an individual organization right now. If you didn't have an individual recognition right now, unless the IPS national has every year annual MOU with our zone or the state, we are not under national body for technical purpose or legal purposes, sir. We don't have to keep always subduing ourselves to say that national body can decide better. Whatever communication you send can be easily subdued, not discussed. Yes, if it's resolution, yes, there are a lot of people who can gang up and say raise hands. Even now we can do that and raise hands and say we want to do this sort of thing. It's not always right to think that we have to be always diplomatic, always nice, and keep always trying to say that we don't have to have a war or a protest. If it is right, we must protest. It's our right, sir.
I'm Dr. Kesharao, Hyderabad. We had this big argument 4 years ago when I was Telangana president. But of course, we are all part of IPS, so the fight was given up at the last minute. So see, the main issue here is we pass a resolution, but that resolution, can we post it in WhatsApp groups? Because it is passed among all of us. So I can just simply this. No, I will post, sir. I will post in my group. Nobody stops me. Because you have passed a resolution, I know what resolution is passed, so I will simply post in the group. The other thing is, I would like to post the full text of the speech. People should know what he has spoken. And people cannot speak all rubbish and claim that they have spoken right, and the South people have, whatever people here have passed this thing unnecessary. So everybody should know that people all over the people don't appreciate what he has said. I did not know the politics. I was surprised. What is this fellow talking? A stupid fellow. And I did not bother that there was real politics behind it. But I think some action need to be taken.
The same recording can be absolutely edited. Link should be given and the link should send to everybody. This is what's happening at national level. More than enough. I think. Okay, sir. No reason.
See, it is such a sensational issue. Yes. There is no doubt in it. At least can you have a chance, at least his AGP can listen to it? At least the important part, 1 or 2 minutes. Because he is a national office bearer. It should not be left like that. That is my...
Okay.
Mr. President.
No. See, there is always a legal remedy. That's a different matter. But let me also express, sir, I'm again sorry because you are elder person, and when we are corrected, we will correct. That is the biggest heart of this land. Number one. Second thing is, he can be impeached. Why not he can be impeached? Let that be the resolution. We are having enough number. We can mobilize. What he has done is not just to South Zone, he has done to many people. He has a track record of that thing. He has a track record. I'm sure many junior members have been arrested. Are we getting a party being silently doing it so-called diplomatic way? No, I think some action has to be taken. That is my pray.
Mr. President, I think just because he acted inappropriately, we should not also act inappropriately. What we should do is that the South Zone President should write a polite letter to the National President with copy to Vice President and if possible to all the Executive Council members, saying that this particular person has spoken like this in the meeting, which was very inappropriate and it has hurt the feelings of the South Zone members. And it we had to cut a sorry figure in front of the minister who was also present in that meeting. And we request that this type of behavior should not be repeated again. So regarding the speech, if some people raise this question regarding what he spoke, then the recording can be put it in the public, no problem. Because otherwise people will not understand why we are protesting. But go in a very polite way. Don't try to, just because he is acting in a funny way, in a very inappropriate, indecent way, we should not lower ourselves to his level. We should maintain our dignity and our level in his response to his inappropriate behavior.
And about the protocols, about calling national office bearers, making them sit on dais is all unsaid thing. We have no obligation put in bylaws, conference conduct and thing. It is just an obligation that people expect, and I think we should de-link all those things. One organization having these sort of invitations, if it is not mentioned, it is just an obligation, sir. Nothing is bound on the organizing committee also to follow. Dr. Abhay Matkar has invited him, but there's no reference for this invitation. Why he should be invited, why he should be on the stage, why he should be allowed to speak also is not mentioned anywhere.
I fully agree with Mahesh. I was Secretary General for 4 years, 2002 to 2006. Many zonal meetings, I just sat on the front row. Nobody ever, they were just mentioned the Honorary General Secretary is there. Otherwise, the privilege given was our courtesy, South Zone's courtesy. The National President was also on the, I also agree with all of you that it was too much inappropriate, extremely inappropriate for him to have made this. But I agree with Joseph Varghese, let us not be lower ourselves to his level. South Zone has been always leaders of Indian Psychiatric Society, has been showing the path. So let us be mature in our approach. And the President should write, with this AGB should pass a resolution, and the President should write to the National Presidents and say that this matter should be placed in the agenda of the AGB. Once you make that request, it has to be in the agenda. So then let us see what is going to happen there. Thank you.
Yes. The president need not write as a president. You also better you say that it's a reflection of the AGB. It was discussed in AGB and it was resolved to represent.
Yes, sir. Yes, sir. We tomorrow. Okay.
So we cannot be polite. We can ask us apology. We can write a letter and ask an apology from him. We can demand an apology from him.
Apology will end the issue, sir.
Let him apologize. Let him apologize. Let him apologize. Letter with the resolution.
Once you insist that it has to go to the AGB, automatically he will come down. In the AGB, we will mobilize our people and then we will raise the issue. We got strong support in the AGB also.
Sir, incidentally, yesterday, due respects to sir, yesterday only he said, I am ready to cry, I am ready to apologize and all those. Sir, this was a managed show. For whatever respect I had for the post, that is lost. But that is something which we have to put it on record, one. Two, it has to be reaching more number of people. That should be our aim. So I request the President to take it up tomorrow's first EC and formulate a plan. Let the House allow them to do
Yes.
it.
Yes, sir. Yes, sir. Resolution will. Yes, sir.
Sir President, sir, one issue.
And sir, Ramesh sir, as a member of EC can take up the issue in the EC also, isn't it?
Yeah.
Is there an option now?
Yes.
No, sir. In the national EC, you can take up the issue now. You can, as a member representing the South Zone, say that our sentiments has to be met. This was anti-national, and whatever you said, sir, I am an emotional person like you. 100% with you, sir. I am with you. I am with you. I tried my level best to keep quiet, but unfortunately, sir, sorry. I can't. You should, sir.
Sir.
I see your post and I already know, sir.
Sir,
I am also emotional. 100%
President,
with you, sir.
Sir,
So the
President,
next TV
sir.
we are gonna run. Thank you, sir.
I would like to bring to the notice of this AGB. So one more situation where IPS South Zone was put at a what to say, discriminated level, embarrassed level. In the AGB, in the EC meeting of the national IPS, it was publicly, I mean, in the EC, the President has declared that IPS South Zone is the only zone which has not intimated their annual conference dates. But in true, we have intimated the IPS South Zone office well in advance, even before the other zones have intimated their the dates of annual conference. And even in spite of being reminded by our representatives who are there in the zone, and he was passed it saying that it was not personally sent to me. So I don't know whether it is clearly written in the AGB minutes. I need confirmation from there. If it is really written in their EC minutes, then this will be another issue which we need to beat. Yeah, yes, sir. Sir, the office is informed well in advance before the West Zone. Yes.
Sir,
this is one
incidentally,
incident which,
sir, incidentally, we are the first to inform our conference.
No.
No, sir.
This was the comment
AGS,
passed
sir.
by the President in the EC.
Sir, it is publicly announced by the President of IPS that all communication should go to the personal mails only, not to the official mails. It is publicly announced by the President of IPS that only all official communication should go to their personal mails, not even if you see the IPS website, they have removed the official email and put the personal email address of the secretary. This is unfortunate. We have fought, but unfortunately sometimes ours is only a personal single voices. Has been happening. There has been a long discussion on that and sad state of affairs.
The organization is not responsible to answerable is not answerable to a person. Any communication has to be sent to the office, not to anybody's personal mail, because his insistence on that is absolutely unconstitutional. He cannot do that, and we should not do that. We should not.
Actually, sir, IPS national body is there, but no zone is under them.
Yes.
For all purposes. Yes. In the constitution and bylaws, you carefully go through it. There is no word that we should furnish all the informations to them. We are not at all subject to that. There is two representatives we send to the national IPS EC. That's all. They coordinate with all the informations. There is no provision, there is no compulsion or provision or direction from the national IPS to send all these informations to them. We are not under the administrative control. It is only a formal courtesy call and courtesy that we invite them for our functions. That also need not be done. And financially also we are independent. It is a separate registered body. Officially and legally. Mind that word legally. Legally we are a registered body, separate. Not coming under the IPS Registration Act.
Okay, sir. Yes, sir.
I think we'll close this matter.
Yes, sir.
We entrust the President to do the whatever is necessary.
Sir, whatever the necessary resolution will prepare
Resolution we have passed. We have passed a resolution.
Okay, sir.
Right there. Content is you apply.
Okay, sir. We
have passed a resolution.
Okay.
Unanimously, we have passed a resolution.
Okay, sir. Thank you, sir. I think everything is done. Thank you for attending this conference.
No, I think
AGB.
two things. We should thank the previous office bearers. Then we should thank the organizing committee.
Yes, sir.
So do these two things we have to do.
Okay, sir.
I also would like to place on record the organizing committee led by Jagdish and Mahesh Gowda for the excellent conference and the wonderful arrangements and the beautiful venue. Congratulations.
Yes. Sir, anybody want to respond on this? About organizing the...
Yeah, please get that back. If the AGB is over, I have a personal job.
No, we'll pass the resolution.
Yes, sir.
We'll
Pass,
request
no?
then. No, we'll ask.
Sir, anybody is not signed, please sign it.
Yeah.
So as a matter of formality, I just announced that resolution is passed by the AGB condemning the IPS Honorary General Secretary's speech during the inauguration of IPSOCON 2024. I request the members to raise that. Pass. Yes, sir. And it
should be condemned. Condemned.
Yes, sir.
Thank you. I have a pleasant task in felicitating few of the members with whom I have worked. Please be here for some time.
So on record, it is on record. Everybody is unanimously.
It's not for all. Those who work with me, those who will work with me can see later. Those who work with me. Thank you so much. Hey, you were sitting, I asked you to come here.
No, you were felicitating me. I thought I should not help you.
Not for you, John. Sir, I didn't do 6, sir. That's why you're not here. It's coming also, you can see. Just see the count.
Sir, I'll give it, sir, no problem.
Organizing committee.
Sir, I'll give it, sir, no problem. You can do it.
This is for Jagdish. Jagdish. Hey, buddy. And the other three is for you.
The organizing committee organized the IPSOCON 24. It is excellently, and it is okay, sir. Excellently organized conference. For that, immediate past president felicitated the secretary and chairman. Thank you, sir. Thank.
No, you have to please accept your apologies, sir. No, sir. Thank you, sir. Thank you very much, sir. Thank you so much, sir.
Thank you, sir. Thank you, sir. Sir, please rise for the national anthem, sir.
Yes, sir. Uday garu.
Sir, what a thank you.
Uday, sir. Uday, you also work with me. Yes. Or I work with you. Please come.
Okay, sir. Sir, please. Sir, please raise for the national anthem, sir.
National anthem, please.
National anthem. Sir, national anthem. Yes, sir. Start, sir. Jana Gana Mana Adina. Yes, please. Okay, you want to play.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, Jai.
Photo of the photo.
Thank you, sir. Thank you, sir. Thank you, sir. Thank you, sir.
Sir, let me also film.
Thank you.
Some this side, please. Arun, please come. Pawan. Sir.
Okay, say cheese. Heated discussion and good resolution. Three cheers to South Zone.
Sir, come.